Live now, right?
We are live now.
Right. So we welcome everyone to the Periocular Aesthetic session by the APSOPRS. And the program directors for this session are Dr. Kasturi Bhattacharjee and Dr. Milind Naik. And along with that, we have the panelists, Dr. Adit Gupta, Dr. Preeti Uday, and Dr. Ananya Abhyankar. So now we'll hand it over to Dr. Ananya just to introduce Dr. Kasturi and for the session to begin.
Thank you, Dr. Rituja. I would like to welcome all speakers here and introduce the dignitaries one by one. We have Dr. Andre Borba with us. He has a fellowship-trained oculoplastic surgeon from UCLA Jules Stein Eye Institute and has earned his PhD in medical sciences from the Sao Paulo University. He's an oculoplastic surgeon specializing in eyelid surgery, periocular root rejuvenation, and regenerative procedures. He's on the scientific committee of Brazil. He's also the host president of the APSOPRS Congress that is happening in 2026. His interests are in functional, aesthetic, and regenerative oculoplastic surgery. Welcome, Dr. Andre. We also have with us today Dr. Hamza Mastak, who's a consultant ophthalmologist specializing in ocular oncology and oculoplastics and orbital surgery at the Groote Schuur Hospital. He has done his medical training from the University of Cape Town and fellow of the College of Ophthalmologists of South Africa. He is oculoplastic trained from UCLA as well. He is the president of South African Society of Oculoplastic Surgery and the African Society of Ophthalmic Plastic and Reconstructive Surgery. He has over 37 indexed articles and 4 book chapters to his name and is interested in ocular oncology, eyelid and orbital disorders, and reconstructive surgery. Welcome, Dr. Mastak.
Thank you.
We also have with us today Dr. Scott Goldstein, who is an oculofacial plastic surgeon from Philadelphia, USA, currently working at the Tri-Century Eye Care Center. He is also a clinical professor of ophthalmology at the Shy Eye Institute, University of Pennsylvania. He's the financial director for American Society of Ophthalmoplastic and Reconstructive Surgeons, past president at AAO, and Pennsylvania counselor to American Academy of Ophthalmology. We welcome you, Dr. Scott. We also have with us today Dr. Tanuj Nakra, who's a triple board certified facial cosmetic and oculoplastic surgeon, has done his education from University of Washington and UCLA. And in 2008, he moved to Austin to join the Texas Oculoplastic Center, Eye and Face, and is the program director for AACS Facial Cosmetic Surgery Fellowships. He's also the preceptor for ASOPRS Oculofacial Plastic Surgery Fellowship at the TOC Center. He has over 60 publications and is an executive committee member to the American Board of Facial and Cosmetic Surgery and also a board member of Cosmetic Surgery Foundation. He's also a co-founder of Avya, a skincare line that blends advanced science with Ayurvedic medicine. On the panel today, we have Dr. Milind Naik, who's a consultant oculoplastic at LVPI Hyderabad. He is also on the editorial board member of Orbit and vice president of APSOPRS. Dr. Kasturi Bhattacharjee, who is currently the director of Sri Shankar Deva Netralaya Oculoplasty Services and also the president of APSOPRS. Dr. Adit Gupta, consultant at Mumbai Eye Plastic Surgery, also trained at LVPI and UCLA, is on the panel with us today. We have Dr. Preeti Uday, who's the medical director and head of oculoplastics at DRR Eye Care and at Agarwal Group of Hospitals. And myself, Dr. Ananya. Thank you for patiently listening to all the introductions. I would like to hand over to our speakers and Dr. Kasturi for her few words.
So good evening, everyone, and a very good morning to Dr. Tanuj, Dr. Scott, Dr. Andre, and good afternoon, Dr. Hamza. On behalf of the All India Ophthalmological Society and the APSOPRS, It is my great pleasure to welcome all of you to this exciting webinar on periocular aesthetics, organized as a part of the AIOS IOC academic series. Over the last decade, we have witnessed remarkable advances in both surgical and non-surgical rejuvenation techniques, transforming the way we approach aesthetics around the eyes. Today's sessions bring together an outstanding international faculty who are the leaders, the innovators, and pioneers in this field. We are privileged to have experts who will share their insights on a diverse range of topics, from the broadleaf to the regenerative blepharoplasty to the management of the malar festune and the evolving roles of toxins and the facial rejuvenation. These presentations promise to provide not only the practical surgical pearls, but also a glimpse into the future of aesthetic oculoplastic practice. I would like to extend my sincere gratitude to all the distinguished faculty members for taking the time to share their expertise and experience with us. And also, I would like to thank all the participants and all delegates joining us today. And I encourage each participant to engage actively, ask questions to the learned faculties, and take advantage of this unique opportunity to learn from some of the best minds in periocular aesthetics. Once again, I welcome all of you to this APSOPRS AIOS webinar today, and I look forward to a stimulating, educational, and thought-provoking session. Thank you very much, and over to you, Dr. Milind. Milind, you're muted.
Yeah, sorry. Hi. So let's get started, Ananya. So we'll start with the first talk by Tanuj Nagra on brow lift pearls. Tanuj, you can share your presentation. So Sumer, you can keep the timer and let us know.
Well, I really appreciate the kind introduction and the opportunity to join all of you virtually. I am reporting from Austin, Texas in the United States, and this is the home of Formula One in Austin and Austin City Limits Music Festival. Many of you have actually visited us here in Austin, so it's always wonderful to see you. I'll be speaking about brow lifting today. It's one of my favorite topics, and anybody who performs periocular aesthetics should understand the value that the framework of the forehead and the eyebrow region as it impacts the eye area. Brow lifting is a critical component of improving periocular aesthetics, without which we sometimes cannot really see the benefits of blepharoplasty. So over the course of the next 10 minutes or so, I will try to get through numerous topics in brow lifting. This is a lot to cover in 10 minutes, so I'll speak clearly but quickly, and we'll try to achieve a lot of information exchange over the next 10 minutes. And we're going to start by talking about symmetry as it relates to brow lifting. As we all know, there are asymmetries in all of us, relating to the bony structure around the eyes, and oftentimes the low side of the face the low side of the brow corresponds to the small side of the face. The low side oftentimes is associated with ptosis, maybe a bit more anophthalmos on the side that's smaller, and it's important to recognize these asymmetries pointed out to the patient in advance so that not only can we improve the asymmetry in surgery, but also it's important to explain to patients beforehand their asymmetries. Many people just don't see it, and you have to point it out in advance, because what you tell them in advance is an explanation, and anything you tell them afterwards is considered an excuse. So we'll spend time looking at the asymmetries during the preoperative session. And this is a patient literally just moments before we take her back to the operating room. And we're making decisions about how to design the vectors of the lift. And not only are there medial considerations, but also lateral considerations. Medially, we'll be working with corrugator muscles as well as vectors of fixation, as well as laterally release of the temporal region and vectors of fixation. And so customized vector design is something that is really needed for every brow lift that we perform. This is the planning stage of an endoscopic brow lift, and I mark my vectors with arrows and also the amplitude of the lift that I intend to place on the forehead with internal sutures with the thickness of the markings in the preoperative area, so that when I'm actually performing the surgery, I can translate my preoperative ideas into surgical decision making. And here's an example: someone who has a smaller right side of her face, lower right brow, and without this symmetry enhancement, the upper blepharoplasty simply would just not be visible or as beautiful as it is here in this before and after montage. And we'll translate this vector design to the actual incision designs in the operating room. And then it's also very important to achieve a complete release during endoscopic brow lifting, similar to if you wanted to move a sofa in a room with a hardwood floor, you can pull on the carpet and the entire sofa will move. Very similarly, if we can get underneath the periosteum all the way down to the supraorbital attachments, then we can lift the eyebrow using endoscopic approaches. It's important to release the ligamentous anchors of the scalp. And for a brow lift, that is mostly lateral attachments along the temporal crest or the fusion line of the deep temporalis fascia, the superficial fascia, and the periosteum at the temporal line. And then we dive below the facial nerve, beneath deep to the intermediate fat pad, also known as the Aspergill's fat pad. If we're below that fat pad, we will always be safe in relationship to the frontal branch of the facial nerve. And then, in addition to releasing the temporal attachments, we'll also work on releasing the lateral orbital retaining ligaments to be able to achieve lift and temporal elevation. Here's a coronal brow lift demonstrating that fusion line of the deep temporalis fascia and the relationships to the temporalis muscle and diving underneath the intermediate fat pad, the yellowish fat that we see here laterally. And now we'll take an endoscopic view of brow lifting, and we'll perform a temporal elliptical incision to allow for vertical passive elevation at the end of the surgery during temporal fixation. And this incision is made with a 15 blade. We'll take the tissue off the superficial fascia and use bipolar cautery as needed to take care of any branches of the superficial vessels, including the temporal artery. We'll spread through the superficial fascia until we reach the deep temporalis fascia, and then we'll convert to a dissection with elevators to release superior to the dissection and release the superior aspects of the temporal fusion line. Then we'll switch to endoscopic view, and we'll take this dissection inferiorly along the deep temporalis fascia, releasing the medial attachments, the lateral attachments, and getting a complete release of the fascial attachments, taking care to spend extra time in releasing the conjoint tendon, the temporal fusion line, from the lateral side. And now we can just barely begin to see the fat layer of the intermediate fat pad, and we're going to take the time to dive deep to that fat pad. Heading inferiorly, we're dissecting under that fat pad. Oftentimes, this dissection will reveal sensory branches of the zygomaticotemporal nerves. Sometimes we'll see venous flow through this region, and we'll try to avoid those both venous connectors from the deep to superficial region, as well as the sensory nerves, to avoid any sensory loss post-surgically. And then we'll release the periosteum beyond the orbital rim, starting laterally, and then extending further inferior along the lateral orbital rim. These are the attachment releases that are required to get a complete temporal elevation release. We'll extend this dissection down onto the zygomatic arch. Here's the medial zygomatic arch past the temporalis fossa, and then we'll back cut the superficial fascia laterally to allow for further release. Now we can start to see that sensory branch there laterally that will preserve in this dissection. We can use a vertical scissor spreading maneuver to release further to allow for additional release. And we'll extend past the lateral canthus. And I'm going to jump ahead here so we can make sure we cover all the ground we need to in this particular series. But we'll complete the medial release with using the dissector past the orbital rim and release the periosteum off the nerve using spreading maneuvers with a scissor. We'll dissect under the intermediate fat pad as one of the key points that is a take-home lesson from understanding how to perform endoscopic or direct temporal lifting. We'll release the periosteum beyond the orbital rim to be able to get the benefit of full periosteal elevation of the entire forehead. We'll extend the dissection onto the zygoma, which allows us to access the lateral orbital retaining ligament and get a full release. And we'll oftentimes work very hard to get periosteum released from the nerve to achieve a full medial release as well. The ultimate goal is to get a complete release across the entire soft tissue structure of the upper face, so that when we have this complete release, we can perform temporal fixation and elevation effectively with a single suture point out in the lateral orbital rim. I like to use the Trepsat dissector. This is a dissector that allows for spreading of the soft tissues off the deep bone structure, and any of the sensory or motor facial branches can tolerate stretch. And so this is an important tool in getting a complete release. Sometimes we'll strip the corrugator. I'll use a nerve hook to separate out the corrugator from supratrochlear and supraorbital nerves. And then we can use a baby Takahashi to grasp the belly of the muscle. And this is performed in select cases to achieve additional medial elevation, such as this patient here who had a specific desire for forehead lifting with special attention to the medial region achieved by corrugator stripping. Volume augmentation is an important tool with periocular rejuvenation. We lose volume in the orbital fat pads and the subcutaneous structures as we age. Augmenting brow lifting with fat grafting, with autologous harvest from the abdomen or the medial knees, can achieve three-dimensional volumization of the periorbital complex in conjunction with brow lifting surgery. And many times the brow lift is performed 50% by tractional elevation from above and 50% by volumization and anterior expansion of the three-dimensional compartments of the brow fat pads with fat transfer. I like to perform fixation of my brow lifting using bone tunnels. Bone tunnels allow for infinite customization of the access point and the fixation point. Sometimes when people have a low temporalis muscle, we can perform an additional bone tunnel laterally. And there's never a question about whether the fixation point is going to last during the healing process, because you have absolute fixation of what I like to use a 2-0 PDS suture to either 2 or 3-0 PDS suture attached to the galea and the frontalis to elevate the flap up to the bone tunnel. And this is a tapered needle, which avoids tearing the tissues as we're anchoring in place, and this allows for vertical fixation. Just another view of this bone tunnel. This is a 1.5 millimeter drill bit. We have 1 centimeter of thickness of the frontal bone to work with here, with diploic space sandwiched between the two cortical faces. And so there's plenty of room to be able to perform this bone tunnel within the outer table of the bone.
Dr. Tanuj, we are short of, we're slightly overshooting time.
Okay. Well, I will go ahead and conclude there. There's a lot of information to cover in 10 minutes, but we were able to get through the endoscopic brow portion of the talk, and I'm happy to answer questions when the time's right. Thank you very much.
Dr. Milind, shall we take any questions right now?
Yeah, I think in the interest of time, and also the fact that Tanuj is awake early in the morning, if there are any questions for him, we should take them up right now. We can check if there are any online questions.
Dr. Tanuja, I had a question. Usually what we see is a temporal brow droop or a temporal brow ptosis. When you're doing endoscopic brow lift, how do you treat that differentially, a full lift versus a temporal lift?
Yes, so most of the problems that occur aesthetically and functionally with brow descent is in the lateral aspect of the brow. So as I was demonstrating in the talk, paying particular attention to temporal release of the temporal fusion line and the lateral attachments allows for the best quality lift. The vector of lift should not just be vertically upwards, but sometimes medially slightly to be able to get rotation of the brow. It is possible to get lateral brow lifting without doing an endoscopic approach. I suppose we'll have to have another lecture for that topic, but certainly subcutaneous lateral brow lifting or temporal direct brow lifting are very useful tools for the oculoplastic surgeon to achieve optimal periocular enhancements from blepharoplasty and brow lifting.
Thank you, Dr. Tanuja. I understand this is a vast topic. However, thank you for pointing out the difference between either side of the face, where one side looked smaller and thus the brow looked lower. That was something that we would have missed. Thank you so much for your wonderful.
Thank you.
Yeah, Tanuj, you are most welcome to stay back with us for the entire session, but we can understand if you want to call it off.
Thank you.
Thank you so
Thank you
much
very
for
much.
being here.
Okay. Thank you. Bye-bye.
So
Dr.
we'll
Anand,
next move. Yeah, go ahead. So
request you to just unshare and reshare once so that we can see the entire screen. Yeah, perfect.
yes, perfect. So next speaker is Dr. Andre Borba on regenerative blepharoplasty. Andre.
Hi, everyone. It's a super pleasure being with you, this invitation, great honor for me. So we're going to talk about my experience the last year. I can tell about this kind of blepharoplasty. We can say it's a new concept. You know about all it's happening in regenerative medicine. So the first thing I point out is the diagnosis. We need to understand what is going on. The quality of skin is very important for us as well. And also the lack of volume and this eyelid. We all know the importance of having a super beauty and natural and secure rejuvenation from our mentors, and we know how it's important with all of this kind of diagnosis. Let me check here. We have the excess of skin, canthal tendon laxity, fat bags. Everybody knows how important is the eyebrow, as the doctor told, muscle dynamics, and the three-dimensional volume. These two last 8 items they are very, very important for us. So this is a paradigm nowadays. We are having many, many patients with loss and lack of volume, like these patients that we need to make the fat transfer. And this is something that we dominate, we know how to do. But the problem also here in Brazil, and I think in the United States, and I think in all of the world, we have this impact now with the GLP-1. And that's why I am bringing this issue for us to discuss. We have so many lack of volume and a super deflation that happens with these patients. So always we go to a surgery, in general, I use the technology, I like DECA laser, and also we can use after cutting, we can also make in all our reconstructions and also use the CO2 laser as a rejuvenation tool. Why? Because we open the channels, the micro channels, and we have 3 minutes after that to use a nanofat, a PDRN, an exosome, something that we're going to make this quality of skin a little bit better. So in this case, for example, I use the lower eyelid, but the CO2 laser, But, we need to understand the hypopigmentation, the retraction, and also thinking about the rejuvenation. So if it's possible to put something there that's going to penetrate in the skin and it's going to activate, we know that the literature is not good, but the evidences, the clinic evidences that we have is really very interesting. And I incentivize you guys to use it because it's very interesting. Here in Brazil, I've been doing for this time, and we know that this regenerating activists really boost the collagen and provide antioxidant protection. Like this. We know after this resurfacing, we used to see erythema, edema, and after this, the use of these anti-inflammatory tools, it's wonderful, even the post-op after a resurfacing. So it's something very good and we need to consider. In this case, I did the surgery and also the microfat and nanofat. I'm going to show a little bit. This is just a PDRN, so it helps the quality of skin after the surgery. But the beautiful thing I'd like to share about my experience is with the nanofat. This is a stromal vascular fraction, regenerative cells, growth factors. We have no volumetric intent, so it really goes just for rejuvenation. This case, I did the microfat under the eyebrow and all these parts in the lateral wrinkles, and we know how nice the product goes, like autologous product, and we know that's going to be it will last at least 1 year, 2 years, and then maybe I can do more in this old patient. We know that she's going, she's like 70, 80 years old, and we know how the quality of the skin is not good, and we need to repeat sometimes the procedure, but it's something that helps a lot when the patient comes to us. So the microfat, the difference is just the support, volume restoration, all of you know and use it. And the nanofat, basically the texture enhancement and also the dermal improvement. Like this, as the doctor told, we have all this area. We need fat. We need to see this. It's a relief, and also we can see how depression we have in this area, and we need to put some volume there. We need to say to the patient that it's not going to be immediately like a filler, like an hyaluronic acid. It's like we need to use like understanding that in 2 or 3 weeks, it's going to start to have some effect. And also what we do is to make good light respiration. In general, I take like 4 cc's from each leg, and then I make the procession with some filters. Nowadays, I'm also using the LipoCube, and then we have the material for using in this patient. The good thing is that it's autologous, and we use with a 22 gauge cannula and go to everywhere before performing the surgery itself. I have all the marks, but then after making the microfat, I go and I make the infiltration with anesthesia, and the patient is sleeping now, and then I can make all the surgery. So it's important and help us a lot. We can go to everywhere, temples, and also the sulcus, superior sulcus, upper sulcus. And also, I like very much to make all the design of this area in the mandible and also the menton. So then we perform the surgery. The periocular volumes are really different, varied from patients, and this is the point. We needed to make more and more to make it very well. and perform. After the CO2 laser, just for opening the channels, it's not a very, very deep one. We can also use the nanofat in the inner part of the skin and under the dermis, and also on the skin. We know that we only have 3 minutes for using it, and we can use other products as well if you believe it's going to be good for the patient as something that's going to be bright, the skin, make it brighter, like tranexamic acid that I like very much. And then we have good results, and I think the patient's very, very happy. Many of them, it's very rare you see a patient that's not happy with this kind of procedure. We have the lipocube, as I told you. It's been very interesting. I think we don't have any block during the injection, and it's something very interesting, I think, for the microfat especially. I am more confident when I use it. And then I have here during the surgery, some patients also in the ambulatory, not also in the day hospital with the local anesthesia. You also can do that in some place, especially in the Lamellar area when we needed to fill. And it's a place that I like very much to make, and we can make it. We also can use exosomes, autologous, and from also the exocube. And then we also can put a little bit of nanofat and inject in the dermis area, under the dermis, of course. And then we have a good result as well of the quality of skin for some time. So there are some resources and the tools we have to use nowadays. You understand how nice it can be. Some patients here, and then in 10 minutes, I can show to you how nice it goes on temples, malar area, and also the quality of the skin itself. The practice is technique is very, very easy. We can use like if you know how to inject hyaluronic acid, you also can make all the microfat injections in your patient. It's the same risk areas, and it's important to understand this as well. Small areas, I believe it's important to remember the hyaluronic acid. You're not going to put this patient under anesthesia, remove fat just for making a place. She was very sad with this because of a microfused ultrasound problem. And then we have a case here for show to you as well. And we are just finishing. A patient who was with the hyaluronic acid, and it was a tyndall effect like this, a lot of hyaluronic acid in this area, a technical error. And then after I decided to remove it and make with fat, microfat, and also using nanofat and CO2 laser. So I think for these cases, it works better. And a patient that came for a surgery 3 years ago, it was like this, but she has PMMA under the eyelid. And then I said, I'm not going to operate you. She go to another doctor and she did the procedure and came like this with this terrible ectropion. And we used PDRN before the surgery for the inner scar. And then I did the graft, the skin graft with also nanofat and everything. And it helped a lot, I think, the case. And the last one, another problem, complication done by a dentist. In Brazil now, the dentists can operate eyelids. Okay, this is a problem, a very, very huge problem. And then the patient had the bipolar, excessive bipolar cautery in the lower eyelid. And you see the thermal necrosis, the fibrosis. So this patient, I did like a lot of injections of PDRN. It's off-label but I did injections to make it better, 5FU as well. And then I had better, it was a little bit soft in 4 months before the Christmas. I decided to operate her. My plan was 6 months, but then before a little 2 months before I did the surgery to help her, I used this Lamicin. It is, the PDRN. It's wonderful. I did the graft, and now she is like this, a little bit happier. And that's what I'm experiencing with all of those regenerative things. I think we need to think, a little bit further about this. I think the surgical elegance is not about removing more, and all of you agree, and that's it. So it's a super pleasure being with all of you. We need to understand this new era of regeneration and being in all surgeries with this kind of thought, because I think it will help our patients. And I wait for you in at the APSOPRS this year in Portugal, Cascais, in September. It will be a pleasure to having you there. Thank you very much.
Thank you,
Thank you
Dr.
so much, Andre.
It was really an excellent presentation. Dr. Andrew, I have a question to you.
Please.
Do you mean that there is additional benefit with SVF as compared to nanofat alone?
Alone. That's what I'd like to make, But nowadays, what I can tell you, the patients are adapted. All the dermatologists are making these treatments at the office, so they do a lot exosomes and PDRN and mesotherapy with this. Okay, so this is total in Brazil. It's like water, you know. So the patient comes with this, and it's really interesting. There are no many scientific papers, but we see some result. We see that we know that's regenerating. It's very. There are some scars that we cannot say it didn't regenerate. It's very interesting. But nanofat is, I can tell you, the best in my opinion, especially with the CO2 laser. If you can combine in the inner part of the skin, especially in the lower eyelids, with a little bit, just open the channels with CO2 laser or microneedling as also, it helps a lot. So you need to be quick. 3 minutes only you have for not closing the channel, and then you can put the nanofat there. And I wait for 24 hours before removing it after the surgery. In general, I combine with the surgery.
And one more question. How long do the regenerative benefits of this nano or SVF
This is the question. This is the big question. We are working it. We are studying, trying to make it a little bit scientific. But I'm bringing this topic because, here is something like everybody's making it. And I think United States, many people use LipoCube too. In Europe, we see as well this movement, and I think that it will be the future, in my opinion.
Last question. See, when we use a hyaluronic filler, we usually aspirate whether we should go ahead, we do not go ahead. But in your place, like especially you have mentioned the dentist and all are also doing all this periocular rejuvenation, any complication in regards to your nanofat or your SVF for the periocular rejuvenation?
You mean the complication? We needed to treat all these patients. There are no ways. We need to treat. It's our patient.
What are the common complications that you have come across?
Actually, from dentists is ectropion, of course. Okay, many of them, many complications, and also there are one. There were some courses of dermatologists that went like 1 year ago, and it was like a problem as well. We have 20 million people in São Paulo, where I live. So you imagine many people performing blepharoplasty now, dermatologists, aesthetic medicine, and also dentists. So what do you think is going to happen? Many complications and but ectropion, I think, is the worst one.
But amazing presentation, Dr. Borba.
Thank you.
On behalf of APSOPRS, we invite you to Guwahati for our biennial meeting, which is happening in November. Very soon, Milind and me will write to you again.
Nice. I'll be there. Thank you very much for all. Today I'm running a cadaver course here, and I'm going to that place now, but I'm going to be in the meeting with you. Okay?
Thank you. Thank you so much.
Preeti, you'd like to have any questions for Dr. Andre or any experience of your own?
Oh, yes. Andre, hi, nice to see you virtually.
Hi,
And
how are you
it was,
doing?
I'm good. And it was a wonderful, wonderful presentation, especially the last case was an eye opener. I think we have to be careful with bipolar cautery and oxygen together. My God, that
Yeah.
was something scary, and you've managed it so beautifully. My question is like, do you have any selection criteria where you use PDRN versus PN versus exosome versus nanofat? And do you have any increase in post-op inflammatory phase when you do these fat injections? Do you like change your post-op protocol based on that? Because we do use lipocube here quite often. I also use it pretty often. And I find some of the skin textures, they get a little yellowish discoloration in spite of following the entire protocol in nanoflat. Do you also have similar issues there in your part of the world?
I had one case from many, but one case of it was like a chantelasma.
Yeah.
And I was just thinking if it was some aggression I did in this area, some damage, I don't know, during the injection. I'm not sure about it. We are just studying and making all the data. It is very interesting. The majority cases, we don't have problems, as you know, but there are some bumps as well that sometimes we see, but in 2 or 3 months, we don't have more. We also have the quality of the skin much better and the patient very satisfied. This is what makes me very happy with this treatment. There are some plastic surgeons here that they're mixing with hyaluronic acid as well to make it in a good plan, but I don't feel comfortable. I don't know. I think they are all different. So this is a movement, I think, from the industry of the hyaluronic acid to put it together because it's very popular now here, the nanofat. So everything happening at the same time very quickly. And we are just trying to understand a little bit more this movement of the nanofat here. But I think the results are outstanding. They are nice.
You would use it for every case of blepharoplasty, or you
Not all
different selection?
cases, but if we have a lack of volume, yes, I use the micro and nanofat.
So for nano, yeah.
Yes, I go to the operating room and general anesthesia in general, I make it, very comfortable for the patient. And I make it like in 3 hours, very tranquil, and I make it very well, like a full face rejuvenation. And I think it's something that we needed to think about. It's really interesting for some patients.
PDRN versus PN, any difference?
Sorry?
PDRN versus PN.
PDRN and exosomes, let's say, I have a dermatologist that worked with me. And in some post-ops after resurfacing, she makes these mesotherapies with the PDRN. And she shows to me some cases that it's wow, you know, the anti-inflammatory effect. Nobody can tell that's different. They have a super anti-inflammatory effect. That's why I injected. It's off-label, but I injected in that case because it was so hard to make. I needed to break that scar to make the graft. So I didn't know. I didn't like to use also triamcinolone. I don't like it. So I tried, and I have a super new good result. Like it was soft for operating. And this is something that we need to study as well for scars, for this kind of fibrosis. It was very, very bad in that case. Yeah.
Amazing. Thank you so much.
Thank you. Thank you for everybody.
Thank you so much. We can move to the next speaker. Dr. Hamza, could you share your slides?
Should be sharing.
Yes.
You see it there? Okay.
Yes, it's visible to us.
Yes, Vic.
Okay. Thank you very much for this opportunity to chat, and actually fantastic to follow on from Andre's talk. So today I'm going to be talking to you about the treatment of malar fluid edema using a thermochemical fractionated energy with topical tetracycline sclerotherapy. So I've got no conflicts of interest to declare, and unfortunately no propriety or financial interests in the devices or products I'm going to discuss. So we often use the term festoons, and what it describes is the anatomical changes that accompany the laxity of the lower lid area. So this is namely the inferior displacement of the skin, which is accompanied by loss of skin elasticity. We see draping of the orbicularis and then descent of the fat. The term is actually derived from the Latin word festo, which refers to a wreath or garland that hangs down from 2 points, so sagging down. Now, festoons are often used interchangeably with malar bags. However, some clinicians make a distinction between the two as differentiating influences the treatment choices that we make. So what are malar bags? Malar bags, also referred to as malar edema, describes the accumulation of fluid in the fat compartments overlying the cheek. This fluid develops and collects in distinct compartments bounded by ligamentous structures that we're all familiar with. So the orbital retaining ligament and the zygomatic or cutaneous ligament. The pathophysiology behind festoons may contribute to the development of this edema. However, there may be other causative or aggravating factors. I often see this in patients who have underlying rosacea, so an inflammatory dermatitis, which might contribute to this. So an understanding of the regional anatomy and the changes that may happen is important to identifying malar edema and thus choosing the appropriate corrective strategies. If we look at the lymphatics of the lower lid and cheek, we see actually that we have the medial branch that we're familiar with, and then in the lateral region, we actually have a deep lateral channel and a superficial lateral channel. And these collecting networks sort of layer down through all of the tissue layers. And you can see that where they're bounded by these ligamentous structures, you can get kinking and tethering of the lymphatic outflow, and so accumulation of this fluid. This is why if you poorly select patients for filler injections or HAG filler, you'll see that by adding volume in this area, you can actually obstruct the lymphatic fluid channels. And there you can see the accumulation of where that fluid would happen. So what are the therapeutic approaches? So one is you can promote lymphatic drainage, but this is not that effective because you have to still address the underlying pathophysiological mechanisms. Then we've heard about stimulation of neocollagenesis, which increases the skin elasticity. And the neocollagenesis actually causes basically a sclerosis or shortening of these fluid spaces, so reducing lymphatic stasis. And the descriptions of RF-based devices, microneedling, chemical peels, and biostimulators. During my fellowship in LA, we also used to talk about the posterior girdle technique, where we would lay down calcium hydroxyapatite deep onto the bone and then use HAG filler in a more superficial plane to try and squash the fluid, essentially. So there's a device called the Tixel, which is a non-penetrating thermal energy delivery device. So the device head consists of an arrangement of these indenting pyramids. So they don't penetrate, they're just indenting that heat up to 397 or 400 degrees Celsius. And so it's delivered by this handheld system, and the contact time and indentation depth are the controllable parameters for a fractionated treatment. So the primary idea essentially is that the thermal microtrauma will result in tightening and neocollagenesis. And why we have it in our practice is that it also has applications for meibomian gland dysfunction dry eye treatment. We're also familiar with tetracycline, which acts as a sclerosant as well as inhibits MMP and various other growth factor activity, and essentially causes sclerosis of these fluid-filled spaces in malar bags. The usual route of delivery that's been reported is direct injection into the malar bags, with a success rate of about 59%. Repeat injections usually are needed, and patients often describe these injections as being very painful. And concentrations of between 1% and 3% tetracycline have been used safely. So what about combination treatment? And Andre talked about the opening up of passages, so basically breaking up the squamous keratin to allow penetration of your drugs or delivery systems. So there's a paper by Ronan and Shavit looking at the Tixel and how it can actually increase absorption of medications, topical medications, for up to 24 hours following treatment. And you'll see that in this histological slide, what tends to happen is that it causes a zone of so where the zone of tissue injury is in terms of the burn, either adjacent side to that, you get dehydration of the surrounding skin, which then creates these little channels for penetration of drug. So the Safi Hastin et al. Also then, using this principle, looked at delivering liquid tetracycline for the treatment of thermal festoons following Tixel therapy. And so in their paper, they actually provided a grading system, which I think might actually be useful in terms of choosing what treatment modality based on what Andre has also mentioned. So here's a few of my cases that I've treated. And so here in the top picture, this is a pre-treatment. You can see the little fluid pouches in the malar area. So it's a right grade 2, left grade 3. And this is immediately post-treatment. You can see the treatment area. And then we apply on topical 1% tetracycline. And this is 4 weeks after her first treatment. And you can see the improvement in the fluid festoon or fluid bags. Here's another patient, also sort of milder. And these are the kind of patients, if you had to give filler, you may get away with it, but you may only exacerbate these sort of malar edema. So grade 1, both sides, and this is after 2 treatments given 1 month apart. So here's a case I learned a lot from. So this patient came in for lower facial rejuvenation, and you can see, treated with hyaluronic acid gel filler. And as I mentioned before, you can see how this has exacerbated that malar edema. So we then dissolved out the filler and then used the Tixel tetracycline combination. And you can see after 3 treatments of Tixel and tetracycline given 1 month apart. So, after listening to Andre, I think this is now an opportunity for me now to start using nanofat to improve the rest of her lower facial area. So Tixel and tetracycline, it offers the benefits of both thermomechanical skin stimulation and the sclerosing effects of tetracyclines. And those channels, as I mentioned, have been shown to stay open for up to 24 hours. So the tetracycline dose we use is 1%, and you can actually give the patients this to apply on for those 24 hours after treatment. The optimal drug delivery occurs at settings of 400 microns for a duration of 6 milliseconds, according to the papers. But the range I usually use is between 400 and 800 microns for 6 to 12 milliseconds. And it's very quick to do. Treatment time is 5 to 10 minutes, very well tolerated. So sparing the pain of intralesional tetracycline injections. And the number of treatments depend on severity and response, but range generally between 2 and 5 treatments, and each treatment given about a month apart. So, in summary, careful evaluation and appropriate treatment for malar edema in patients seeking lower periocular rejuvenation helps improve outcomes and patient satisfaction. Many commonly used rejuvenative treatments such as filler and even surgery may only exacerbate this malar edema if it's not identified and treated either at the time or beforehand. And so Tixil followed by topical application of tetracycline is a well-tolerated, effective treatment option to add to the armamentarium of the periocular rejuvenator. Thank you for listening.
Thank you, Hamza. Is Adit here?
Yeah, I'm here.
Adit is our Festoon expert. So, Adit, over to you.
Hi, Hamza. Nice to see you here virtually.
Yeah, yeah.
That was an amazing talk, especially considering that all of us have exhausted all possible options for treating festoons. We still believe that if a patient is persistently requesting you to treat a festoon, we refer it to our nearest competitor in India.
Exactly.
But in India, we have started using doxycycline injections because tetracycline is not that freely available. We referred to a paper published by Chong from US on the East Coast, and they did submit some data, but as you mentioned very correctly, that around 59% improvement in patient satisfaction is present after these injections. We also find maybe similar results here with doxycycline as well. But yes, we've not tried a combination with the TCIL device that you have there. Maybe something like Thermage or something might work along with doxycycline injections. But yes, I think patient selection is the key. When you're choosing these therapies, the patient has to be really motivated that they want to get rid of these festoons. Second, they need to be counseled very well because counseling is very important. As the physician themselves, they don't know what the end outcome would be. And third is obviously repeated sessions, which may be required in these patients. And always under promise and over deliver, I think, should be the key principle followed here. But yes, otherwise, I think all over the world, all of us battle with this problem of festoons. But this certainly, the combination therapy provides us with a new dimension here. In Indian patients, I don't know, the patients that you treated were mostly Caucasians and Fitzpatrick on the lighter tone. In Indian patients, whenever we combine a heat device along with these injections, already the pro-inflammatory effect along with heat sometimes causes hyperpigmentation. So that is one concern we have because of the skin quality. I don't know if anyone has similar experience, but I would like to hear from the panel and the other speakers as well about this.
So for me, why I chose Tixil actually is because it's a very low energy delivery system. So the depth of penetration is not that much. So it would I suppose similar to a low depth micro needling type of effect. But what appealed to me actually was the paper I read where it creates these little channels that stay open for longer for drug delivery. So like Andre was mentioning, it's we've seen the benefits of PDRN, PN exosomes anecdotally, especially from our dermatological colleagues. But then what other modalities can we use? And we know that, doing nanofat and microfat injections help also to improve the skin quality, So for me, it was about where the fluid is sitting, I think it's both in that subcutaneous layer and deeper. So which to me would make sense why, using doxycycline as a sclerosant might help. But I think one of the things is that it's multifactorial, and we're now seeing different modalities of treatment, and I'm sure in time we'll each come up with our own algorithms based on what we identifying in the patient. So for example, the patients I showed you is we could use the Tixil and treat them, and then once we see that the fluid is settled, we can actually now go towards doing surgery and adding fat and all of those. Whereas if you had done that primarily, the edema might just worsen. Then coming back to your question about the Fitzpatrick scoring. So we see a lot of darkly pigmented African patients here. So the Tixel actually works, we don't see much pigmentary changes. And if we do, they're transient, they're very transient. They fade after a couple of months. So often you'll get those little, these little sort of dots that they get. They hypopigment and then slightly hyperpigment and then it fades. So we've never really had an issue in those. It's interesting for me, but I think it's about presentation. So our African patients don't tend to present with the festoons. It doesn't seem to be as obvious in those patients. The pigmentation maybe hides it, to some degree.
Yeah, because we see a lot of festoons. Sometimes we see patients who predominantly present with festoons and very little fat, and that always presents a challenge here in our part of the world. So it's something we have to work out on.
One last comment that's made a difference for me here is actually, picking up underlying rosacea. There are lots of patients who have it and they don't, it doesn't bother them when, in terms of the redness and the heat. But if I'll always ask pointed questions, whether the fluid changes during the course of the day. Is it worse in the morning, better, throughout the course of the day? Are there any triggering things, so like tannins in wine. So these patients who have rosacea, they often, after a few sips of wine, they look like they've had a whole bottle because they just flush. And, it was interesting for me because we use the Tixel for meibomian gland dysfunction treatment as well as a heat-based device. And those patients would say that those dry eye symptoms actually get worse after they've had, wine the evening before. So for me, what it meant is we're looking at the form of ocular rosacea as well. And it's often those patients who have the fluid festoons. So it was in treating patients for meibomian gland dysfunction with the Tixel that, I'm sorry, the other way around. I was treating festoons and the patients actually then reported that their meibomian gland dry eye symptoms got better, so it's, so if I pick up rosacea, I'll also give them treatment for that, before even touching them with anything else.
One last question I had is I actually had a patient a few months back who had a deep plane facelift, and with the deep release of the ligaments in the area of the blocked lymphatics, her festoons significantly improved. I don't know if anybody else has seen that experience with that, but it was sort of a phenomenal improvement without actually directly treating the festoon per se.
Yeah, yeah, I think so too, and I think it's because when you get laxity of those ligamentous structures, so we know like the blood vessels and that will always move across those ligamentous structures. So with the lymphatics. So I think what tends to happen is that the lymphatics, being a very low flow system, get kinked, and then you get releasing that would make sense then.
Yeah, one of the mechanisms of festoon is because of the tethering of the ligaments. So if we do a subcision and release those ligaments and fill it up with a sclerosing and even with a biofiller, it does work with the subcision of the ligaments and the combination therapy.
On the contrary, sometimes people say that playing around too much with these ligaments can sometimes worsen festoons as well, because it damages the lymphatics because they pass through the ligaments. So it can sometimes, in the initial 2-3 months after the surgery, it looks better. But later on, after a year or so, there is a rebound where, the fluid starts collecting more there. This is one of the views which was expressed because I was going through a lot of literature about festoons, and that's what they showed, that predominantly the lymphatics, especially the zygomaticocutaneous ligament, where it is the most densely attached. And if we start releasing that too much, the lymphatics get damaged and there is rebound sort of festoon formation 6 months, 9 months down the line after the surgery. So it's very interesting, which...
Yeah, it is. And on that point, so it was saying anything we do in this lateral compartment, because that's often an area that people want to fill. So, a lot of our aesthetic GPs, they love to inject the cheek area, especially this sort of that lateral cheek area. And it's often in those patients that we'll see fluid buildup. So any sort of intervention in that lateral compartment where you've got the superficial and the deep lymphatics may cause retention of fluid there.
Yeah, festoon is really a topic which can go on for hours, but Thank you so much, Hamza. In the interest of time, Hamza, I'll ask you to unshare so that we can have our last speaker, Dr. Goldstein, who will talk about toxins in periocular and facial rejuvenation. Thank you. Thanks, Adit.
Am I still sharing?
Yes.
Sorry. There we go.
Well, greetings from Philadelphia, and I'm going to run through this talk relatively quickly. This is a talk that I'm actually giving here right now, and then I'm actually heading down into the city in an hour to give this to residents and fellows in a slightly different version. But I have no financial disclosures. Hold on one second. There we go. As we all know, there are different things that we can offer our patients in terms of facial rejuvenation that they can do at home, things that we can do in the office, things that we can do in the operating room. And we've been hearing a lot of great techniques throughout the morning already today. Here, I want to focus more on the office side with cosmetic evolution of neurotoxins and oculofacial rejuvenation. We know that we can use toxins around the periocular area. It's been done for many years. There are lots of approved toxins on the market, but we're going to talk about facial rejuvenation applications, complications, preventions, and some emerging concepts. Toxins came out in the 1980s where they were originally used for blepharospasm and strabismus. And by 1989, they were fully on the market. Within 10 years, it was obviously recognized that these had cosmetic applications. And over the last 25 years or so, there's been an explosion of techniques. If we look at a survey done by the American Society of Plastic Surgeons, which they do on an annual basis, we can see the number of blepharoplasty, facelift, toxin injection, filler injections, and how they have evolved. Patients used to want to go bigger and better, and now people are really looking more for tweakments and prejuvenation with more subtle natural results in 2026. So with toxins, we know that oculoplastic surgeons have pioneered periocular toxin applications, but the cosmetic uses expend well beyond wrinkle reduction. We can use them to do brow shaping, facial contouring, neck rejuvenation, and using smaller microtox techniques to improve skin quality. If we understand the facial muscles and how they move under the skin and how they pull on the skin and cause wrinkles in the skin, we can then use toxins to target these different areas to get the effects that we want. We all know that the toxin binds at the neuromuscular junction and inhibits the release of acetylcholine. That effect lasts for about 3 to 4 months. And eventually there is recovery of the axon through sprouting and reinnervation. And by injecting into these areas selectively, we can have dynamic rhytid reduction with softening of static rhytids as well over time. There's reduction in facial movement, and we can start to use these to sculpt the face, such as the brow or soften periocular lines. And if we know our underlying facial muscles, we can then start to target them specifically to achieve the results that we want. In the periocular area, there are 5 muscles in general that we focus on, from the orbicularis, which closes the eye and can pull the brow down, but also our corrugators, procerus, and depressors supercilii are pulling the brow down, versus the brow elevator, which is your frontalis. And we try to create that balance between the brow depressors and brow elevators in the periocular area. Weakening the lateral orbicularis can produce brow elevation as well, but be careful as you get to the eyelid area to avoid the levator and not induce ptosis, or in the lower lid lateral cheek to avoid the zygomatic major and minor muscles to get facial droop. But certainly, if you maintain a safe distance from the orbital rim and stay superficial with conservative dosing, you'll get a nice result. And we can start to target different lines around the face and eyes if we understand this. Again, there is an underlying tug of war going on between different muscles in the face, so you want to selectively use your toxins to not only do wrinkle reduction, but ensure that you can adjust the brow position, eyelid support, and not affect the blink. In the United States, we have 6 toxins on the market, and they all typically work with serotype A. They all last about 3 to 4 months. Daxibotulinum toxin is supposedly marketed originally to last 6 months. I still find that lasts 3 to 4 months. In Asia and Pacific countries, there are a whole host of toxins on the market, but brand name wise, Botox, Dysport, Xeomin tend to be the three big companies that are out there being used around the world. South Korea has a lot more innovative techniques out there, but you gotta be careful because they are a lot less expensive. Buyer beware what you're getting. With glabellar injections, we all know that we can just get in here and we can see where the procerus muscles, the corrugators, and the depressor supercilii muscles are, and we can target these with our toxins and getting down deep. Here in the glabella, I like to go a bit more vertical and get under that thicker skin to make sure that I'm into the muscle. And we can put 3 to 5 injection points here and spread out our toxin and get a nice result. For the frontalis muscle, keep in mind we have 2 bellies of the frontalis muscle, and they are pulling our brow up. We've saw a great talk earlier at the start of the session by Tanuja on brow lifting, but you can also use this balance between frontalis injections and your depressor injections to target how you want to adjust the forehead and the brow area. Keep in mind when you're doing frontalis injections, you got to get out lateral. I'm feeling a temporal fusion line here. If you got to get out just medial to that temporal fusion line so that you can soften the brow without giving a lateral elevation from the frontalis being overactive and the very medial portion being underactive and giving a tilt to the brow. I also can come here into the hairline and just smaller doses and get the very superior portion of the frontalis. In younger patients, you can use larger doses. In older patients, you're going to get more of a brow ptosis, so you got to be careful there. In the crow's feet area, we can sit in here and we get our patient smile. This patient had about 3 months, 4 months out from her previous injection, so she's having a lot of movement, and she's in her mid-40s. But you can see here as we get in here, again, 3 to 4 points along the orbicular orthoculi. As you look at the schematic drawing on the left, you want to definitely avoid getting too inferior and getting into the zygomatic major and minor muscles out here. And you can even come a little bit into the roll here of the eyelid to get the orbicularis and help contour that area as well. And we're going to repeat this on the other side. In the name of time, I'm going to skip up to the next video. We can see here that with the perioral area, we tend to target the orbicularis oris muscle. Here we're going to do a little lid flip. We're giving about 1.5 units per injection here. You don't need a lot here. If you give too much, you're going to affect the pucker, and patients are not going to be happy with you. But with a small amount, you can get the perioral rhytids, and you can get that little lip elevation. You can also inject into the depressor angular oris here with 1 or 2 injection spots to soften that muscle down there. If we head down further into the face, we can start targeting the masseter and the platysma. These work very nicely. So here I have the patient bite down. I can feel the masseter muscle. I stay inferior to a horizontal line from the earlobe to the corner of the mouth. And as long as we're staying low, we're not going to affect the facial movement in the upper part of the face. Once we get the masseter, we can have the patient tighten their platysma, and we can come from under the jawline all the way down to the clavicle and give serial injections here to help soften those muscles there as well. We're going to move on. So with botulinum brow attacks, we're giving injections in the glabella and the lateral tail of the brow. We can start to elevate the brow and give nice contouring. If we have asymmetric lines in the glabella, we can certainly come in here and do asymmetric injections and dosing to achieve better symmetry. Here's a patient who was in a motor vehicle accident about 30 years ago and has scarring in her right brow and upper lid. And that right brow is scarred down and up. So it doesn't have a lot of movement, but she really does not like that her left brow is lower. So here we injected the right frontalis muscle to lower the right brow a little bit. And we inject the left brow depressors to elevate the brow. And you can see we can achieve a better balance here between the two sides just with toxin. In the crow's feet, nice injection here, giving a softening of those lines with the dynamic rhytids. Here's the patient that we did our perioral injection on. You can see a nice lid flip here with that lid up and softening with the depressor angular oris. In the neck, we can see softening of the platysmal bands and this improvement of the skin texture as well. Complications, we know that there are a lot of side effects to toxins. Most common is going to be bruising. If you hit a sensory nerve in the glabella area, you can sometimes get a little bit of a headache. If you're not careful with your sculpting techniques, you certainly will get facial asymmetry, especially in the brow area. And again, in older patients, when they get into their 50s and 60s and 70s, you got to be very careful to not over-inject the frontalis muscle, or you're going to significantly drop that brow. Eyelid ptosis, if you're injecting too deep in the eyelid area, you're going to get into trouble. Too much injection around the orbicularis can cause lack of thalamus. Thankfully, I've never seen diplopia from aesthetic Botox, but you certainly can get facial asymmetry, as we talked about. But if you understand the anatomy, you use conservative dosing and appropriate dilutions, you should avoid these problems, such as this patient who came into me from another Medi Spa where she had received her botulinum toxin 10 days earlier and came in with a new onset ptosis. That will resolve in 2 months. Around the world, oops, went too fast there. We do see that there are a lot of toxins coming out. You can buy these on wholesale websites, but I do recommend you be very careful where you get your toxins from because you don't know what you're always purchasing. So in future directions, we know that longer duration formulas are being developed and that we're trying to do precision microdosing with our treatments, as well as combining these with regenerative aesthetic techniques. Future trends include novel toxin serotypes, which keep getting released, as well as the potential for topical neuromodulators and expanding our approach to periocular rejuvenation strategies. But our modern takeaway is, modern toxin therapy has evolved from simple wrinkle reduction to rejuvenation of the whole face and the periocular area specifically, with comprehensive facial modulation. And botulinum toxin I still find is a very important part of my aesthetic practice and sort of the foundational basis for where we start. Periocular applications require detailed anatomy knowledge, and that between these newer toxins with diffusion, formulation changes, and duration, as well as less immunogenicity, we can start to see how we can improve what we're doing with our toxins that have been around for 40 years. And with that, I say thank you from Philadelphia, which we're getting ready to celebrate our 250th anniversary here in the United States after the Declaration of Independence was signed here in Philadelphia on July 4th, 1776. And with that, I'll end my talk.
Thank you so much, Scott.
There we go.
Those were lovely videos. And just one quick question and a tip to avoid ptosis in glabellar injections. Your comment.
Yeah, it means for my hand, I like to keep my finger along the orbital rim, and I like to stay just above the brow, and I have my angle of my needle going upwards towards the forehead, not towards the eyelid. In all my years of doing periocular Botox, I've had one patient who developed a ptosis, and she came back. Finally, a year later, I convinced her to do it again, and she got a second ptosis. And for her, I think she had a little connection from the sensory nerves down into the orbit that maybe the toxin was traveling through that went down. But for the most part, if you stay above the orbital rim and stay about a centimeter apart, I think you're going to be just fine.
Well, thank you so much, everyone. I can see the presenters from the next session already appearing. So thank you, everyone, to all the speakers, as well as the panelists. And thank you, Ananya.
Thank you so much.
Thank you.
Thanks for having
Bye.
us.
Bye.
Hello, Dr. Vito.
Hello, hi.
Hi. Hello, Dr. Sorcha. If I'm saying
Hello.
it
Hi.
right. Hello. How are you? Hello, Dr. Fogla, sir.
Hi.
Hello.
Hmm.
Hello, sir.
Hi,
I
Vitu.
believe that Dr. Namrata ma'am will be joining very soon. She is multitasking between sessions. So I think she'll be here in a while.
Good afternoon, everyone. Hello, sir. So I'm Dr. Nidhi, and I will be managing this session along with Dr. Rolika. So would you like to try on your slides once, or we'll do it once the session starts?
I'm in the first, right?
Yes, sir.
Let's try. Can you see?
Yes, sir.
Okay. Okay.
Dr. Nidhi?
Yes.
Just 1 second, I'm calling you up.
Yeah.
Hi everyone, thanks for joining in and taking out time for this session. Yes, ma'am.
If you want, I mean, I'm last, but I can just really quickly test out my slides there. Do you see my slides?
Yes, we see.
Yeah, okay. All right. Then I think that will work.
Yeah, mine is working as well.
We can see as well.
Sure, fantastic.
We start to get good at Zoom.
May I share my slide? Hmm. Okay, you can see my slide.
Yes.
Yes.
Thank you.
Dr. Fogla, so Namrata ma'am just called that she'll be joining briefly.
Mhm.
I mean, in just a while because she is in Coimbatore in another session. So
Mhm.
she'll be joining shortly. And till then, we will just start with brief introduction. I mean, we'll start sharp in 8 minutes.
Sure.
And Dr. Nidhi just wanted to check everybody's affiliation so that we don't get anything wrong. So, Dr. Nidhi, over to you for just checking the affiliation.
Yes.
Yeah, that's absolutely fine. Don't worry. I'll be able to announce the speakers.
Okay,
There's no
perfect, ma'am.
problem. There's no problem, right? Or
So,
else
ma'am,
I'll
you will
send
be
you.
taking the speakers part?
Yeah, there's no issues. If you want to check, I can tell you.
Yeah.
Yes. You have Dr. Romanos.
No, ma'am, if you will be briefing the speakers, that's absolutely fine.
Okay, sure.
We just did not know the flow. So, Dr. Nidhi will be just introducing the session and then she'll hand it over to you for the briefing of the speakers now. Is that okay, ma'am? Perfect.
Good. Is the screen visible, ma'am? Nidhi, ma'am?
Yes, it's visible.
Okay.
And you're audible as well.
Okay.
Yeah, it's visible and audible. You need to probably stop sharing.
We start, ma'am?
Yes. Thank you everyone for joining us for this AIOS International Conclave. It's completely my pleasure and honor to have such a great faculty here for us. And we will be having a session for about an hour, more than an hour, 1 hour and 15 minutes on lamellar corneal surgery. So I will be introducing the first topic, which is global trends in lamellar keratoplasty. This would be spoken by Professor Vito Mano. He is in Italy in University of Brussels. Over to you, Dr. Vito.
So thank you very much, Nidhi, for the introduction. Thank you very much for the invite to Namrata Sharma, to all the organizer of the conference. Just can you see my slide, right? Can you see, right?
Yes, we can see. Yes.
Great. So this one, I'm presenting an initiative from endothelial keratoplasty learning group, and that with the European Eye Bank Association brought forward in last months. So it's a global trend in lamellar keratoplasty. Why is needed? Because it's more than 10 years that everyone knows about this paper about the Tourette group that about the what's happening in the cornea in terms of supply and demand. So in more than 10 years, there's been a shift from let's say penetrating keratoplasty to lamellar technique, and especially DMAC. So what we try to do here to describe the supply and demand in the lamellar keratoplasty era, and to align what's happened with the capability between the surgeon and the eye bank. So we have two cross-sectional survey. We have a surgeon and we have eye banker. So the eye surgeon as eye bank has been asked over a period of 6 years between 2019 and 2024 what's happened in terms of volume and which surgery they can do, and which are their preference in terms of preparation and the cell density threshold and postoperative management. And same thing we did in eye bank. So who answered 60 surgeons. So there is a high response rate here, 44 eye bank, and most of the hospital were university hospital. And so this means that we need to take in account in case of a limitation of this data. And then the period, as I said, is 6 years. So the area, it's missing just one continent, but you can see that there is Europe, Asia, Americans, and Oceania and Australia. So which are the results? We see that the DMAC is persistent growth, as you can see from 2019 to 2024. There is a DSEC is going a little bit down, and the ALK, it's a pathology driven and it's more or less stable. We need to take into account that during 2020, 19 and 20, due to the COVID, there's been a reduction of the procedure, and of course it's been due to the COVID. In terms of practical pattern, it's interesting to see that between the surgeon that most of them, they perform DMAC. So this means that it can be a little bit skewed. And there is a graft preparation. Most of 42% they do surgeon prepared, 27.8 preloaded, and some pre-stripped. So still the majority, again, is the surgeon prepared. The marking, someone with the ink, is 55%, asymmetrical is around 18%, and no marking is the rest. The tamponade, most of the people use air, but the other half use SF6, that we know as a tamponade lasts longer. Most of the people, 85%, do a peripheral reidectomy. Just a few people use OCE, intraoperative OCT in DMAC. And the rebubbling rate is around 10% and go from 5 to 16. DSEC, instead, it's interesting to see that majority, they probably not all the centers have microkeraton, nor prefer to prepare outside of the theater in an eye bank. And the people that they use instead in theater, most of the people use it with the microkeraton, just few people with the femto. We know the limitation of this. The preparation time is about 10 minutes, and then most people use air. Here we know that the detachment rate is less. For this reason, probably most people skew to the hair. And the OCT is not really used. And the ALK, big bubble technique is the preferred technique. Mushroom PK, it's rarely used. And here, intraoperative OCT, I think if you have to give additional information, but it's not diffuse overall. Also, this is very interesting regarding the follow-up and the steroid use. after EK is interesting because the follow-up, we see that 40-45% of surgeons keep looking at their patient, but it's not possible everywhere because sometimes there is some big referral center and the patient is being seen locally by their own ophthalmologist. Instead, in terms of endothelial keratoplasty, as is been discussed, probably the use of steroid long-term is useful. I will show you later. Instead of ALK, most of the people, they stop after a year, more or less 50% of the people. This is important things because the endothelial keratoplasty rejection can happen in 6% of the cases according to Lamis Beidun report in 2016 in the MELES group. Then from Germany, they say that after these are the percentage after 1 and 4 years, probably you can detect with this tiny spot as slit lamp or even better with the sham from camera. And it's very important this from MELES that they still using, they showed that if you're still using steroid, this is probably the reason why most people keep using it, there is a less risk of rejection. So the suggestion, I think, come from here. Regarding the eye bank, 44 replies, I said before, the median age of the donor is 67. We are talking about, eye bank from every part of the world globally. The cadaveric, most of our cadaveric donors, as I said, and direct retrieval oversight. So it means that there is an equipe that retrieve the eye straight away. There is a balance between organ culture and cold storage. We know that Americans go for cold storage and Europe go for organ culture mainly. The distribution here, you can see that which are the people, the country that go within the country that are most, and international instead just few of them, and then there is a local. So that means that they are the smallest one. It's interesting here. You can see the tissue, the trend in high bank in terms of retrieval and suitability, and this is important to see how much corneal we have, and we had a dipping as well here during COVID. There is some discard for microbiology, serology remain low as said. I think here we need to highlight the importance of endothelial cell density and how to evaluate. At the moment is still operator dependent, and probably we need a more fix how to fix this. Preloaded tissue seems increasing, but think about that we are looking at just few eye banks. They are probably in good centers, and this is important. But we need to keep in account that, as previously said, probably they carry on with the high detachment rate, and the time between the preparation delivery is important in terms of graft rebubbling rebubbling, especially in DMAC. Fuchs endothelial dystrophy is still dominate as an indication. As you can see here, probably the DMAC and the outcome is making important this shift because probably more and more people is going towards a surgery because the results are quite good, the rejection are quite late, they're quite small. It's very important to keep in account if you have some biomarker that you have this posterior stroma ripples, because we know that go to influence the vision. If so, in case you have this long-standing edema, you have remodeling of the stroma, and probably it's worthwhile to do surgery as soon as possible. This is something that we look from this perspective. So we did a supply demand with the practice level view of the gap. So this means that we see how much corneas in mean that are suitable and distributed by the bank, and which is the maximum number of keratoplasty that in mean, of course, a surgeon can deliver. These numbers are 403 and 150 per year. So we did our calculation with the practice level. So means that we need how many cornea can be supplied by the bank and the surgeon can deliver. It's no epidemiological study or real-time clinician. So this is one of the limitations, but Following this definition, and we looked at the numbers, we can say that we have one donor for every 3.7 needed, with a range between 2.5 and 7.4. So of course, this is not a precise estimate of the unmet demand, is no epidemiological study, but give an idea of how many cornea do we need in this, how many, the maximum that it can deliver in the surgeon and the cornea can, and the eye bank can provide. So these are the limitations. As I said, there is, of course, a self-reporting, no voluntary participation. Okay, so probably there are active center or engaging center that are more involved in this study because of the AKLG and EBA. Of course, can be a sampling bias. But I think this is a way to, let's say, reply to the research question and to our question to understand the supply-demand question. So the message is DMAX is confirming that it's dominant for endothelial keratoplasty. The practice pattern are a little bit heterogeneous. There is not a clear cut in terms of graft preparation, marking, or tamponade. The eye banking is shifting towards an preloaded in terms of probably in high volume one, it's more important. But regarding the supply demand alignment is imperfect, as I said, and the population level, so epidemiological study probably still needed. So thank you so much. I would like to thank you as well, of course, the EKLG and the EBBA that make this thing possible. Of course, with a lot of, also Needy and all the others here help to reply to these things. Thank you so much.
Thank you, Dr. Vito, for a wonderful talk. And it seems like the world is moving towards DMEC and more so towards a pre-stripped, DMEC tissue would be supplied. Any comments or question for Dr. Vito from all the esteemed faculty here? So just a question to the faculty here from my end that what has been your experience in using the pre-stripped or the tissue here in India or anywhere around the globe? Have you compared your results with your own prepared tissue and what has been your experience?
If I can add a little bit, I had the privilege to work with Melis in the Rotterdam clinic, and they always worked with pre-stripped tissue because the people there had the experience from the very beginning, and their expertise of stripping over and over, and that being their primary task, led to a very high quality. So once I started to receive pre-stripped from extremely good technicians, I couldn't go back. It's so predictable, it's so reliable, and it saves an awful lot of hassle in the operating room. So I'm very, very happy with pre-stripped. I don't necessarily need preloaded for the additional costs, but I'm very, very happy with pre-stripped tissue.
One quick question to Vito. When you analyzed on the outcomes of using pre-stripped tissue, did you compare between preloaded and just pre-stripped, and did you find any difference?
There is no big difference between preloading and pre-stripped. Yes, we compare preloading and pre-stripped. The big question I think we need to focus is how the distance or the time between the eye bank and the surgeon, because as soon as you increase the time, I think you will find some differences. Probably the explanation could be the migration of the cells on the other side of the descent, and we partially address. We see that the medium, if you put dextran in the medium, probably if you take it out, you reduce a little bit the rebubbling rate. Probably it's a multifactorial things that make but the difference between the surgeon prepared and the preloaded and pre-stripped in our eye bank means with the 2 or more days of time between that, it's difference, it's big difference. So for this reason, I think we need to understand how far is the eye bank. Also in America, normally they use, if you notice in America, most of the time they do not dye again the tissue. This means that it's very close in terms of preparation and in terms of, I think the best will be, of course, to have a nice eye banker technician that is skilled and do this 20 minutes before. but it's not always possible, and this will make a difference. So there is a difference in how you define preloaded and all these kind of characteristics.
Yeah, thank you for that talk and wonderful discussion here. I think we'll go ahead with the next talk. And I guess Dr. Mohit, who was at Harvard, will be talking about adapting eye bank systems for the evolving needs of lamellar keratoplasty. Over to you, Dr. Parekh.
Just a second. Okay, can you see my screen?
Yes, we can see your screen. Yes.
Okay, excellent. So thank you, Nidhi, for inviting today, and to everyone who are present here. Amazing faculty, and I think all your questions are very valid after Dr. Vito's presentation, and I think I will be able to probably highlight a few responses to these to the questions through my talk. So just to start, we have already seen that corneal transplantation has undergone a major transformation over the past 2 decades. Once the DMEC and preloaded and everything just started coming in. We have moved from full thickness transplantation, as I said, towards a very highly selective lamellar procedures. And while surgery has evolved rapidly, eye banking systems worldwide are adapting to these changes. And not all the eye banks have been able to outperform, but high volume eye banks have particularly been involved in innovations and getting everything on the floor. So today in my talk, I am going to discuss about the adapting eye banking systems that are needed for the evolving needs of lamellar keratoplasty. And we'll also look at what are the future options and what are the eye banks looking towards. I do not have any financial or personal conflicts of interest. So just to go back and start looking at where we actually started from, the philosophy of corneal transplantation has changed dramatically. I mean, we started with the penetrating keratoplasty long back, and instead of now replacing the entire cornea, we selectively replace disease layers. So it could be the endothelium with stroma like D6, or only the ALK. So endothelial keratoplasty in particular and anterior lamellar as well have improved the outcomes significantly. They have reduced rejection rates and accelerated visual recovery. So this surgical evolution has fundamentally changed what surgeons now require from the eye bank, because now that we know that these surgeries can be reliable, maybe the grafts prepared from the eye banks could make it more easier for the surgeons. So this is just an overview of how historically the eye banks used to mainly recover, evaluate, and distribute tissues for PK, and how they have moved into lamellar surgery demands with much greater precision. Also, surgeons increasingly expect pre-processed, validated, and surgery-ready tissues. Especially in US, we have been seeing a very good trend, increasing trend in terms of these precision selective transplantation for mainly for DMEX and preloaded tissues. The eye banks are actually now transitioning from tissue repositories, so where the tissues were just collected and not even processed. It was just basically quality assured and provided to the surgeons. Rather than that, now they are moving into specialized processing centers where the tissues are being processed, they are being quality assured, they are being quality controlled, and then provided to the surgeons. And now they are also going back to look at how to predict the outcomes. So one of the biggest shifts in the eye banking after the DMAC in 2006 by Dr. Mellis has been the emergence of surgeon-ready tissue. So as we discussed before after Dr. Romano's talk, that there are a lot of factors that influence the outcome of these pre-prepared tissues. But however, the preloaded and pre-stripped grafts have shown to reduce the operating time, as again Dr. Sorka just mentioned. It has also minimized manipulation and improved standardization. This is especially important in those countries where surgical expertise and training opportunities may vary widely. So we see that a lot of surgeons prefer their own centers to prepare, or they prepare the tissues by themselves. But if there is not much training opportunities available, then these surgeons can heavily rely on the eye bank prepared tissues. We have also seen that a high volume eye bank can prepare more than 5 grafts per technician per day, which can allow the technicians to learn microsurgical skills and actually outperform low volume surgeons when it comes to tissue preparation. So additionally, we have seen that these tissues come with complete quality checks from the eye bank, which is not always possible in the OR because not all the surgeons would have the capacity to do the trypan blue or the endothelial cell counts or other quality assurance parameters. We have also shown with Dr. Romano that you can use V-check as a method in the OR before transplanting the tissue. So that could be one of the good options. As I said, that in the recent era, quality control becomes a big question because all the tissues are prepared by the eye bank and then being delivered to the surgeon. So most of the common requirements are the endothelial cell analysis, the microscopic variation, like everything matters, including the endothelial viability, graft thickness, tissue handling directly after surgical success. The quality assurance systems, they must become more and more sophisticated, standardized, and very recently also data driven. So AI and ML could really play a big role in terms of quality control and assurance. Recently, we have also started observing that the future could extend beyond donor tissue transplantation for an eye bank, because eye banks do provide the tissues for cell therapy. Many eye banks are now investing a lot in the regenerative medicine area and also in bioengineered corneas. So as I said, like regenerative medicine is definitely rapidly entering ophthalmology, including the epithelial. We have been seeing the epithelial cell transplantation for a while now. With recent KLEC transplantation in US, we have the endothelial transplantation ongoing in phase 3 with Orion. And there's a lot of work going on in the bioengineered side with EndoArt. So these are the processes that could redefine the role of eye banks. And tomorrow's eye bank may absolutely function more like a tissue engineering and cellular therapy center rather than just a traditional processing area. I'm sorry, sorry. So India, so what it means for India, India is uniquely positioned to become a global leader in next generation eye banking. The country has absolutely strong surgical expertise and a large patient population. Um, However, the access and infrastructure still remains uneven. There are centers who have really good eye banks and completely standardized areas, but there are certain centers which lack these infrastructure. So developing a centralized lamellar processing hubs and standardized quality systems, these could dramatically expand access to advanced corneal transplantation, at least pan-India. The next frontier could be the artificial intelligence. As I said, it's there and it's here to stay, and this may soon transform iBanking workflows mainly, because predictive analysis could definitely help with determining graft suitability. It can forecast endothelial survival, optimize donor recipient matching. We can combine the digital tracking systems in iBanking and see where AI would be efficient and personalized in personalizing tissue allocation. So that could be an area of interest in the future. So the whole iBanking system is, or rather, the next generation iBanking system would rather will be built on three major pillars, and these three pillars could be the precision tissue preparation, where the advanced microsurgical techniques would come in place, with sterile controlled environments and consistently high quality tissues. The second part could be the regenerative medicine integration, where the bioengineered cornea, stem cells, regenerative medicine would play a big role in bringing the cell therapy and the ATMP products into practice. And the third one could be AI, where digital and AI-driven quality systems could provide real-time monitoring and predictive insights for better outcomes. To summarize everything, it appears that lamellar keratoplasty has definitely reshaped the entire corneal transplantation ecosystem, but iBanks will and must evolve from passive tissue suppliers into active innovation partners, because that will support the precision surgery, regenerative medicine, and digital healthcare, as I said in my previous slides. Of course, the future of corneal transplantation will depend on these transformations. There's also this very big project going on with ARPA-H in the United States, that is on the whole eye transplantation, where iBanks are playing a key role in identifying the best eye globes and best tissues and the preservations for the whole eye transplant, and that could be one of the major goals in the coming decade. And with that, I would definitely like to thank all my peers and partners from UCL, Institute of Ophthalmology, Venice Eye Bank, and Mass Eye Ear. And I'm open to questions. Yeah, thank you.
Thank you, Dr. Parekh. I guess we are looking at a future. We were talking about pre-stripped and preloaded. We are going to regenerative medicine in eye banking, and a very great model that you kind of propose as to have processing centers which have high quality parameters to check for the tissue and supply. So any questions or comments from all the faculty here? Dr. Tityal is also with us. Thank you, sir, for joining us. If any questions for Dr. Parekh?
May I ask a quick question? I think it's a really great idea to have the cornea banks as central models for regenerative medicine, because they have the connections with all the surgeons. Have you any idea about the appetite of corneal bankers to sort of shift and pivot to regenerative cell therapies? What's their perspective on this?
So the eye banks have so even if you want to go for the tissue regeneration, you will still need the primary cells. So unless we go into iPSCs or any other cell type, the eye banks will still be present. They will, so most of the, so for example, if we are doing KLEG, so when we were doing the KLEG trial, we were using the patient biopsy. But if you want to go for the allogenic epithelial transplant, then you will need the tissues. Once you have the tissues, you then need to understand what are the parameters that will be used for the expansion of these grafts. So the eye banks are asked for very, very specific tissues. For endothelium, I remember talking to Dr. Kinoshita, and he was saying that if you want to expand it to like really good number of tissues, like really large number of grafts, then you need very young donor tissues. And that is a trend that we have been seeing with most of the companies here, MSL, OcuCell, even Orion Biotech. They all need younger donors and younger pairs. So younger donors is one of the major parameters. Then we need the tissue, the preservation time. So there are factors that only eye banks can really work on. And these are the factors that the eye banks are already working on. But side by side, they also want to make sure that if there is a shift in the cell therapy, then what are the other products that the eye banks would bring in? So even if we have the cell therapy, the eye banks can then start looking into how we can preserve these cells for a longer time, shelf life, all the other parameters that actually can be done by the eye bank, specifically because these technicians know how to handle these tissues and cells.
I guess we are looking at a future wherein the regenerative medicine, a GMP facility, would be working along with the eye bank. So it would be
Yeah.
actually one team which needs to come under one umbrella and work for the future regenerative medicine.
So we already had that in Venice. So our iBank was a part, and then we also have an extended version where we have the GMP facility. So that is a very good model actually. And if possible, I mean, we would also like to start something like that in the future. So we have that entire translational part that we can then provide the tissues along with the GMP grafts.
Cost will be the only limiting factor.
Cost is always a limiting factor. So.
Because in Japan, I believe one treatment with the cultured endothelial cell costs something around $80,000, which is currently supported by the Japanese government. I don't know whether any of our patients would be able to bear such kind of an expense.
Yeah. So
I
sorry.
think with that you can do 80 DMEC surgeries,
Yeah, sorry. I'm working in Japan because Japan are importing many donor corneas from US eye banks. And then if the Japanese patients would like to have the Japanese domestic donor corneas, they have to wait 2 to 3 years. So, and then and then surgeons would like to perform DMEC, and then the pre-peeled descendant membrane is reasonable for DMEC, of course, and then surgeons would like to import pre-peeled DMEC donor graft from US, but if patients will have US imported donor corneas, then 100% of the procedure have to be paid by the patient themselves, not by the health insurance system. That's Japanese system. So that's why now many of the surgeons shift to cell injection therapy instead of the imported donor cornea, DMEC or DSEC. So it's a very local issue. And then cost, I admit that the cost is very expensive, but there are normally two ways. The equivalent way, if we will have the new glaucoma eye drop, and then the government will refer the previous glaucoma eye drop, for instance, but there is no previous cell therapy product for treating Buer's keratopathy, and then the companies can they put the all cost to develop the new therapy products, and then once once the new product is accepted, then the price will decrease by using the economic estimation system. So it's just the beginning. So and then so this is the situation from Japan.
Thank you. Dr. Tatyal wanted to say something. Yes, sir.
No, I was thinking, the future is definitely shifting towards a regenerative technologies in every area, looking into endothelial cell cultures and getting the, things done. But in our country, in India, it might take, I don't know how much time to succeed into this because we are struggling with the available things, which we are not able to utilize them in an appropriate manner. But I think with the invention of AI-based technologies and things are moving very, very fast, and if it can be done in a manner which actually reflects the equitable distribution to not only India, the world over, I think that's the future. I think what Mohit was talking about has a definite sense for us to look into something which gives you, more precise treatment for these people.
Yes.
But yes, it is a definite future.
Yeah, I guess we have a challenge of giving quality care to patients with having processing centers, at the same time trying to develop regenerative medicine for taking up the need that we have, which cannot be overcome by the present supply. So I guess both needs to go hand in hand. So with this message, we'll go on to our next speaker, who needs no introduction, has been mentor to most of us, and it's completely my pleasure and honor to invite none other than Dr. Fogler. He is just the person to talk about talc in any meeting, and he'll be talking about femtosecond talc. Over to you, sir.
Thank you, Nidhi. I shall be talking about femtosecond laser-assisted DALP for keratoconus. No financial interest to disclose. Now, if you look at the management algorithm for keratoconus, surgical intervention like a partial or full thickness corneal transplantation comes way down in the management options once you have exhausted all other means. But the advantage of performing a partial transplant like DALP is that there is no risk of endothelial rejection as you preserve the healthy host endothelium. You need to use steroids for a shorter duration. The surgery is performed in a closed chamber, so reduces the risk of intraoperative complications, and you can do much large diameter grafts because of the lack of endothelial rejection. This is a patient where we have done a DALP 20 years ago, and you can see that the cornea looks very clear with a good contour on anterior segment OCT and maintaining a good healthy cell count. And I added one more advantage to DALC is that it can easily be repeated if required because the interface never really heats. There are two main techniques, one which is popular, which is the big bubble technique, where you have a stromal injection of air to create a plane of separation between the stroma and the predeciments layer. And the other one is the Malbrand's peeling technique, where you try to go as deep as possible and close to the decimets and peel off the stroma. The advantage of using a femtosecond laser is that you can make very precise incisions, shaped incisions, like the top hat, mushroom, zigzag, Christmas tree. This increases the surface area of the graft host junction, so gives better apposition, and sometimes tectonically the strength is also greater. With the modern femtosecond laser, it helps simplify the surgical technique, and some of them are equipped with intraop OCT, so makes the surgery a bit more easier, and you get faster and better visual recovery as well. This is a patient post femtosecond DALC with a mushroom-shaped graft, and you can see at 2 months has a unaided vision of 20/40 and a best-corrected vision of 20/15, and that's the topography and the cross-section on the anterior segment OCT. My personal experience has been with the Zima Z8 femtosecond laser. It has dedicated software for performing DALC, and you will see in this video, this is a patient where we can plan the treatment. We can also make the track or the channel for the inserting the cannula to inject the air into the stroma. So the laser makes a side cut and a lamellar cut at 200 microns as we plan. And there is a track as well into which we introduce the bottom port air injection cannula. And as we inject air, you can see that you can achieve the big bubble. And because the end of the tunnel is placed very close to the decimets, the success rate in the learning curve can be improved. You prepare the donor in the same way using the same mushroom shape, and this can be secured using sutures, and you can see that you get because the donor corneas are kind of a little bit more swollen, sometimes the cut may not go through and through because the laser fails to cut at a deeper level. You place the graft and you complete the suturing. This is another technique of doing a femto DALC where we are using the peeling technique. So here we prepare a 360-degree stromal pocket for the intracorneal ring software. And then we make here you can see between 7 and 8.6 inner and outer diameter at about 450 microns depth. We created that channel for the intracorneal rings. Then we refine from the surface. Now you can go with your scissors into the channel for the intracorneal ring, and you can just complete the cut. And then you can just do the peeling. The left hand is doing most of the work. The right hand is just allowing the fibers to separate. You can use this kind of counter force to peel off, but I feel that sometimes if your apex has any scar, you can end up opening up the posterior layer. And then you put in your graft and you can secure with sutures. And you can see that's how the patient looks in the postoperative period. And that's the anterior segment OCT for both the big bubble and the manual. And you can see that there is hardly any residual stroma that's left behind. Comparative studies have shown between femtodalk and a manual dalk. This is from Garrett Mellis's group, published in 2019. And they found that both in terms of visual acuity and the astigmatism, the difference was not quite significant. The only difference they found that the manual dalk, the corneas, had a slightly steeper curvature compared to the femtodalk, possibly because the femtodalk has a larger graft-versus junction interface. So maybe the wound is stronger, resulting in a slightly flatter cornea and a lower myopic shift. This again, paper from Moorfields, where they compared multi-surgeon results, and they found that when you use a femtosecond laser, especially in the learning curve, the incidence of intra perforation of the descemetes and conversion to penetrating keratoplasty was much lower in the femtodalk compared to the manual dalk. So I think in the learning curve of performing a dalk, especially when you're starting off, having a femtosecond laser does reduce the incidence of complication. Another study looking at doing a RCT on comparing whether femtosecond laser dalk does make any difference. When they compared the mean postoperative astigmatism and the outcome, they did not find too much of a difference. But in the subgroup analysis, if you do look at the rate of conversion to PK, you find that in the femtosecond assisted dalk, it was 31% and 37% in the standard dalk. And also the rate of big bubble success was higher, 67% in the femtodalk group compared to 52% in the standard dalk group. So somewhere there is, again, it depends on which laser they were using, because now the newer laser, which have the integrated OCT and dedicated software, maybe they will allow a greater success rate of performing the dalk. So in conclusion, I think the femtosecond laser allows greater precision and customization of corneal incisions for dalk, integrated with the anterior segment OCT, because you can see intraoperatively after you applied the section where exactly your cut is going. It improves the safety profile and it can help reduce the complication associated with manual dalk surgery. And possibly you will have better refractive outcomes if you can make the corneal anatomy much more normal. Thank you. Thank you for a patient hearing.
Thank you, Dr. Fogler. So of what the results were showing, it indicated that most of the parameters are similar whether you were doing a manual DAC or a femtosecond. So from your experience, is there any specific indications where you would want the audience to know these are the situations wherein you would actually go ahead and use femto over a manual DALK?
Given a choice, cost is the limiting factor. If my patients, everybody would pay for a femtodalk, I would do a femtodalk in almost every patient of dalk, because I believe that you can get much more precise incision both on the patient and the donor. When you put in your donor, you find that the donor actually fits. You cannot really oversize your graft when you're doing a femtodalk. Even if you oversize by 0.1, 0.2, you will find the graft looks bigger. So that's the beauty of the incisions which are there. And I think the manual dalk that I've started doing, where I make the 360-degree intracorneal ring pocket, that makes it very easy, because that's what you're doing when you're doing a manual dalk, whether you're using a scissors or you're using a spatula to do the spiraling technique where you make the peripheral groove. You have a beautiful device like a femtosecond laser that can make it in a very precise manner, especially with the integrated OCT, because I put the suction, then I go on the OCT and see where my cut is going to be. And I can take it down very close to the decimus. Otherwise, you usually put that based on your pachymetry measurement and you make an assumption that that's going to make it. But here, when you can see where the cut is going to be, you can confidently go and make a cut very close to the decimus. And then if you want, the software doesn't allow me to make two cuts. Otherwise, I have to use two procedure pack. But I would go and then make a mushroom cut on top of it, which goes into the interface. And then I can just peel off the grafts. So imagine surgeons who don't want to do dalk just because it's too time consuming or they fear complication. This technique would take away the need for them to inject air or do anything. They can just use the femtosecond, make this 360-degree pocket, make the side cut, and then just peel off the graft, put in the donor, and they would finish the surgery in less than 30 minutes.
I guess we are talking of more precise surgery, better adoption of dull cure with femto laser, and also in situations, challenging situations wherein you wanted, where the manual dull could go wrong. That's where the femto would come in and do a very precise and safe surgery. Thank you for that fantastic talk. And we have Dr. Namrata Sharma ma'am also join us. Thank you, ma'am, for inviting this group for this meeting. We have you joining us, and I'll be giving my introduction myself. I'm going ahead with my next talk is by myself. I'll be talking about, this is a presentation which I would dedicate to this group, EKLG study group. It actually just started as a learners group, and I'm sure all the faculty here has been part of this group. We have evolved from a research into a global research forum, and we have now such a kind of distribution of over 56 people globally. And that's the work which is coming out from this study group. I'll be presenting the consensus in management of Fuchs dystrophy, which is the major indication or the main primary indication for DMEC globally, or endothelial keratoplasty, mostly in the West, a lot in this side as well. So there was a need for Delphi panel, which was required, understanding that, there are so many studies on Fuchs corneal endothelial dystrophy. So this panel primarily wanted to know that what is the current understanding of the pathogenesis of Fuchs, what is the diagnostic criteria we should be using, what is the clinical assessment and ancillary tests we should be doing, and what are the current options for conservative management as well as the recommendations for surgical intervention. Like a typical Delphi methodology process, it underwent 3 stages of selection of the experts and round 1, round 2 questions, and finally a discussion round, which was a live round of members globally who participated, with 70% deemed as achieving a near consensus. This was the participant group and the members who were on the panel who actually designed the questions and who took up the results to understand what is going to be the recommendations. So I'll be presenting these recommendations, the first one being on the pathogenesis. So it was understood that the prominent disease mechanism was defined to be a TCF4 gene issue with an oxidative stress mechanism. And also it was understood that it was not just the endothelial cell loss. It was actually an abnormal Descemet's membrane which was responsible for the Fuchs dystrophy. It was also understood and agreed that the endothelial cell mosaic may typically remain intact over the guttae. It's not that all the endothelial cells are lost around the guttae which are present in Fuchs dystrophy. And it was understood that the chronic state of subclinical edema actually precedes the detectable clinical edema in FECD patients. Now, coming on to terminology, which actually mixes between corneal edema, corneal guttae, and the Fuchs endothelial dystrophy, it was defined, corneal guttae was defined as a non-progressive central guttae or a central guttae in asymptomatic patients. However, FECD was represented at different severity of the same disease. It could be the scattered or confluent guttae, it could be central or paracentral, and it could be typically bilateral and symmetrical. However, the subclinically or clinically detectable edema was not required to diagnose FECD. So that is the important takeaway from this Delphi. Now, coming on to diagnosis, for which would be very important for all the clinicians who are present here, the diagnosis of FECD was mainly slit lamp examination. It was not thought that any specular or confocal microscopy was not thought to be necessary to make the diagnosis of FECD. And the early vision symptoms in FECD would typically include loss of edge, clarity, loss of contrast equity, and disability glare that the patients would be coming to clinic to us. A central scattered guttae in absence of a subclinical or clinical edema do not usually impair vision in these patients. That was the understanding of this group. And FECD with subclinical or clinical edema could actually affect the color perception in these patients. So these are the important symptoms with which these patients would come with. Now, what is the clinical assessment which would be required? So measuring the central endothelial cell density is not accurate. That was understood and accepted by all. The distribution and extent of guttae by clinical examination can be helpful for decision making in clinical practice. Now, patients with FECD have vision symptoms without clinically detectable corneal edema, and corneal topography is indicated in these patients. So an increase in CCT could signify the disease progression. Assuming that CCT is measured at a similar time of the day, a 10% increase in CCT over time was considered as significant. An asymmetry of 10% CCT between the fellow eye is considered significant in these patients, and a 10% increase in CCT in morning versus the evening was considered as a significant symptom in these patients. Now, when to intervene in patients of Fuchs? So, delaying any corneal intervention is appropriate if the patient is asymptomatic, even if there is a subclinical edema which is present. And delaying corneal intervention is usually not appropriate when clinically detectable either epithelial or stromal edema is present. So that is something we have to, as clinicians keep in mind. And when determining if the vision symptoms are from FECD in addition to cataract, it is recommended that the corneal intervention should be based on the objective measures in these patients. That would be either a tomography pattern, a significant change in CCT, as we have already told, and in addition to the subjective clinical judgment. So this is a very common scenario that the patients have a cataract and present with FECD. Now, what about the conservative management? Do they really have a role in these patients? So it was understood that a hypertonic saline, which we usually give to these patients, are best prescribed as an ointment at the bedtime to these patients. However, any form of steroids were not considered to be an appropriate medical therapy for FECD. Now, there are commercially available ROCK inhibitors, which are being talked about globally. They were not considered as effective medical therapy, at least in patients wherein they have FECD. Now, let's go from medical therapy to the surgical intervention in these patients. So, at present, although DSO is being widely performed in Western countries, DSO is not currently considered as standard of care. And if it's indicated, wherever it's indicated, it is most successful when the guttea are centered in the central 4 mm zone, and that's where you are doing the DSO. Now, there is also insufficient evidence to recommend a minimum peripheral endothelial cell density for successful DSO. That's also a challenge here, that we do not have that minimum peripheral endothelial cell density count in these patients. And an ideal ROCK inhibitor treatment is also not available here, which could be recommended along with DSO. That's what the group thought it to be. So hence, DMEC outcomes are definitely thought to be better than the DSO outcomes. Now, desmetorex's diameter between 7 and 9 mm is acceptable in patients where we are doing DMEC, and a phakic DMEC or FECD without a significant cataract is appropriate mostly in patients who are younger, 45 years or younger, and patients who are older than 45 years presenting with Fuchs in your clinic. You could think of seeing how much amount of lenticular opacity is present in these patients. Now, when cataract and corneal surgery are both indicated in the setting of FECD, it is recommended that the toric or multifocal IOL should be avoided when you're doing a combined surgery. However, if you're doing a sequential surgery, you could consider the toric or the multifocal IOLs. Now, with which, because of the time that we have in hand, I would not take up the pediatric EK recommendations because it's a long talk. I would just like to stop here and thank this group who has worked for this EKLG study group and is also working ahead. And I'm happy to take up questions from the audience.
Thank you, Nidhi. I think that was an excellent, must first of all congratulate you for putting the EKLG group together, which you are doing almost single-handedly with the entire team. And I think all the endothelial keratoplasty surgeons have come on the same page, which has been done in really a short period of time. And I'm sure lots and lots of more inputs and good work is going to come out of it. And the work that you presented is, of course, the testimony of the same. So,
thank you.
Are there
Yes,
any questions?
should we go ahead? Yeah.
Yes.
So we'll be going ahead with the talk by none other than Dr. Namrata Sharma. Ma'am will be talking about the role of OCT in EK surgery. Ma'am, we are happy to invite you for the talk.
So thank you, Nidhi, and thank you for putting up the session together. I would be talking to you about intraoperative OCT-guided lamellar keratoplasty. There are no financial or proprietary interests, although the intraoperative OCT really costs a lot. And of course, the advantages are that you have real-time images with dynamic visualization, and you have continuous and simultaneous acquisition and display of OCT images. Availability is an issue, and of course, the expense is also another problem. Now, this is a case of keratoconus where partial thickness trephinition has already been made and a bubble is being created using the needle. So the air bubble is instilled in the supradesmate membrane compartment. And just as you give a nick in the overlying stromal layers, you can actually see the descemet membrane marching towards the overlying stromal layer as the bubble egresses out. And then subsequently, as the viscoelastic is injected, like a kangaroo's pouch, one can see that the descemet membrane has fallen back, and dissection is done above the descemet membrane so that the bare descemet membrane is now there, over which the donor cornea from which the descemet membrane has been removed can then be sutured. So the advantage is that without actually having to imagine anything, you can actually see on the intraop OCT microscope at what level you are working. Likewise, this was a case of limbal stem cell deficiency where SLET has already been done. And just by comparing the, when you do a manual layer by layer dissection, by comparing the adjacent cornea, one can tell at what level one is dissecting. And now it seems to be clear. So again, the donor graft can be put. In healed eye drops, I think it has a huge role to play because as you come up to the area of the scar, so first partial thickness trephinition is done, and again manual layer by layer dissection is being done. And as you come to the area of the heel scar, you move your dissection a little anteriorly. So the heel scar is somewhere over here. So you move it a little anteriorly, and this also can be visualized here. And you don't open up the area of the eye drops. Then I think it has a very important role to play in eye bank, and we've been using it. So you measure the donor cornea on the intraop OCT microscope. There is a scale which is present adjacent, and subsequently the microkeratome is used. So the tissue cut is using the 400 microns on the microkeratome, and there is a factor which you have to multiply the thickness of this tissue, and we measure it actually with the scale. And in the current system that we have, we multiply it by 1.25. So you know what thickness of the cornea or the donor lenticule is there for the subsequent dissect. And we published this IOCT guided donor dissection for the dissect lenticule. Then this is a paper by Professor J.S. Tityal, a very elegant paper on IOCT guided dissect. And this is the donor lenticule, which is actually being intracamerally pulled, and subsequently the air bubble is instilled. And once you instill the air bubble, the dissect graft gets stuck to the back of the cornea. And according to this publication, 3 minutes is good enough for the air to be there so that the graft does not detach. And one can actually titrate to see that there are no gaps present at the end of the surgery. So it helps you to actually see the unseen, and what you would actually imagine, one can actually see it. Now here it was it was an ultra thin dissect lenticule which got rolled on its own, and it was upside down, which can be seen. So just by orienting the curvature, one can actually getting the two curvatures to be parallel to each other, one can get the ultra thin dissect to be in correct position, and then again air can be instilled so that the endothelial side is the one which looks down, and it can get stuck to the back of the cornea. And this is the ultra thin dissect. Now this is case of shed. Again, it is very helpful. It becomes very difficult to actually see the remnants which are present, Descemet's membrane remnants. So one can see on the intraop OCT microscope. Alternatively, if you don't have it, we can also see it on a silver reflector like this, like a crescent blade, and then pull it out with the help of the micro forceps. And the advantage is that it it stabilizes it a little bit. And in cases of shed, you can't even make out where the graft is and where the edges of the graft are, because obviously this is hazy. So as you inject the air bubble, one can see that the graft has got stuck to the cornea, and then you can also see the internal reflection at the edge of the graft here. And this is a case of IOCT guided DSEC which was done. And this is yet another case of IOCT guided DSEC in shed. We've published our results on IOCT guided in shed in a case series with good results. It helps in pediatric keratoplasty as well, and this was again published in American Journal of Ophthalmology, and we compared our results of IOCT with UBM in various corneal transplants in children. Now, when you have a graft which has got detached, again, it helps you to know where it has got detached. And as you put the air bubble, you can actually see that the graft has got attached. So it helps you in managing the complications as well. In DMEC, I think, again, it has a very important role to play. So all the desmet membrane remnants, which actually can be seen at the back of the cornea here, and these can be addressed. And as you put the graft inside, even if you don't have a S stamp, which was not there, you can see that it is upside down because it's not biceps curl upwards. So inject some fluid so that the biceps curl upwards configuration comes, and then you can inject the air bubble so the graft gets stuck to the back of the cornea. This is the same case at week 1, and then this is at 3 months. In hazy corneas, again, it makes a lot of difference because as you inject the graft, you don't know, even with the S stamp, because you can't see the S. So the graft is injected intracamerally, but you can see that biceps curl upwards configuration. And as that is seen, just as in this case, you get the correct side of the tap the graft once the biceps curl upwards configuration comes, and then air bubble is injected and the graft gets stuck to the back of the cornea. And this is in the post-op period. Again, when you have folds in the DMEC graft, one can see them. So you can see that there's a fold which is present here. So you have to go beyond this fold with the fluid so that you unfold the fold and then inject the air bubble. So here, with the help of the fluid, the fold is getting unfolded and then you inject the air. So this the fold is taken care of. Again, this can be done with the help of the intraop OCT. And this is the last one to show that this whole disc of desmet membrane had actually detached during phacosurgery. So this was injected inside. And again, one has to know, this is 2 hours after the phacoemulsification surgery was done. And so to know which side is up, look at the biceps curl upwards. Alternatively, you can stain it with trypan blue dye also to see how it curls. And then again, air bubble is instilled so that the patient's own desmets get stuck to the back of the cornea, and I call it auto DMEC because you're not using a graft. Of course, for biosynthetic corneas, we've used it for intrastromal keratoplasty. So the pocket is opened up, and then after opening up the pocket, the biosynthetic cornea is instilled inside as in. And this was a case of DLEC that we did with the intraop OCT microscope again. So we actually used a femtosecond laser because the opacity was present only posteriorly. And subsequently, this was removed, the posterior part of the cornea, which was hazy. And this is again on a femtosecond laser where this part of the lenticule is taken and it is instilled intracamerally. And then with the air bubble, the whole thing fits very well. And I call it femto-DLEC because this is essentially a DLEC which is done by femtosecond laser. And then air bubble is instilled at the end of the surgery. So this is the post-op picture, and subsequently the edema does clear over a period of time. And these are our publications, IOCT guided in anterior segment surgery. And so to conclude, I think IOCT is a useful tool in the armamentarium of keratoplasty surgeon. It acts like a third eye, helps to see the unseen. Of course, it has to get less expensive over a period of time so that everybody is able to afford it. Thank you very much for your kind attention.
Thank you, ma'am. I think that's the most extensive talk I've heard on IOCT and, so many indications. And in fact, I saw that the surgeries of DMEC being done in such hazy cornea, primarily because you have an IOCT for you. So any questions for Dr. Namrata? So I think we were talking also about having processing centers. I guess use of IOCT that you showed in graft preparation for DMEC. That is very, very a new concept. I mean, we've not really heard about it. So do you have good results with it, ma'am?
So the graft preparation that we did was the DLEC, and we've done now almost 5 cases of femto-DLEC. And of course, the case selection has to be good because only the cases where anterior part of the cornea is clear and posterior is opacified, we do this. DMEC graft also you can prepare using intraop-OCT microscope. We use it because we have it. But I think trypan blue, if you stain with the Descemet's if you stain the Descemet's membrane with the trypan blue, also works quite well, and you can actually see it. I think the greatest advantage of the intraop-OCT microscope is when the corneas are not very clear and you can't see your S stamp very clearly. I think there it really helps you a lot by the configuration of the curl.
Yes, I get the Indian subcontinent, at least we have a lot of pseudophakic bullous keratopathy, which have a lot of hazy cornea. That's where I guess is the main prime use of IOCT that we are seeing. Thank you, ma'am, for a great talk. And we'll move ahead with our program. We'll be inviting Professor Okumara, and we know he will, his name is associated with Rho kinase inhibitors, and we are glad he'll be talking about his work on Rho kinase inhibition in corneal endothelium. Over to you.
Thank you very much for inviting me. It's a pleasure to speak with you today. I have no financial or intellectual property related to this topic. My story with ROCK inhibition started when I was a graduate student. At that time, culturing human corneal endothelial cells was very difficult. We tested many compounds. By chance, we found that ROCK inhibition made the cells grow well. This table shows how our understanding has grown over 15 years. First, we found that ROCK inhibition helps cell attach, survival, and proliferate. Later studies showed effects on wound healing, on cell engraftment, on the cell cycle, and on barrier and pump function. More recently on cell migration. So ROCK inhibition affects almost every part of endothelial cell biology. This slide shows how the field moved from the bench to the clinic. In 2013, we reported the first clinical signal. Topical ROCK inhibitors seem to help recovery from endothelial dysfunction. In 2017, Dr. Molny combined DSL with Ripastil. He showed faster corneal clearing. At the same time in Japan, cell injection therapy with ROCK inhibitor reached clinical proof of concept. More recently, the Netarsto trial and the global K321 program moved the field into large-scale development. I took this picture during my graduate school days. When we added ROCK inhibitor, the cell colonies grew much faster. This was a surprise. At that time, most people believed that corneal endothelial cells do not proliferate. This finding later became one of the foundation of cell injection therapy. It also raised a simple question: if ROCK inhibitor works in a dish, can it work in the eye? To answer this question, we made a rabbit endothelial injury model. We removed half of the endothelium of the rabbit. Then we applied Y2763-2, which is a ROCK inhibitor, 3 times a day. You can see the treated cornea became clear faster, and the Ki67, which is a cell periphery marker, showed a higher rate, showing rapid proliferation. By day 14, the difference was very clear. The treated cornea was almost transparent. The control eye still had edema. This was the first in vivo evidence. ROCK inhibition can speed up endothelial wound healing. Then we asked which patients can benefit from this. The idea is simple. If healthy cells remain, maybe we can stimulate them by using ROCK inhibitor. On the left, a patient with endothelial damage after cataract surgery. On the right, a patient with Fuchs endothelial corneal dystrophy. In both cases, some healthy cells remain. Maybe these cells can restore function. You can see the red area. Red area shows the relatively healthy residual corneal endothelial cells. This patient had severe endothelial damage during cataract surgery, and he was referred to our university clinic. And we treated him with topical Y27632. The cornea slowly became clear and his vision improved. Of course, spontaneous recovery is always possible, but after several similar cases, we felt that recovery was faster than usual. Cell density in the healthy area was also preserved. So this suggests a real regeneration. The role of ROCK inhibition after cataract surgery is not fully proven. A randomized trial in this setting is very difficult to design. But for patients with accidental damage, immediate eye drop treatment may reduce the risk of bullous keratopathy. More work is needed in this area. Now let me move to Fuchs endothelial corneal dystrophy. In FECD, the damage starts in the center. The peripheral cells are often preserved. So we thought maybe peripheral cells can migrate to the center and restore function. This was one of our first FECD patients in a clinical research protocol. At that time, DSO, Dismiss stripping only, did not exist. The patient was already scheduled for corneal transplantation, and we asked, can we try a regenerative approach instead? Since DSO did not exist yet, we used transcorneal cryotherapy. We selectively killed and removed the central endothelial cells. One important point, we removed the cells, but the guttae remained. This was different from modern DSO, but it allowed us to test our hypothesis. This video shows the same eye about 2 weeks later. The cornea is now clear. We considered this proof of concept. With the right signal, residual cells can restore function by using ROCK kinase inhibitor eye drop. This patient kept the cornea clear for more than 10 years. His vision improved very well. This case suggests that long-term restoration may be possible. But edema is not the only problem in FECD. Guttae themselves scatter light. They reduce visual quality, so even if the pump works again, vision can still be limited. This idea later became important to understand DSO. This video shows DSO performed by Dr. Moloney, and DSO is common now, but he was one of the first surgeons to apply this idea to FECD. The concept is elegant. Remove the diseased central descemet membrane. Let the peripheral cells repopulate the center. Clinical studies show that DSO can clear the cornea well in selected FECD patients, even without using ROCK kinase inhibitor eye drop. Dr. Moloney's group also showed that adding Ripastil, which is one of the ROCK inhibitor, makes recovery faster and improves the success rate. I had a chance to meet some of his patients, and many said that night driving and visual quality improved very much. By 2019, comparative studies of DSO with and without Ripastil studied. These images show faster endothelial recovery with Ripastil following to DSO. This study showed 2 key points. Cell density recovered better, vision recovered faster. At this point, I think experts started to accept ROCK inhibition as a real clinical tool. Today, the most advanced program is K321. One important detail, every pivotal trial combines Ripastil with desmetoroxis, a DSO. The goal is not to replace surgery with eye drops. The goal is to support recovery after minimal surgery. The global phase 3 has completed follow-up. The detailed results are not yet public. Several ROCK inhibitors are now available or in development. Ripastil is most advanced clinically from the bench to global phase 3. For a ROCK inhibitor monotherapy, the evidence is limited. Some FECD patients improve, but long-term data is still missing. DSO combined with ROCK inhibition has strong support. It can help selected patients avoid a graft. Cell injection therapy with ROCK inhibition, which we studied in Japan, has already shown clinical success, but for advanced diffuse endothelial failure, endothelial keratoplasty is still the standard. Several questions remain. Which patients benefit most? Is migration more important than proliferation? Can surgery truly avoid it? What will the K321 phase 3 data show? Based on current evidence, here's my answer to the title I was asked to address today. ROCK inhibition has not abolished surgery, but it has made surgery smaller, later, and in some eyes, avoidable. Thank you very much for your kind attention.
Thank you, Dr. Okumura. I guess we understand that ROCK inhibitors do have a role in our clinical practice, and the evidence is only building up to understand that they definitely have a role with DSO. Any questions for Dr. Okumura here from the panelists?
I only, rather than a question, I have a comment, which is to say thank you so much for all the work in ROCK inhibition. I had a DSO patient that actually asked me if I could remove her DMEC on the other side because she was so happy with her DSO. Thank you so much.
Thank you. Thank you very much. Glad to hear that.
I told her no, I would not remove the DMEC.
Okay, thank you. And because of the time that we have, we're running a little short of time. We'll go ahead with one of the very important futuristic talk, which we'll be having from Sorcha. Thank you for joining us, and we'll be looking into what's coming in regenerative therapy that we started off with discussion in this session. Over to you. You're mute. You're mute. Could you just unmute yourself, please?
I just want to say thank you so much to you, Dr. Gupta, and to Dr. Sharma for inviting me to speak in this really nice group. And in fact, we've already heard some of the treatment options. My name is Professor Sarkni Ul. I'm the chair of the Cornea Committee of ESCRS, and I'm on the board of ESCRS, and I'm going to run through some of the exciting areas in endothelial or lamellar keratoplasty. And it's really fascinating to see the timeline of corneal transplantation, where we had this explosion in new innovations from 1998. And when I worked previously with Gerard Mellis in Rotterdam, I said, how do you go about innovating something so new? And one of his simple answers on that moment was, I hate sutures. So he wanted to always try and simplify and ease the surgical procedure and try and improve it from there. And that was inspiring. We've already seen that endothelial keratoplasty has been the huge shift in the last 20 years. And it's easy because it gives great vision, quick recovery, and excellent patient satisfaction, fewer suture-related complications. We also don't have the open globe moment, and we have lower rejection risks. So the question I would pose is, do we even need a new paradigm for innovation? So we have to look at the downside. Endothelial keratoplasty, there are limited tissue options. We've seen from Professor Romano that not everybody has access, and even if we optimized everything, there would still be people that didn't have access. Logistics at the level of eye banking, as Dr. Pragesh also mentioned. Longevity, how long will these cells last? Because we know the cell loss is acute in the beginning, but there is continued attrition slowly and slowly. So the DMECs we do now, we still need to know how long those will be, and there is certainly room for improvement. The endothelial layer is incredibly complex. It looks very simple with its hexagonal morphology outside. The interdigitation between the cells is really important for communication. And the big change in the paradigm, as we all know, was this essential New England Journal paper where the concept of culturing cells, expanding them and injecting them became a reality. This was a beautiful study, a beautiful paper regarding the cell suspensions, injecting the cells and posturing the patients down after giving a cleaning to the endothelium. Excellent and game-changing. The problem is bringing it to our clinics. And there has been a major evolution here in that there has been an acquisition from Orion Biotech, lead shareholders of Alcon. And this is, as we already heard, a reality in Japan. Let's not talk about cost at the moment, but it's a reality already in Japan, and it is making it closer and closer to the clinical centers. They have had 3 phase studies. They're making excellent progress. We can skip over this, but they're not the only game in town. I'm restricting the talk to cells that are already being used in human trials, although there's a lot of work in this space. The interesting concept from MSL, and this is a US group, is that they conjugate a magnetic nanoparticle together with the expanded cells. The idea here is that the more cells concentrated on the region of the cornea that's damaged, the better. So they augment the cell injection with a magnetic patch that draws the cells to concentrate where you need them the most. Their concept in their clinical trial is that they may not actually need to remove any surgical tissue. Most of us would debate this, that you probably do need to remove the aberrant decimae, because you heard from Dr. Duke Gupta's talk, this is a disease of the decimae, and the endothelial cells are a consequence of the decimae disease. But they're already up to phase 2 clinical trials. Their idea in the longer term is by increasing the safety and efficacy, you could probably treat patients earlier. But we've already seen in Professor Romano's work that people are treating earlier with DMEK. The number of treatment for Fuchs has increased, most likely because earlier onset treatment. Let's go to another concept, and this also comes from Japan, who are certainly the world leaders in stem cell regenerative medicines. This takes to another idea, which is the Shimura group is using iPSCs, or has used iPSCs, and brought this platform to the clinical trial stage. The great advantage is that you have a single cell pot or a large donor source, so you could treat a lot of patients and you could upscale better. It is a great idea, but, and this is the important but, there are risks. The Shimura group has brought it to a patient who had a rejected corneal penetrating keratoplasty, and the idea was to regenerate the cells using the iPSCs. Great idea. It was the first in-man trial. But unfortunately, after the fact, there has been the detection of a gene defect, a deletion in EP300, which is on the cancer gene census. So they've detected that it is not from the stem cell bank. It was during the expansion phase that this deletion was incurred. So it raised a little bit of a question mark. iPSCs are exciting and interesting, but maybe not ready for prime time just yet. So there's 2 ways to administer the cells. We can perform the cell injection technique, very attractive, very simple, but you could also conjugate the cells to a scaffold to affix your cells where you'd like them to be in a technique very similar to the DSECs that we're all very familiar with. You need a lot of different properties in your scaffold. You want to keep it as thin as possible because nobody wants to return to the old phase of big, thick DSECs from back 20 years ago. But you have to be prepared on the composition, and the idea of attaching the cells to the scaffold without losing them is crucial. So this was trailing a little bit behind the cell therapies until October of last year, when the first conjugated cell scaffold approach was placed in the first in man in Israel in October. So this is their first case, but they're running a single arm trial to treat patients with what they're calling a 3D printed endothelial keratoplasty. But the idea between the 3D printed culture ink is that there's a high density in the bioprinted ink. So the idea is to get a lot of cells exactly where you want it. And they're calling this PVEC, which is precise vision endothelial keratoplasty. The results for these cases are not yet out. But in parallel, Singapore is obviously pulling up speed with TEEK, which is tissue engineered endothelial keratoplasty. They're in clinical trials, but I don't have any data to share from that group. It is expected in 2027. Running away a little bit from the complicated cellular therapies, well, what about just keeping it really easy? with a no cellular implant. And in that area, already in the market, we have the Ion Endo Art, which is a simple, almost like a contact lens type material, which stops diffusion of water through the cornea. It's not as good as the real living tissue, but in very complicated cases that are likely to reject living tissue, this can be a real way to improve vision without taking a major risk. You see that you can manipulate the piece of plastic. There's no cells on it. You couldn't do this to a DSEC or a DMEC, but you can introduce this layer in and you can give these patients some degree of visual improvement with only a small piece of plastic. This is a different concept, cheaper, simpler, off the shelf. So it could be for the right patient. We published the first case doing it under a rejected PKP, and those patients did quite well. So what's the future? A lot of exciting things are happening, but donor scarcity seems to be what drives this advancement to regenerative medicine. But if it's donor scarcity we want to handle, then we need something cheap, mobile, transportable, and globalizable to actually address those patients, because the patients not getting graft tissue now are not likely to be served by a very expensive treatment. So we asked, what do corneal surgeons themselves want? We recently published an article in Cornea where we surveyed over 100 corneal surgeons, and thanks again to our participating parties, including Professor Romano, where we saw severe shortage is one of the biggest problems. Corneal surgeons suggested that the most promising approach for the future, on the left here, is the endothelial cell injection. 60% of respondents wanted to go for the cell injection, and the biggest concerns were regulatory hurdles and, of course, costs. If you look at those cell therapies, the current strategies, DSEC, DMEC, are cheap. They're excellent value and they're cheap in comparison. When we asked surgeons what their preferred cell source was, the most didn't mind, as long as the cells were safe and validated. They didn't really mind whether it was iPSC or cultured expansion. The last most interesting question on that was, do you think it needs a corneal surgeon, or could it be done by comprehensive ophthalmologists? And 82% said it needs to be done by corneal surgeons. Although I will bear in mind, this was a survey of corneal surgeons. So if we ask the generalists, it could be different. So in the future, if we extend the timeline, you could have synthetics, PVECs, cell therapies, bioengineers, but I think you'll probably have iPSCs much further into the future. So thank you so much for your attention, and forgive the speed at it. And if anyone is in London for the ESCRS, we're all very happy to invite you to that session. Thank you so much.
Thank you so much, ma'am. Dr. Nidhi ma'am is unable to join the meeting again. So, and Dr. Namrata ma'am, would you conclude the session, as we have the next session at 6 o'clock?
Yeah, surely, Nidhi. I think all the speakers, although I did not hear the ones who were there initially, but I think it was a great session. And I would particularly like to thank all the speakers from different time zones in different countries who've actually joined and made it happen. And ours was a truly international session because all the speakers were international. So thank you so much for joining, and we hope to have you on another platform at another time, and hope to meet you in other conferences. So thank you so much, everyone, for your time and for your contributions. Thank you.
I would request all speakers to just turn on their cameras so we can have a group photo. Great.
Thank you, everyone.
Thank you.
And thank you, Namrata ma'am. I know that you're already traveling and juggling between all the sessions. So thank you, ma'am. Thank you for the session.
Bye.
Thank you. Bye, Vito. Thank you. And thank you,
Bye.
Mohit.
Thank you.
Thank you so
Dr.
much.
Sharma. Thank you.
Thank you, Shosha. Thank you.
I would like to
Rashmin, sir,
hand
over
over
to you.
the session to the next coordinator for the next session.
Right. So we have Dr. Rashmin, sir. Rashmin, sir, we have with us Dr. Anna and Dr. Kshitij were there to coordinate and help you out. with whatever you require. And I'm right here if anything is needed.
All right. Thank you, Rolika. Can we go ahead and start the session?
Yes, at 6 o'clock, if you would like, we can proceed.
All right. Thank you so much. On behalf of All India Ophthalmological Society, it's a pleasure to welcome you all to this session on optic neuritis, status 2026. We'd like to thank AIOS, Dr. Santosh, and the entire team for this kind invite. It's an absolute pleasure now to introduce the moderator for the evening, Dr. Mahesh Kumar. Dr. Mahesh is the Director of Neuro-Ophthalmology at Arvind Eye Care System, and he also is the Chief Editor of Indian Journal of Neuro-Ophthalmology. Over to you, Dr. Mahesh.
Thank you, Dr. Rashmin, and I thank the All India Ophthalmology Society for providing this platform. So, Dr. Rashmin, President of INOS, has done a great job in putting up these program schedules, and I would like to welcome him, President of INOS, and he's a consultant neuro-ophthalmologist at the Center of Sight, Hyderabad. And I would like to welcome Dr. Ambika in absentia, Senior Consultant, Department of Neuro-Ophthalmology, Netralia, Chennai.
अच्छा ठीक है.
And so I would also like to introduce my other esteemed panelists, Dr. Hemalini Samant, who is an eminent neuro-ophthalmologist and pediatric ophthalmologist from Mumbai. Another esteemed neuro-ophthalmologist, Dr. Jyoti Matalia, who is also a pediatric neuro-ophthalmologist, joins from Narayan Netralia, Bangalore. And finally, we have Professor Rohit Saxena, the Professor of Ophthalmology at the All India Institute of Medical Sciences, New Delhi. So these esteemed panelists, we would like to invite first speaker, Professor Clement Tan, who will be speaking on how do I investigate a case of optic neuritis. Dr. Clement Tan is a senior consultant, professor, and head of the neuro-ophthalmology services at the National University Hospital at Singapore. Welcome, Professor Tan. On to your talk.
Good evening, and thank you very much for inviting me to speak this evening at this Congress. Can you see my slides?
Yes, we can.
Okay, fantastic. So thank you once again for asking me to share on this topic about how I investigate a case of optic neuritis. I have no relevant financial disclosures in this respect. And so when faced with a patient with a possible optic neuritis, there are a few thoughts going through my head at that time. The first, of course, is this actually an optic neuritis, right? Are we seeing a patient with an acute presentation, or is the question that's put to us one of a previous optic neuritis? In other words, the patient has presented with acute symptoms sometime in the past, and now the question is, was that previous event an optic neuritis? The second set of thoughts going through my head was in my head is, well, which of the following categories is the patient likely to fall into? Is this a neuroinflammatory disease, and that besides including those that have brain and spinal cord lesions, is this a neuroinflammatory disease that's just confined to the optic nerve? Or is it associated with other systemic autoimmune diseases, such as the ANCA-associated vasculitis, ankylosing spondylitis, Behçet's, IgG4, sarcoid, and so on and so forth? And of course, you mustn't forget infection, post-infectious optic neuritis, maybe a post-vaccination optic neuritis. And although I did not put in the list here, at the back of our minds is always, is this a compressive lesion or a cancer of some sort? The first thought in my mind is always get an MRI, right? And the MRI being the MRI being
I would request
the main tool that we have to use. And of course, when faced with a patient, especially with an acute optic neuritis, we do know that there are certain features that suggest one diagnosis or another, such as a short segment being more associated with multiple sclerosis, a long segment, posterior segment, or chiasmal lesions being associated with NMOSD, perineuritis with MOG, and so on, right? And of course, you hope that the MRI, or I hope that the MRI gives me clues to make that decision, right? But of course, we also understand that although these are suggestive of, they are not necessarily diagnostic of. And so this will be a nice case which has classically got posterior optic nerve, bilateral posterior optic nerve, and chiasmal involvement, suggesting that this was NMO spectrum disorder. And then this patient with perineural enhancement and fat stranding, extensive fat stranding, is suggestive of Molk disease. And so these, when you see these, we start to make a little bet and say, well, is this the disease that I'm thinking of? But there are other MRI clues, which are sometimes easy to find and sometimes not so easy to find. Area postrema is associated with NMO-SD, but I must say that I've often found it really difficult to find the lesion on the MRI, even if the patient is symptomatic. Acute disseminated encephalomyelitis, especially in a child, may be associated with Molk disease. And we have quite a number of MRI features that may be suggestive of multiple sclerosis, periventricular plaques, Dawson's fingers, and the new ones, the central vein sign, which is the bottom left picture you see there, and the paramagnetic rim lesions, which is the bottom right picture on the screen. What about a spinal MRI? I don't usually order this in the first instance, although the neurologists that I work with are often very eager to order the spine MRI, and I can understand why, right? It lends to trying to define the whole of the disease spectrum, particularly if the original brain and orbit MRI shows contrast enhancing optic nerve. Then you want to see if the spine is also involved. So do consider that. I do consider that too. But the next thing, of course, as the patient is being prepped for the MRI, is to ask, and especially once the MRI comes back showing contrast enhancement of the optic nerves, is to ask, well, what kind of blood tests should we order? And I'd say in the case of an acute optic neuritis presenting, for the first time with acute symptoms, the classic features of a optic neuritis and the MRI that shows the contrast enhancement, even before the MRI is out, sometimes we will send off the anti-aquaporin 4 and anti-Molk antibodies because as it turns out, they are fairly common, and getting them back early helps to make some of the decisions on the treatment. There are certain circumstances in which I will consider other antibodies. So in cancer patients, although aquaporin 4 can be associated with cancer patients, I will think of CRIM5. If there's a meningoencephalitis, I think maybe of sending off the GFAP. And if there are other features in the history that are suggestive, I might order the rest of the autoimmune workup. Not forgetting, of course, TB and syphilis. I do sometimes get anxious and order many things up front because I'm afraid I'll forget. And if you forget for too long, antibodies may be suppressed by steroids in weeks or months. And so if you forget for too long and you realize you haven't got your results back, if I haven't got my results back, then I might have missed the window to investigate them. And of course, we often do what we like to call here a pre-steroid workup, which is to see if the patient has a latent infection that might flare up when we start to give high dose corticosteroids. What about CSF? Well, I guess I think about this a fair amount, especially when the etiology is uncertain. When it's an isolated optic neuritis with no other features to suggest which other condition it might be, I think the CSF is helpful because if you come back with CSF restricted oligoclonal bands or kappa-free light chains, which is the new thing, you might be led to thinking a bit more about MS, although you don't know that for sure yet because oligoclonal bands can occur in other neuroinflammatory disease. When it's not really certain, and especially when the two major antibodies are negative, and the brain does not give you any further clues, I think it's useful to go ahead and look for infections because they are common in this part of the world. And if there is even a hint of suspicion of a malignancy, especially when the contrast enhancement around the nerves is not very vivid, I would consider the CSF for flow cytometry to look for lymphoma. What about the role of OCT? This has been talked much about, and I must say that I'm victim to the hype and, will fire off the OCT as a baseline investigation anyway. I think in the acute setting, the role is a little less certain, except perhaps when there is minimal disc swelling and not really certain, and the OCTs help you decide whether there is true disc swelling or not. And it is reported that sometime down the line in the patient's disease course, if I'm assessing a patient later on, that within 3 months of an acute presentation, an inter-eye difference in the macular ganglion cell IPL or in the peripapillary retinal nerve fiber layer may indicate a previous optic neuritis. And then we come, of course, to electrophysiology, and I'm a great fan of electrophysiology, but really, if there's a clear clinical scenario, there's no real need for any of it. But I do find it useful, and I do order it when, for example, I'm sent a patient with multiple sclerosis, NMO, or MOG disease, who has presented with other symptoms such as transverse myelitis, but no history of any eye complaints, and I'm asked to screen for previous eye disease. And I think the electrophysiology nicely complements the OCT because, OCT on its own, if it just shows thinning, sometimes you're not certain whether that's sufficient to make a diagnosis of a previous optic neuritis. Bear in mind, of course, that electrophysiology is much more than just a pattern VEP. And one should complete the whole suite of investigations with a flash VEP, and I definitely need the pattern ERGs, and I would always prefer to have the full field ERGs as well in a case where I am uncertain whether the patient that presents is with visual loss has a retinopathy, macular, optic neuropathy, because there are no acute signs anymore, and the MRI is normal. So I thought I'd round up with 2 cases. This is a 62-year-old woman with a history of polycythemia. She has a history of longitudinally extensive transverse myelitis. She was put on mycophenolate, but decided to stop it on her own. And a hematologist called us up to say that her vision was going down in the left eye, and her vision was 618 in that eye and 612 in the other eye. She had no complaints about her right eye, only of the left. And of course, you see the visual field defect in the left eye, but there's also a visual field defect in the right eye. On the OCTs, there is swelling of the left optic disc. The right optic disc, the peripapillary retinal nerve fiber layer, does look a little bit suspiciously thin, and there is some thinning on the macular GCIPL. But on the MRIs, there really only was contrast enhancement of the left optic nerve. She was treated with IV methylprednisolone plasma exchange, and she went on to ravulizumab as well. But 3 months later, when we reviewed her, you can see here that the visual fields in the right eye have fully recovered. The visual field in the left eye have improved. The macular GCIPL thinning on the right is still there, as well as the thinning on the retinal nerve fiber layer. And the left side has now got a diffuse central thinning, as well as thinning of the peripapillary retinal nerve fiber layer. So I do think that this patient did have possibly an old optic neuritis on the right eye as well, whether it was just before the left eye presented, making it bilateral, or much further back and she had a recurrence. It is hard to tell. Suffice it to say, she's clearly had quite a few episodes of inflammation of her central nervous system, and long-term prophylaxis is certainly something that she will need, and I think she's finally come to accept that. And then to end off this other patient here, a 21-year-old woman who was managed in another hospital prior to coming to us. She had blurred vision in the right eye for 3 days and a visual acuity of 612, the swollen right optic disc, a dense visual field defect, no thinning of the ganglion cell IPL at that time, and not a whole lot of swelling of the retinal nerve fiber layer, the peripapillary retinal nerve fiber layer. The MRIs, they showed contrast enhancement of the right optic nerve, but not the left. Although, when you look at the visual fields, you wonder if the left nerve was involved as well. She was treated with IV methylprednisolone and then put on a tailing dose of oral steroids, during which time her aquaporin antibodies came back as positive. But while the steroids were being tapered, her vision in the right eye dropped drastically to count fingers. You can see that the visual field defect is now fairly central, although the field defect in the left eye seems to have cleared up. At the same time, you can see in the macular ganglion cell IPL that the left shows some inferior thinning and the right has this real diffuse thinning there. What is instructive though is that when we repeated her MRIs prior to starting her on plasma exchange, that there was barely any contrast enhancement left in the optic nerves. And so this case often reminds me that a couple of weeks after the initial presentation, the MRI can sometimes show minimal changes or even be negative. And so you really will catch it really when we do the MRIs in the acute phase. And so to conclude, when faced with a patient with a possible optic neuritis, the first question is, what is the clinical scenario? Is this an acute optic neuritis, or am I just asked to evaluate something that might be chronic? What is the rest of the history, the examination? What does it lead me to think about, right? I think MRIs, I almost can't live without the MRIs in managing these patients because they give so much information that is hard to do without them. It's useful, and I'm learning over the years to read the MRIs a little better on my own. Blood investigations, will launch quite a few of them, especially the aquaporin 4 and the MOG antibodies. The CSF, depending on the scenario, OCTs are helpful, and electrophysiology in specific circumstances. And with that, thank you very much for your attention. And once again, thank you for this kind invitation to participate.
Thank you very much, Clement. That was a very comprehensive overview of the most essential investigations in optic neuritis. So I would request the panelists to give their comments. To start with Hemalini.
Thank you, Mahesh. I think Dr. Clement has very beautifully summarized everything. I really don't have anything to add to what he said, but just a little comment that, many times general ophthalmologists tend to do CT scans for optic neuritis. And Dr. Clement has very beautifully outlined that there's no role of CT scan, that you should do an MRI with a contrast in all cases of suspected optic neuritis.
Thank you, Hema. Any other comments, Jyoti or Dr. Rohit?
I think what Dr. Hemalini also I would like to say that very well explained. In our scenario, I have seen a situation where we got a patient who appeared to have optic neuritis, and when we did the MRI scan, we actually got a cysticercosis pressing on the optic nerve through the enlargement of the lateral rectus. So I think we should be very specific about what the patient is presenting with, what are the clinical, but rightly said, CT scan will not work here, and MRI would really help us to pick out what this is. So very important. And I think this macular GCC IPL is very important that you do. Many a times you're able to pick up, they correlate with the visual field defects, and sometimes in some cases they resolve very well, sometimes they don't, but that gives us a fair idea about how the patient's eventual visual acuity would be. So I think these are the basic investigations, but rightly said, need to do what is important, not that we have to do all of them. When we see something specifically, just order those rightly so that we are able to achieve a proper diagnosis.
Thank you, Dr. Jyoti. Dr. Rohit, any comments?
No, I don't think so. Clement has beautifully talked about it. In our Indian scenario, we need to be a little more aggressively looking for infections because that's something that often does surprise us when we see. As also, we do tend to do a chest X-ray just to rule out an underlying tuberculosis. One, because of its possible remote association with the presentation, and two, of course, you don't want to have a missed active tuberculosis that flares up because of your steroid. Other than that, I, as has been well discussed, MRI and blood investigations. Again, NMO, MOG. The moment you feel there is even a slight bit of atypicality and there is not adequate recovery, you must always think in terms of getting a blood test done. But great presentation. Thanks, Clement.
So thanks, Dr. Rohit. Thanks, Dr. Clement, once again for a great presentation. Next, I'm very happy to invite Dr. John Chen. who will be speaking on management of optic neuritis. Dr. John Chen is a neuro-ophthalmologist and he's a professor of ophthalmology and neurology at Mayo Clinic, Rochester, USA. He has done great work on NMO and MOGAD, and it's a great privilege to hear you speak, Dr. John. Please present your case.
Well, thank you so much for that kind introduction and the invitation to speak here today. Dr. Tan gave a wonderful introduction on optic neuritis and the various etiologies. And so now we're just going to go and step next to the management of these patients. And I'm going to focus on demyelinating optic neuritis. And so I would just start with a case here. This is a 34-year-old female with subacute vision loss in the right eye, pain with eye movements. And after listening to Dr. Tan's talk, we see there's a little bit of disc edema, the vision is a little bit down, and we're suspecting optic neuritis with the pain with eye movements. As Dr. Clement said, the next thing we want is that MRI. And so when we get an MRI, we see enhancement of the optic nerve, and this confirms our diagnosis of optic neuritis. As Dr. Tan had mentioned, it's important to get an MRI of the brain to look for other lesions that might suggest particular etiologies. And this patient has these scattered T2 lesions, very suggestive of multiple sclerosis. And so now the question is, what is going to be the treatment? Is it no treatment? Do we offer IVMP? Do we definitely treat with IVMP? And we're going to come back to this case at the end of the talk. Now we're going to have a very similar scenario, but I'm going to change a few things. One is the vision is now 2400, not 2040, and we don't see MS lesions now. Does that change how we're going to approach this patient in terms of the acute treatment? And this brings up the question, do we use something called plasma exchange? And if so, when? So I'm just going to step through the various demyelinating optic neuritis attacks and really focus on essentially prognosis, because that kind of helps determine how aggressively we have to be. We'll start off with MS, which is the most common cause of MS, at least in the US. MS tends to cause moderate vision loss, not necessarily as severe as some of the other ones, with a median visual acuity nadir of 20/70, but 36% can be 2200 or worse. The vast majority of patients with MS optic neuritis do recover, median final visual acuity of 20/20, and only 3% 2200 or worse. In terms of treatment for typical and MS optic neuritis, we actually know a lot about it because we have a randomized clinical trial, the optic neuritis treatment trial, that was published in 1992 in the New England Journal of Medicine. What's interesting is it found that high-dose IV methylprednisolone led to faster recovery, but did not actually change the ultimate outcome. And surprisingly, it found that low-dose oral prednisone did not help, and it potentially increased relapse rate. And so essentially, these were the conclusions. Again, this is back in 1993, where treatment with high-dose corticosteroids accelerates rate of recovery. The decision to prescribe steroids or not can be made for each patient on an individual basis. And oral prednisone alone at a low dose should not be prescribed. And again, this is for typical MS optic neuritis. Since then, there's been some studies comparing actually high-dose IV methylprednisolone to high-dose oral prednisone, the bioequivalent. And essentially, they're equivalent. And so that's important. And so for MS or typical optic neuritis, we can do IV methylprednisolone or high-dose oral prednisone, 1,250 milligrams. And that will quicken recovery, but may not change the ultimate outcome. And so that's what we know about the ONTT and MS. But what's interesting is when we look back at the patients in the ONTT, which is in the US, a predominantly Caucasian population, we had about a third of the patients left, and we checked for aquaporin-4 and MOG antibodies, and you can see that none of these were aquaporin-4, only 2% were MOG. And what that means is that the ONTT provides excellent details for MS and typical optic neuritis, but not so much for NMOSD and MOGAD. So let's talk about NMOSD next. We've got the biomarker for aquaporin-4, and when you compare how NMO presents compared to MS, NMO presents with much worse vision, median visual acuity of count fingers, and the outcomes are worse. You can see here a median visual acuity of 2100, 46% of patients end up 2200 or worse compared to 3% for MS. So the bottom line is NMOSD causes blindness, and we have to treat these patients very aggressively because we want to avoid that blindness. There's been multiple studies showing that early steroids are associated with improved outcomes with NMOSD. And so if you have a patient and you're suspecting NMO optic neuritis, you have to treat them with IV steroids. We can't just quote the ONTT and say, well, you're going to get better whether we treat you with steroids or not. You have to treat with early steroids. And it's early. We think that time is vision, and the earlier you treat, the better. And then there's also plasma exchange. And Dr. Tan had mentioned his case of NMOSD that they treated with plasma exchange. With plasma exchange, essentially what we're doing is we're taking the patient's blood and removing the pathologic antibodies and cytokines and then giving them back replacement human albumin. And so it's a way of rapidly removing these pathologic antibodies. And the largest study on plasma exchange for optic neuritis to date was this large international retrospective study of almost 400 optic neuritis attacks. Almost 100 were NMOSD, 75 aquaporin-4 positive. And again, bear in mind that this is retrospective. But essentially what we found is that patients who were treated with plasma exchange had a very severe vision when they were being treated with plasma exchange. We're treating with Plex because of the poor vision, so visual acuity of count fingers. And you can see here, after plasma exchange, patients with aquaporin-4 positive NMOSD optic neuritis had reached a median visual acuity of 20/30. And if you compare that to what we think is the natural history of 2100, this seems like this is leading to better outcomes. And therefore, we highly recommend plasma exchange for patients with NMOSD. Multiple other retrospective studies have suggested that plasma exchange improves any attack from NMOSD. When it comes to plasma exchange and the use in optic neuritis in the US, you can see here that the rate of plasma exchange is really going up quite astronomically. There's been a tenfold increase over the past 20 years, but really the vast majority of the increase has been over the past 5 and 10 years. And I think this rate continues to go up. We are using plasma exchange much, much more, not just for NMOSD, but for any severe optic neuritis. What all the retrospective studies are showing is that early plasma exchange is associated with better outcomes. You can see here that this is a graph. This is time to plasma exchange. And if you have plasma exchange within 7 days, you've got a 63% chance of getting back to 20/20. Whereas if you have a patient treated after 28 days, you can see here only a 22% chance of having complete recovery. And so multiple studies have suggested that early Plex is associated with better visual outcomes with optic neuritis. The only drawback is these are retrospective. And what I mean by that is if you've got a patient who's presenting within 7 days, this patient could potentially get back to 20/20 with no treatment at all. And the ONTT showed that that happens in a lot of patients. And so there could potentially be a lot of bias in these retrospective studies. So ultimately what we need is a randomized clinical trial to answer that. And that's where the Timely Plex trial comes in. This is a PCORI-funded phase 3 randomized clinical trial where we're going to have 31 sites enrolling 200 patients with severe optic neuritis, and we're going to randomize them within 8 days of symptom onset to the traditional rescue Plex, where you get IV steroids, and if they don't recover, then you give them delayed rescue Plex at 14 days, or the early Plex approach where you get steroids and Plex simultaneously right at time of presentation. And this will ultimately answer, is early Plex truly helpful, and help guide us in terms of when to give Plex and how important it is for these patients. And again, this is a large randomized clinical trial that's being run in the US. And so we're definitely looking forward to this. For the last couple of minutes, I want to talk about MOGAD. Optic neuritis is the most common phenotype of MOGAD. And MOGAD presents with very severe vision loss. You can see here 2,600 at median. But the outcomes are so much better than NMOSD. We've got a median visual acuity of 20/20 afterwards, with only 5% ending up 2,200 or worse. And that's because these patients tend to be very steroid responsive. And multiple studies, again, have shown that early steroids leads to better outcomes. And again, these are retrospective, but again, the idea is time is vision. If you can catch them early, you can often lead to much better outcomes. And so when we have a patient with MOGAD optic neuritis, we treat them with IV methylprednisolone for 5 days. We also often do a prednisone taper over 1 to 3 months, usually more closer to 1 month, but many people in Europe do 3 to 6 months, even up to a year, because sometimes optic neuritis from MOGAD is not only steroid responsive, it's steroid dependent, where if you come off the steroids too fast, they'll have a relapse. We've shown multiple times that early treatment is associated with better outcomes with retrospective studies. And we have some prospective studies suggesting this as well, which I don't have time to get into. And we consider plasma exchange if it's severe and there's no recovery after high-dose corticosteroids. Going back to our paper here, you could see that we had almost 100 MOGAD patients. And what we found is that with MOGAD, patients tended to do very, very well with plasma exchange. Again, coming at count fingers, median visual acuity of essentially 20/25, 20/20. The drawback is, could these patients have recovered without plasma exchange? But it's certainly something that we employ if they don't respond to corticosteroids. And then what's very important is the chronic treatments are very different as well. And so that's why it's important to know the various causes of optic neuritis when you have one. So going back to this patient with likely MS, I think you could offer IV steroids. This patient, you don't know if they have MS. It doesn't really look like it. It could be MOGAD or NMOSD. So I would definitely treat with IV corticosteroids and immediate plex if aquaporin 4 positive, otherwise plex if they don't recover. Thank you for your attention.
Thank you, John. That was a great presentation and gave a very wide overview of the treatment options available. So can I ask Dr. Rashmin to give us a view on this?
Yeah, thank you, John. That was a fantastic presentation. And I think some of the points which John beautifully highlighted, especially, I think what comes through is our role as an ophthalmologist in the management of optic neuritis. We're no longer now limited to referring these patients to neurologists because we have an access to their visual acuity. We have an access to their optic disc status. We have an access to their visual field and OCT, which are contributory factors to making a diagnosis of antibody-mediated optic neuritis, which is much more common in our parts of the world. And as John highlighted, that early intervention with steroids and early plex can change not only their visual acuity, but also the potential neurological complications later. So I think that came through very well. So thank you, John, for that lovely talk. Thank you.
Jyoti, your comments?
I think he has really summarized everything beautifully. Just one question I had: if you're not able to get, they are all seronegative, you're not able to get any of the antibodies positive, do you still go ahead? How would your plan be in those situations where we are clinically suspecting, but we are not sure whether it is like MS or MOGAD or NMOSD? What would be the plan then?
Yeah, so the drawback early on is the antibodies sometimes take 1 to 2 weeks to come back. So you really have to make your decision in terms of treatment acutely. And so if it's severe, I don't offer them observation anymore. If it's severe, I'm going to treat them with high-dose corticosteroids, whether it's IV 1,000 milligrams of methylprednisolone or very, very high-dose oral prednisone 1,250 milligrams, because they might be NMO, they might be MOGAD. And then if they don't recover after 1 to 2 weeks, I'll add on plasma exchange. And so that's if I don't know what it is initially, or if I don't have antibody testing, I'm going to approach it the same way. And then really the antibody testing is very important for the chronic treatment, because the chronic treatments we didn't get a chance to talk about very much, but they're very, very different. So I think that's why it's so important to stratify the etiologies.
Yeah, okay. Yes, thank you. I think it's important that we need to treat them immediately, at least the acute cases, so that we prevent the longer complications. Yeah, thank you.
Dr. Mahesh, I have one question. May I ask?
Yes, Hemalini.
Sir, the question is that a lot of times neurologists here like to give IV methylprednisolone 1 gram for 3 days, and some of them decide to give it 1 gram for 5 days. And then if they're giving it for 5 days, then they do not do an oral taper of corticosteroids. Any comments on that?
Well, I think the last part cut off, but I think what the question is, if you give 5 days, what about the oral taper? I think it really depends on the etiology. And so if you're thinking MS, you could probably just do 5 days. You don't need the oral taper. If it's MOGAD, you're going to want to taper probably at least a month because, again, not only steroid responsive, but steroid dependent. And if they're NMO, I also do a prednisone taper because I don't want them to have another attack before we get the more definitive treatment like ravulizumab or one of these new FDA-approved medications. And so they're on steroids until I get a medicine working on board. And again, it's important to kind of pair up with your neuroimmunologist or neurologist to kind of help you with these chronic treatments. But yeah, every animal patient needs to be on chronic treatment, prednisone, until you get it started. Great question.
Good question. Dr. Rohit, any final word on this?
Just that a wonderful presentation, and just showing the evolving management plan that we have now. We've almost always become far more aggressive than we were earlier, because we've also seen that even if the presentation may be a bit typical to start with, you may have any one of these antibody positives in the long run. So you need to be very aggressive, even when the vision is not so severely affected as was presented in the first case by John. So I would say that if you have a diagnosis of optic neuritis, you need to seriously think in terms of giving IV methylprednisolone and get an MRI done. And seriously, it's the vision recovery probably that is now deciding whether you want to aggressively move towards plex, because as was mentioned, sometimes you don't get the results back so quickly enough. And even if it's negative, as John has mentioned, that it does a wonderful job with Plex, does a wonderful job even in MS. Although again, the disclaimer that it may recover, but then you see it recover so quickly within the period of intervention, which is, I'm sure, really nice feel for both the doctor and the patient. So I think all of us are moving very aggressively towards intervening in in all these patients very actively. Great presentation and wonderfully summarized. Like, it's, I think, wonderfully clear that we're moving more aggressively towards intervention. Thanks.
Thank you, John, and that is a great presentation, and we have a comprehensive idea now on the management of optic neuritis. Thank you very much. And next, I would like to invite Dr. Prem Subramaniam to speak on newer frontiers in diagnosis and management of optic neuritis. So Dr. Prem is a well-known neuro-ophthalmologist in All India Ophthalmic Society. He's a regular visitor to India, and he's a chief of neuro-ophthalmology and vice chair of academic affairs at the University of Colorado, Denver, USA. So I'm very happy to welcome you, Prem.
Thank you so much. And so I'm going to build upon what John just wonderfully presented about the treatment of optic neuritis and talk more about some emerging therapies that, again, dovetail with what was just being discussed. I am participating in a number of the clinical trials I will mention, but I have no relevant financial disclosures on that matter. John just went over the existing therapies, with corticosteroids still being the mainstay of treatment. He didn't mention IVIG, which is sometimes used as an adjunct in the initial treatment and sometimes in the longer-term treatment of these patients as well. I'll talk a little bit more about plasmapheresis just in terms of going forward with that study design for timely plex that John mentioned, because I think it's really a well-designed study that's going to help our understanding of how we treat this disease acutely. There are biological therapies, as he mentioned, for NMOSD that are aimed at suppressing the production of AQP4 antibody, but it's very important to remember that these really are indicated for chronic therapy and prevention of further disease. One of the therapies aimed at C5, complement C5 inhibition, may have a role in the acute phase, but we don't know that yet, and there's still studies going on to look at that. And MS disease-modifying therapies remain very important in preventing future demyelinating events in patients who have MS, and MS remains common throughout the world, including in India. John went through the rationale and background for plasma exchange. I won't spend much time on this, but just to state that, as he described, the usage of this has really increased as these retrospective analyses have demonstrated that there may be utility. And in fact, what he didn't mention, that he was the first author on a paper that was commissioned by the American Academy of Ophthalmology through its ophthalmic technology assessment system. And this group of neuro-ophthalmologists evaluated the available data around plasma exchange right now and discovered that only 2 studies really met the level 2 of evidence, and the remainder of 10 studies were really case series. And again, these are all retrospective studies, as was mentioned. but they do point to the potential role of plasma exchange in improving the outcomes of patients with optic neuritis, particularly, as John mentioned, when that is done early. But he also mentioned the bias that goes into this, and not just the bias that some patients who present early may get the treatment and then recover, but we as doctors are more likely to do plasma exchange on those patients who have worse visual acuity. And so if we randomize those patients to getting Plex or not, what do we find? And so that's really the study design. And again, I'm just going to mention that briefly because I think it is worth understanding how this is going to advance our knowledge. It's a randomized open label study. So all patients get treatment. There's no placebo arm. And there are 31 sites in the US. Our university is one of the sites as well, with my colleague and Jeff Bennett and I working on this project. We are, of course, focused on optic neuritis patients, but transverse myelitis patients are eligible as well. And the diagram on the right shows you that as long as patients are eligible, presenting within 8 days of vision loss with 2200 or worse vision in the affected eye, severe optic neuritis from any cause, it could be MS, unknown, or MOGAD or NMO, they're going to be randomized to Plex plus steroid immediately, 5 cycles of Plex along with the standard corticosteroid by IV, or corticosteroid alone, and then evaluated at 14 days, where at that point, if they have poor responses, you can see they then get Plex. That's between 12 and 16 days, actually. But if they had a good response, they're not going to get Plex. And then the final outcome is going to be assessed at 6 months. And I think this really has a very good chance of helping us to understand really what the role of Plex is. Does concurrent Plex really benefit our patients? Because there are some risks associated with it. You have to put in a central line. It's large volumes of exchange of the plasma. And so it's not without risk. But I'll move from there to some other strategies that are evolving now. And one in particular comes back to the idea of neuroprotection. We, in these other strategies, are trying to prevent damage, and that is a form of neuroprotection. But there has been ongoing research as to whether we can use pharmaceuticals in association with corticosteroids that might help us to prevent neuronal damage and improve neuronal survival. And so Privosegtor is a novel synthetic peptide that in animal studies was shown to prevent RGC damage and improve mobility in models of demyelinating disease. And it was given orphan drug designation by the FDA and is potentially on a fast track to be studied as to its benefit in our patients with demyelinating disease and in particular optic neuritis. And the figure demonstrates for you how this might work at the molecular level. And interestingly, this peptide does seem to activate the serum glucocorticoid kinase pathway. And so you might think that it's not different than steroids, but as I'll show you, when given in conjunction with steroids, it does seem to have an additional benefit. And that is likely because of its effect as shown here on the nuclear expression of certain genes and upregulation of factors like ciliary neurotrophic factor, CNTF, that then lead to oligodendrocyte activation and a pathway that is separate from corticosteroids that can help our patients. And so these data were presented last year. And remember, these are not peer-reviewed data yet. These are presented at meetings, so keep that in mind. But in this study, patients were randomized either to standard corticosteroid therapy for 5 days of IV methylprednisolone versus infusion of the drug along with the 5 days of steroid. And low contrast visual acuity was judged as a key efficacy endpoint. Of course, the safety was the primary endpoint. And ultimately, what was demonstrated in this phase 2 study, so again, not randomized, is except for Privosegtor versus the steroid, that there was a marked reduction in loss of GCIPL. You still had loss in the patients who were treated with this experimental drug, but it was 43% improved compared to those patients who were treated with steroid. Again, small numbers, keep that in mind, but promising. And similarly, RNFL at 3 as well as 6 months showed a significant difference in the RNFL loss in those who were treated with Privosegtor versus those who were not. And again, the idea is that you are giving a neuroprotective drug that is then allowing an improvement in visual function. I mentioned this is low contrast visual acuity. Remember, gaining 15 letters of low contrast visual acuity is actually pretty amazing. And I think this was very surprising to those of us who take care of patients with MS and optic neuritis or all types of optic neuritis, because the loss of low contrast visual acuity is one of the main things that bothers these patients. And just briefly mentioning, there's now a phase 3 study called Pioneer 1 to treat patients with acute optic neuritis who don't have MS. It will go on to those who do have MS as well. And we are one of the institutions participating in this. And John is also participating in this study. And this is, again, a phase 3 study to see if indeed this effect that was observed is more widespread in a larger population of patients with optic neuritis. I'll finish by talking a little bit more about preventative strategies in MOGAD. So John mentioned the acute treatment of patients with MOGAD and how a long dose of corticosteroid therapy is often done to help prevent relapses. Unlike NMOSD, where we know if you are AQP4 positive, if you do not take a highly effective immunosuppressive therapy, your risk of developing a relapse of your disease is exceptionally high, 70% or more. In MOGAD, it's a little more uncertain. About half the patients who have a MOGAD optic neuritis will not have another event, but then half will, and they will have relapses. And those patients who have relapses, we don't yet know what the best therapy is. Work by John and others has suggested that IVIG may be a very beneficial therapy, but that B-cell suppression, as we do primarily in NMO, may not be the most effective strategy. And so there are 2 phase 3 trials looking at 2 other pathways. One, IL-6 receptor antagonism. Satralizumab is already FDA approved for the treatment of NMOSD by interfering with the activity of the IL-6 receptor. And patients who had MOGAD with recent relapses or repeated relapses were enrolled into this study, and they could continue their baseline immunosuppression if they were on it. And then they were either randomized to satralizumab treatment or placebo. And the outcome that was measured was, can you reduce the number of relapses? And you can see on the right side, though, these data were just presented last month at the AAN meeting, showing that there was a marked reduction in relapses in those patients treated with satralizumab compared to those who don't. But keep in mind that the overall relapse rate was relatively low. And so I think that's a very important question, or very important issue to remember. But satralizumab also is very well tolerated. You can see the side effect profile there is consistent with NMOSD, where patients may have a slightly increased risk of certain infections like pneumonia, but otherwise, really, it's a well-tolerated drug. And then finally, an FcRn inhibition strategy is being studied for the treatment of these patients with MOGAD. These data have not been released yet, but they will be hopefully sometime this year. And again, the idea is to reduce the likelihood of relapse in a population of patients with MOGAD who are at high risk for relapse, because again, not all patients are. It's a drug, again, that is currently being used for diseases like myasthenia gravis. The FcRn depletion strategy seems to be well tolerated by our patients, and we will see what the results of this phase 3 trial show us, and it will give us more options to treat our patients. Remyelination therapy, I will mention very briefly because it has a long and spotty history, very complicated slide. Essentially, on the left, a strategy to try to enhance the activity of oligodendrocyte precursor cells didn't work. An antihistamine activation strategy in the center is currently being studied to see what its efficacy might be. And then finally, an interesting new strategy of catalytic gold nanocrystals has shown some interesting positive data with improvement in VEP that may give us some new treatment. So ultimately, again, we're trying to move beyond steroids, study neuroprotective strategies to repair damage. And I hope that this gives us more options for our patients in the future. Thank you.
Thank you, Prem. Great options available in the future, I suppose, for the management of optic neuritis. Hope some of these work out. And any comments from the panelists? Any of the panelists?
No, great. I mean, excellent presentation, Prem. It was wonderful to see that there are multiple drugs now coming in the horizon, particularly to reduce the rate of relapse in MOGAD, which can be quite challenging. How would they, kind of work with in a patient who is kind of steroid dependent in a MOGAD case?
Yeah, I think the idea, Rohit, is that by instituting one of these other drugs, you would then be able to initiate a steroid taper. And as you said, these patients, the idea is that this is complementary to the steroid therapy. And so in the studies that are being done right now, although they didn't necessarily take the patient off of baseline immunosuppression like that, the theory, just like in NMO, would be that you're able to substitute this therapy for their corticosteroids.
Any other comments, questions? So if that is all, thank you very much, Prem, for once again giving us a great overview of the newer modalities. So with that, I would like to invite our next presenter to present an interesting case, Dr. Virender Sachdeva, who's a neuro-ophthalmologist and squint surgeon, as well as pediatric ophthalmologist at L.V. Prasad Eye Institute, Visakhapatnam. Virender.
Thank you, Dr. Mahesh. Are my slides visible?
Yes, they are. Yeah.
Thank you. So I think the great talks by Dr. Clement and Dr. John and Dr. Prem have set up the things for us to discuss few of the common presentations that we see. This is a series of two brief cases of challenging cases of optic neuritis that we came across. This is a first case, a 33-year-old female presented to us in July 2025 with complaints of acute onset right eye, sudden onset decrease in vision from 2 weeks prior. So she had associated headaches and mild discomfort on eye movements, and prior ophthalmology and neurology consult had been taken. She was diagnosed as retropulpar neuritis elsewhere, and the MRI brain was documented to be normal. She was already given 5 doses of IV-MP, followed and was on tapering doses of oral steroids at the time of presentation. Of note, there was no history of any febrile illness, no history of vaccination, no frank periorbital pain, and there were no other associated constitutional or neurological symptoms that were contributing. On examination, the visual acuity was still markedly depressed despite IV-MP therapy at counting finger right in the right eye and 20/20 in the left eye. We can see that actually there is a small area of RNFL obscuration suggestive of disc edema. Rest of the in the right eye actually, and the rest of the retina is normal in both eyes. Color vision was markedly depressed in right eye, and there was grade 3 RAPD in the right eye. So at this time of presentation, we obtained visual fields, which showed that in the right eye, there was advanced field effect. We can see only stimulus 5 fields in right eye, which are markedly depressed. And in the left eye, there is a nasal field effect. The OCT showed persistent RNFL thickness increase in the right eye, and the macula was unremarkable. So we repeated the MRI, and this showed actually on the presence of a large hyperintense lesion seen in the axial T2 weighted image as well as in the post-contrast imaging. We can see that there is thickening and enhancement of the optic nerve in the right side. The rest of the brain parenchyma was normal, not showing any signs of any demyelination in the brain or in the entire spine screening. At this point of time, we obtained further workup with antibodies, which is definitely needed, as already suggested in the previous talks. So aquaporin antibodies and MOG antibodies done by cell-based assay were negative. The CSF for oligoclonal bands was also negative. So we labeled our patient at this point of time as acute optic neuritis, which was showing poor recovery after initial therapy. And patient was non-MS by the workup and double seronegative. So it's a double seronegative non-MS optic neuritis. We continued the patient on oral steroids and decided to keep on close follow-up. And this is at 1 month follow-up. The patient showed good recovery, but there was a mild temporal pallor and grade 1 RAPD. This is the visual fields showing significant improvement in the visual fields of the patient. And this is a timeline of the patient showing over the course of the next 3.5 months, patient had regained full visual function. I will just briefly take you through the second case. It's a 24-year-old male presented to us with bilateral acute vision loss with pain on eye movements. Visual acuity was counting fingers in the right eye and left eye no light perception. at the time of presentation. Patient had already been treated again by IVMP, 1 gram, 3 doses given, and there was no recovery. Patient was referred to us as atypical optic neuritis or query labor hereditary optic neuropathy, given the young age and male gender. But on presentation, we can see that in fundus, there is RNFL obscuration in both eyes with the disc edema. There is presence of a small splinter hemorrhage in the right eye. And the patient was fitting into a possibly a poor recovery optic neuritis. We obtained further workup of the patient with MRI brain or PETs with contrast, MRI brain, as well as serum aquaporin and MOG antibodies. So MRI brain, I will show the pictures. Next slide. MRI brain was normal, and aquaporin and MOG antibodies were again negative. So this was again a non-MS NMO MOG 00 negative optic neuritis. This is a presenting MRI of the patient showing the presence of enhancement along both optic nerves. So we decided, and the rest of the brain parenchyma was normal. MRI spine was also normal. So we continued the patient on 2 more doses of IV methylprednisolone and followed by Plex. So this is 10 days post Plex. The patient started to have improvement in the visual acuity, showing an improvement in the visual acuity to 20/80 in right eye, and left eye had regained to 20/20. Color vision was still depressed. We can see disc edema has almost resolved. And this is the visual fields at this point of time, showing presence of inferior arcuate depressed fields in both eyes. So along with the neurologist, we kept the patient on slow taper of oral steroids and started on rituximab, given the marked visual loss and poor recovery initially. And over the period of about another 6 months, following 2 doses of rituximab, the patient regained full visual function. So there are 2 cases presenting to us with advanced vision loss. One was unilateral, second had bilateral presentation. There were features of demyelinating optic neuritis on both sides. Both patients showed medium and long segment optic nerve lesions and slow but good recovery. So we looked at the literature if there are subgroups reported in them showing the presence of 00 negative optic neuritis, which is not fitting into MS, and NMO MOG negative. And we looked at our own series of about 98 eyes of 67 patients seen over a period of nearly 3.5 years. In our cohort of 330 patients, there were 67 patients, 330 eyes. We had about 98 eyes and giving a prevalence of about 20%. 16% were children, and there was no gender predilection. Most patients had presented with a sudden onset vision loss, followed by pain on eye movements, and other complaints were like headache. Majority did not have any other features of neurological discomfort, but 1 patient had seizures and 1 patient had ataxia. And on presentation, we saw that it was like a retrobulbar neuritis in majority, and about 29% of patients had temporal pallor at presentation, suggesting a prior episode might have happened, and disc edema was noted in 25%. Visual acuity showed a significant improvement over time from marked depression to significant improvement. Similarly, visual field showed significant improvement in majority of patients. We try to characterize the location of lesions. Brain lesions were noted in only 1 out of 67 eyes where we had full documented imaging. And there was almost 23% with anterior orbital lesion, 17% with long segment involvement, and 21% with posterior optic nerve involvement, and 9% had long segment involvement. So we try to characterize based on the imaging characteristics. Since brain lesions were found in only 1, it was not useful. MRI spine data was not available in all patients, but the distribution of the lesions, as I showed before, was quite widely spaced. So this is a concluding slide suggesting that it does come out as one of the most common forms seen in our own set of patients. They have a similar age of presentation like MS and NMO MOG disease. There was no gender predilection. Pain on eye movements was noted in only 1/3. They might profound dysfunction or visual dysfunction, but majority showed a good response to treatment, and recurrence was noted in only 3 to 12%. So I would like to open the case for discussion. What's your experience with similar profile of non-MS double seronegative optic neuritis? Do you work up them all for all the patients for further autoimmune diseases, ANA profile, serum ACE, GFAP antibodies today? How do you decide about need for plex, and what is the likely risk of recurrence in your experience?
Thank you, Virender. You have brought about some of the common problems sometimes we face in our day-to-day practice. So we'll take the questions to the panelists. Panelists, would you like to answer? Any one of the panelists?
Dr. Prem, Dr. John.
John? Yes, John.
Great cases, Brander. It's interesting because the first case was severe, didn't get plasma exchange, and still recovered. And the second case obviously was bilateral, so you're gonna be more aggressive, and they got plex and they recovered. But it just kind of shows to point. Let's say you had plex that first person, you would have said, "Gosh, my plex got him back to 2020," and yet he didn't get plex. So again, that's the importance of this timely plex trial to show, is plex truly important or not, which I talked about and Prem talked about. So that's why those randomized clinical trials are important. That's one. Two, it's interesting. So when we looked at our double seronegative, we used a population-based study. We found that almost a third of optic neuritis remains idiopathic, as in not MS, NMO, or MOG. We looked at outcomes. We found that MS and MOG tend to do pretty well. NMO does pretty poorly. And for our double seronegative optic neuritis, it actually came in the middle. I suspect there's going to be some antibody floating around that we just don't know yet that's going to explain a large portion of them. And it's probably going to be in between in terms of severity. In terms of workup, I do check everything. I don't get GFAP antibodies or CRIMP5 because they don't tend to cause an optic neuritis. They cause more of a papillitis. But if there's enhancement of the optic nerve, I'm going to be looking for, ANA and Lyme and syphilis and ACE and all of those. We talked about plex. Risk of recurrence, probably 20%, 15%, just like you said. If they do have a relapse, treat them with rituximab, IVIG, CellCept, just something to suppress the immune system. And then going back to your second case, I probably wouldn't have Labors on the differential diagnosis, even though they're young male, because there were no light perception. And Labors would be very, they're going to cause central scotomas, but no light perception. So, Brander, you handled the case perfectly.
Thank you. Yeah, thank you, John. In the interest of time, we'll go to the last case presentation. I would like to invite Dr. Swati to present her case, and we'll take any more questions on this case at the end of it if we have some time. Yeah, Dr. Swati, please. Dr. Swati is a associate professor at the All India Institute of Medical Sciences. Dr. Swati.
I think Dr. Virender will have to stop sharing his slides. Yes, okay. Yeah, thank you, AIS, for this opportunity. And I would like to present a very interesting case of optic neuritis. I hope my slides are visible and I'm clearly audible here.
Yes.
Okay, so we recently had this case of 58-year-old female who presented with basic complaints of sudden onset of vision loss, which progressed over 10 days in right eye and was later followed by vision loss in left eye. She also has classical history of pain on ocular movements associated with headache and vomiting, although not very severe, but just one episode or so. She has no other significant past history or systemic illness. So on examination, the visual acuity in both eyes was extremely poor as no light perception in left eye. Both eyes showed sluggish response. Left was worse as compared to right eye. The anti-segment was normal. And the fundus showed disc edema, very mild, with some 1 or 2 peripapillary hemorrhage. The rest of the fundus was absolutely normal. This is the OCT analysis. As you can see that there is RNFL edema there in both the eyes. Right eye has relatively lesser edema as compared to left eye. And also, as per the protocol, we did MRI and we saw that on T2 images, there was hyperintensity of bilateral optic nerve, which was extending from retrobulbar area to as extending as chiasma, but not involving the chiasma. A classical feature which is associated with MOG-associated optic neuritis, and on enhancement, both optic nerve showed significant enhancement with the perineural sheath enhancement as well. So by now we know this is a very common diagram. So we know that I'm talking about MOG-associated optic neuritis features, and so this is the brain image of the same patient. And surprisingly, what we saw here that there were demyelinating lesions which were relatively punctate discrete around the periventricular area and had classical Dawson fingers over here. So these are the features we can see over here. They were perpendicular to the ventricle, suggestive of Dawson fingers here, which was very, very suggestive of MS. Also, along with that, there were multiple cerebellar lesions here, T2 weighted images on T2 weighted images, again suggestive of probably MS kind of lesions. So we all know that in MS, we can have much more discrete lesions involving the localized optic nerve as well as brain lesions, classical of Dawson fingers. But in MOG, we can still have, we have much more confluent lesions. So we were weighing against with the diagnosis of MOG versus MS. Anyway, we went ahead and gave IV steroid that was anyway given whether it was MOG or NMO. And this was the course of the steroid was over 5 days, we gave 1 gram. And right eye showed relatively better improvement while left eye did not show any improvement. Visual field also showed some improvement there and left eye had no improvement at all. In the meantime, we sent for a serology and we found that the MOG antibody was positive while NMO antibody was negative. At this time, it would have been prudent to do a MRI spine as well as CSF analysis, but unfortunately, due to financial constraint, we had to, weigh between continuing the further treatment in view of poor prognosis or to order MRI spine and oligoclonal bands. So we went ahead, we gave IV IgG 2 milligram per kg body weight of the patient over next 5 days. And this is what we saw. We saw that the right eye still showed just 1 line improvement, but left eye had no visual improvement at all. By this time, the patient, the pallor was set in, and we knew that this was probably leading to optic atrophy. Similarly, then the patient was discharged on oral steroids and we were considering slow taper of steroids with the option of immunosuppressant, again, depending on the patient's financial status. So how frequently do we see this kind of periventricular Dawson finger kind of lesions in MOG positive optic neuritis? What is the role of CSF oligoclonal bands? How would you proceed further? Would you like to treat them on the lines of MOG associated optic neuritis, or would you like to treat them on the lines of MS related optic neuritis? And does it affect the prognosis of whether MS or MOG is what questions we had in mind? So we went ahead, searched the literature, and we realized that the simultaneous presence of MOG and MS feature is there in the discussion for almost a decade. And there have been studies which have revealed that this kind of positivity, oligoclonal positivity, can be seen in 10% of MOG-associated disease. This case report probably was one of the earliest case report where the patient presented with typical MS-like features like Dawson fingers, positive oligoclonal band, and the only neurological problem was upper limb numbness. So they also did MOG testing and found out that the serology for MOG was positive. They went ahead and treated patients in terms of MOG associated disease, and they found that the recovery was relatively better. So to understand that, MS patients with concomitant severe brainstem involvement should be tested for antibodies to MOG. And these patients have higher risk of progressive disease and have low response to the treatment with high relapse rates. So we now come to know that there is something known as MS-like phenotype of MOGAD, where MOG positivity is seen. Oligoclonal band can also be positive, but MRI lesions may be suggestive of MS-like features with or without the involvement of classical MOG-like demyelination lesions. The response to classical MS therapy in these cases may be relatively poor, while the response to steroid is very good, and frequently you will encounter the relapses. MRI, probably doing a serial MRI is probably the better answer to understanding whether this disease is going towards a MOG-related disease or a IMS-related disease. So if it's a MOG-related disease, the lesions of brain and spinal cord will disappear with the response to steroids, while if it's an MS-related, probably they will be there forever. This dual positivity effect, patients who show both MOG IgG and CSF OCBs present, are suggestive of highly inflammatory and polyfocal clinical onset, as we can see from number of studies. And there have been they show aggressive course with frequent and devastating attack and severe physical and visual disability. So it's important to diagnose this entity because it has treatment implications. Rapid rescue in form of immediate treatment, either in form of PLEX or IVIGG, is very, very important. But we also need to keep in mind that these patients are highly dependent on steroids, and we should not stop the steroids abruptly, but a long taper of steroids with the immunosuppressants is what is required. Highly targeted immunosuppression, IVIGG, has been shown to have better response in such cases, and it could be important to understand the role of testing MOG antibodies in cases where the MS disease is not following a typical pattern. With that, I thank you, AIS, for this opportunity, and would like to invite everyone for the INOS conference, which is being held in New Delhi, along with the Asian Neuro-Ophthalmology Society this year from 2nd to 4th of October. So welcome each and everyone. Thank you.
Thank you, Dr. Swati. Very interesting case indeed. So we'd like to take comments from panelists. Prem, John.
Yeah, I think this is
John had something to say.
Yeah, very interesting case, very controversial actually in some regards, because the problem is the MOG antibody is never 100% specific. And so you can end up getting some false positives depending on the titer. So if the MOG antibody, I would want to make sure it's on a live cell-based assay. And if it's at 1 to 1,000, then I'd be more convinced. If it's 1 to 20 or if it's a fixed cell-based assay, there's always the potential there being false positives. I think for this patient, I think a spinal tap looking at a local clonal bands could be helpful. And then the follow-up MRI is super important. With MS, it's multiple sclerosis, multiple scars. The scars persist. With MS, with MOG, like you said, 80% resolve. I think for this one, with that eye being NLP, I probably would go on to do plasma exchange as well. And then ultimately, there are some cases where you just can't tell if it's MOG or MS. And then there, I tend to do B-cell depleters like rituximab. Again, that's going to treat your MS, kind of treat your MOG. But if you go and do IVIG, then that's not going to treat the MS at all. And the one you'd really want to treat is MS, because then you can get this progressive phase. MRI spine for this patient will be important as well. If you see some small lesions in the spine, help suggest MS. But yeah, a very interesting case.
Thank you. Thank you. We did have a diluted titers of MOG antibodies, although it was not a live cell-based assay, it was a fixed cell-based assay.
Prem, your thoughts on this?
No, just echoing John, I think the antibody testing in particular is a really important point because we're seeing more and more patients with these lower titers of MOG that we're unsure what to do with them, and that's where CSF can be helpful, or repeating the test and really putting it into the clinical phenotype. And I think the point, many of you may not remember, but there was a time when we didn't understand NMO as well, and part of how we recognized it was that these patients got worse when put on MS disease modifying therapy. And so I think this is a similar picture that we're going to see as well, that if you're seeing a patient who's been diagnosed with MS, but getting worse on an MS type therapy, not a B-cell depleter, then reconsidering what could be the underlying disease, and in particular MOG, would be important.
Yeah, even if Dr. Prem, even if we leave aside that antibody titer or the CSF analysis, the classical MRI picture of bilateral optic nerve long segment enhancement, as well as perineural sheath enhancement, any thoughts on that? How frequently would you see in a typical MS case such kind of picture?
Yeah, I think the optic nerve sheath enhancement, that perineural enhancement, is very uncommon in patients with MS optic neuritis, and would make me lean more toward this being truly MOGAD as opposed to an MS optic neuritis. But the more we learn, the more we don't know. And I think that it's just that the overlap between MS and MOGAD is really quite fascinating, especially in the pediatric population, right, where it's up to 25%. And so I think we just have to keep an open mind and really continue to study these patients to understand better if these lines that we are drawing are truly appropriate.
Yeah, that's
Your
right.
Singapore experience, Clement. Singapore experience.
Not too different from yours. I actually just had another question, which is, in these overlap cases where you're not really sure, I think John mentioned earlier that we might just want to give them the benefit of the doubt and have plasma exchange anyway. And I was just wondering for the rest of the panelists, if it's not really clear whether it's MS or MOGAD at a particular juncture, let's say this wasn't so much perineuritis, but just a bit more optic neuritis, but they were doing very poorly, would they be candidates for plasma exchange early on?
I would say yes. Like I said, here we are more, now kind of deciding based on the clinical presentation. So if the patient does not do well on your IVMP, then we would be seriously thinking in terms of discussing plexus. I mean, of course, it has a huge cost to it. And of course, the adverse events related to it. But yeah, I mean, if your visual outcome is not good in the initial period, and we would consider. So any other thoughts there?
Yeah, likewise.
And ultimately, the timely plex randomized clinical trial will answer this for us. But for now, it's typically what we're leaning toward. Again, at least in the US, there's a large increase in the amount that we do plasma exchange for optic neuritis.
Right, there's a huge financial constraint involved there.
So as we near the end of our
Thank
session,
you.
hand it over back to the chairperson, Rashmin.
Yeah, no, I would like to thank our faculty and panelists. I think it was a very interesting session, and I hope for the listeners, we have highlighted different facets of optic neuritis and the current thinking and the future frontiers, and also the role of ophthalmologist in management of these varied forms and presentations of optic neuritis. I once again invite all of you for the annual conference of Indian Neuro-Ophthalmology Society. As Swati mentioned, it's on between October 2nd and 4th at All India Institute of Medical Sciences in New Delhi. We again thank All India Ophthalmological Society for this opportunity. Thank you all.
Thank you. Thank you. Bye-bye.
Thank you.
Bye.
Bye, everyone.
Thank you, everyone.
Wi-Fi.
Let me move to a little. Can you check the Wi-Fi once?
Yeah, I'm doing that. Is it okay now? Is it better? I'm just moving a little bit.
Yeah, it's not patchy anymore.
Okay, good. Thank you for pointing out that. We don't want to get stuck in this technical issues. So I was just repeating what's the sequence. First will be divergence problem by Inning, and David will moderate this, and Daisy will give the first comment. And then David, if he finds any time, he will go around other faculty. And when you make a comment, be very brief and quick so that we can move on. Second will be second chance by Sableen. Third one will be by David Hunter. The fourth case will be by Morrow. Fifth is by Aditi. And yeah, that's it.
Ramesh, how do we share? When I try to share my slides, like I just look at the share setting, I'm not able to. So are you going to make us each a host so that we can do that?
There is a share button, not really.
Yeah,
it's a share button downstairs.
Oh, I see it. Okay. Sorry, pardon me. Still early.
Yes.
I'm not actually in California, but
if possible, I just did it. If you can add your country to your next to your name. Ramesh has India, I have USA. If you can, usually there's three dots in the upper corner of your image on the screen where you should be able to rename it.
Yeah.
While everyone's doing
Jitendra,
that, can I just
do it India? Yeah, quickly. You want to share or something?
share? I just wanted to share just to make sure.
Do that.
Yeah, sure.
Don't worry, we have 9 minutes.
Yeah, I just want to remind everybody, I mean, if Ramesh gave everyone a proper introduction, it would take 75 minutes.
Yeah,
So
that's true.
The level of excellence and expertise in this group is off the charts, and we can't tell you how much we appreciate everyone being here, and to try and get cogent comments, and we're all going to have things to say, but paying attention to the time is going to be the only way we get through 75 minutes.
Can you see my slides advancing as I?
Yes.
Absolutely.
Thank you.
Yes, but you're not.
Yeah,
We
I'm not in
see
full
what
screen.
you see. You're
Yeah.
not actually showing them yet.
So this is okay. Is this fine now?
Yes, that's good.
Okay, thank you.
Can I do the same super quick?
Please.
Sure.
Just
Dongsheng, welcome. Dongsheng.
Thank you. Thank you.
Hey,
Fine.
Dongsheng.
Yeah. Hi, David.
Dr. Kekunnaya, we also
Claudia, add your country.
Yeah, Rolika.
Yeah, we also have Tanveer and Arushri over here. So in case you need any help, Arushri can help with the timer part so that everybody knows that the timer is on. I'll help her out with it. And Tanveer will show up a slide. Tanveer is online. I believe she's not. Okay, so maybe Arushri, can you try to show up the slide? The opening slide. Do you have it downloaded? It's not a problem if you don't have it.
Yeah.
You're on mute.
Rolika, I'm having a little trouble hearing you. Maybe it's on my end, but you're a little muffled.
Oh, is it? Just a second, hold on.
Okay.
We
And then,
could hear.
Ramesh, would it be during the discussion, should we have the next person loading their slides
I think
to save time?
That's a good idea. Thanks, David.
Is it better now?
Yes.
Is it better now?
Yes.
Okay, perfect. Hi. Hi, Dr. Granite. How are you? Good
Good,
to see
how are you?
on the other side. Yes, good. So Arushri has these introductory slides so that she opens the session and opens it for everybody at sharp at time. So Arushri, do you have them downloaded with you?
Yes, ma'am.
Okay, perfect.
Good evening,
So once everyone has checked their...
Don't have to worry.
So
I
once
have
everybody
everything
has
set.
checked...
If she hasn't done
Okay.
it, don't worry. I have everything set. We will do everything. Don't worry.
Okay, fine. So Arushri, just sit and enjoy the session.
Yes.
Don't worry,
Yes.
sir has it all under.
I don't want to
Okay,
create a
just
last
enjoy
minute
this.
confusion because as soon as I complete my introduction, David will invite the first speaker, that is Ening, for the divergence problem.
Lovely.
So that way we have a workflow running order already there. So
So
relax,
not a
Arushi.
problem.
Yeah.
So we will just help with the timer part. Is that okay, sir?
Yeah, sure. We have 5 cases and we will take for the introduction 5 or 6 minutes along with David's opening remarks. So we'll have around 68 minutes or 66, something like that. I don't know actually how it goes. So just tell us 10 minutes for each of the discussion. When you reach 10, tell us, then we will wrap it up.
Okay, Arushi, you can text sir on the chat so that everybody is not getting stressed out about that. Okay?
Yes.
Thank you.
Claudia, can you add your country, please?
Yeah.
Yes, I do.
Thank you.
First of all, I would like to thank everyone for joining. I think we may not have at the end to say hi, bye, all that. I would like to really thank all of you for giving this 75 minutes or close to 80 minutes today. So I'm sure it'll be a great discussion. We have fantastic places. The objective is to share 25 pearls along with the panelists. They want to add some pearls. So David and I will do maximum to keep up the time. That's our target. Yeah.
Which means Ramesh and I won't be speaking very much.
No.
Ramesh, can
Is
I have a
David
quick
Hunter,
picture?
are we having trouble with David Hunter?
Yeah, he has
He
not
sent us
joined.
by WhatsApp that he's on.
Oh, he is on in the sense. Have he
But
joined? I'll
he
check
just
with
sent
him.
WhatsApp that he's got his Zoom back unloaded and standing by.
Okay.
I don't know what that means.
David, do you hear us?
He's not in the Zoom.
He's not in the Zoom, so I will share it. Oh, he's saying got my Zoom background.
Please.
Yeah, please join.
So.
Interesting that, let's see, 4 of us chose blue, 1 chose green. Let's see, that looks like David chose blue.
The yellow is very unflattering.
Yes, that's what I thought. The green,
Okay, I
didn't
could
work
see
for my
David.
skin.
David is here.
Yeah, I would like to tell you something. My colleagues told me that they have trouble to get on this meeting because the Zoom is not allowed to be used in China. So it's unfortunate.
Okay. We will share the recorded version probably later. So I think it'll be recorded. So we will share that.
Okay, that's great.
Apologies
Yeah,
for
if
that.
you record it, it's going to be much better. They can get the time to review it. Thanks.
Good morning, David. If you get a chance, can you add your country of origin or where you live?
I didn't see that in the written instructions.
No, it wasn't in the written instructions.
I was trying to be good.
Hello.
We decided that moments ago.
There.
Ramesh, will there be a countdown?
I think so. Arushri, will there be a countdown from the audiovisual people? Or do you want me to do it?
No, I want somebody to say go.
Yeah.
I
I think we only have to do it. So can we start, Arushri?
So it's just
I can't hear you.
10 more seconds.
10 more seconds. Okay.
Go.
David, 10 seconds you can start probably.
Got it. I was waiting for my phone to tell me we had crossed onto the hour. Have fun, everybody.
Yes, thank you.
You are ready to go, sir.
Well, so welcome everyone from around the world. The traditional greeting that we now have is good morning, good afternoon, good evening, and good night, wherever you are around the world watching. Welcome to the AIOS and WSPOS session on interactive strabismus. We have assembled experts from literally all around the world: North America, South America, Europe, Asia, the Middle East. You're going to hear from experts everywhere, and of course, from India. So, with that as a lead in, let me tell you just a tad about what's about to happen. You'll hear experts present very quickly a case and give you 5 pearls to take away, and then you'll have an expert discussing those pearls. We're going to move in rapid fire sequence, and we're going to do a lot in 75 minutes. You'll get 25 pearls, and then you will have discussion about those pearls. With that, I will turn the session over to Ramesh Kekunnaya, our host from India.
Thank you so much, David. Very warm welcome for this WSPS AIOS webinar. This is the combined webinar we are doing. As David said, we have people from all over the world. My co-chair is Dr. David Granite. He's a founder chair of WSPOS, and he's the vice chair at UCSD, and F. and Abraham Ratner Children Eye Care Center. Welcome, David. We have Aditi Parekh. She is the consultant pediatric ophthalmologist at LV Prasad Eye Institute. And we have Claudia Polo. She is our one of the bureau members of WSPOS, and she's a good friend from Buenos Aires, Argentina, and she is the head of pediatric ophthalmology strabismus at Pifero Hospital in Buenos Aires. Next, we have Daisy Gotts, one of the excellent orthoptists, and she's also a bureau member of WSPOS. She's from University Hospital Antwerp, Belgium. Welcome, Daisy. And we have Dr. David Hunter from Children's Hospital, Boston. And he's the chair of pediatric ophthalmology there. Very warm welcome, David. We have Far East, Dr. Dongsheng Yang. He's the director of Institute of Children's Eye Diseases and Ocular Motor Research, Vision Rehabilitation Center, Bright Hospital Group in China. Welcome, Dongsheng. We do have from India, Dr. Jitendra Jitani. He's the director of Baroda Children's Eye Care Center. Welcome, Jitendra. Going again west, we have Dr. Mauro Goldschmidt. He is the executive director and founder of Strabismus Institute at Sao Paulo, Brazil. Welcome, Mauro. And next we have Dr. Savleen Kaur. She is an associate professor from PGI Chandigarh from India. Welcome, Savleen. And we have Dr. Yair Morat. He is the chair of the scientific committee of WSPOS, and he's from professor at the Tel Aviv University and also head of ophthalmology at Shamir Medical Center. Welcome, Yair. Last but not the least, we have our friend Dr. Ening from Canada. She is one of the star in the strabismus and pediatric ophthalmology, and she is an associate professor, pediatric ophthalmology and adult strabismus, Queen's University, Department of Ophthalmology and Pediatrics, Kingston Health Science Center. So we are very, very grateful to all of you to join this webinar. Very interesting. I just have 2 more slides before we close the introduction part. All of you are welcome for the WSPOS Subspecialty Day in London in 2026, September 11th. And also, I invite you all to the 6th World Congress in Pediatric Ophthalmology in Mexico, Cancun, May 13th to 15th of 2027. Over to you, to Dr. David Granite.
Well, thank you, Ramesh. This is an amazing session, and nobody really wants to hear from me. So let's move on to our immediate first talk. We've converged here from around the world, and Yining Struby from Canada will talk to us about a divergence problem.
Can you see the slide okay? Let's see if it went back.
Yes, ma'am. You are visible and audible.
Great. Thank you so much for the introduction and inviting me to participate in this great session. This is a case of mine from 10 years ago that, although a common problem, divergence insufficiency, I struggled a little bit with it. So hopefully there's some learning points for those of you listening. So this is a 64-year-old healthy man, no medications, low myopia as shown here. And he presented to my clinic with divergence insufficiency esotropia with horizontal diplopia only at the distance. At near, he just had a small ESO, which he fused, and at distance, an ET of 14. I followed him in the clinic for stability. We built up his deviation with in-clinic prism neutralization, and the maximum deviation we could measure is shown here, still an esophoria up to 14 at near, and I built him up to a 20 at distance. Comitant deviations, slightly limited abduction, and he accepted 20 prism diopters with free prism. So normally if this was more interactive in person, I'd say, what is your surgical plan? But I'll just tell you. So I brought him to the OR. I decided to do bilateral medial rectus recession 3.5 for the maximum deviation he tolerated in clinic, which was 20. Forced ductions at the time revealed tight medial rectus. And to my disappointment, post-op, he was fine at near as he was pre-op, and at distance, it was almost like nothing had happened. So I continued to follow him. Measurements were stable. He actually liked to have a Fresnel prism on his upper segment, 15 prism diopters. He didn't like it at near. Comitant deviations, and of course, we decided to go for a second surgery. So again, I said, we got to make sure maybe we missed some underlying esophoria. Let's build up the deviation as much as he would tolerate. And you can see the numbers here. So near, he accepted up to 18, and distance up to 25 prism diopters. So again, thinking as the audience members, what would you do next? Intraoperatively at the OR, I found that the medials were still really tight to abduction. And the medial rectus were where I had placed them. There was no forward creep or slippage or any change. And I decided to re-recess both medials from 9 to 11, thinking that that additional 2 millimeters would help correct that 14 to 20 prism diopters. And at the time, I was worried about overcorrecting them at near, and I also want to address the restriction. So here's my great results after my second surgery. Still nothing at near, and distance, again, he had this persistent esotropia. And darn it, several months post-op, he was back to where we started. Still some slightly limited abductions, and again, wearing the Fresnel in his upper segment only. At that time, I decided to do some blood work, make sure this wasn't thyroid orbitopathy. I got an MRI orbits. Everything was completely normal. No new medications. He's still a healthy guy. So what would you do next? This patient was a very patient patient, and he still stuck with me. I decided preoperatively, I decided if during surgery forced ductions were free, I would operate on the lateral rectus. But if they were still tight, my thought process at the time was I'd re-recess the medials. And I kind of was hoping that the forced ductions would be free, but they weren't. They were really tight still with some scarring. And I thought, oh, gosh, all right, I'm going to re-recess them more maximally. And I put them back 13.5 from the limbus. And post-op, he still had a residual ET. And 1 month post-op, again, similar case. So I'm so disappointed. And the patient said, let's do another surgery. So just to summarize, he came to me with an ET of about 14 to 16. I thought I did maximal surgery for 20, went back twice to re-recess the medials because they were really tight. So what do you want to do now? Well, we went back for a fourth surgery, which I typically don't do, but here we are. I'm presenting my failed case. His medial were still tight, and I ignored it. I obviously couldn't put the medial back much further. And I decided to do central plications of the lateral rectus, thinking that if for some miracle I overcorrect him, I can reverse it. And knowing that we get about 6 to 8 per muscle, especially since the medials had been previously maximally recessed. And thank you to whoever above. He looked really good post-op day 4, flick X at near and distance. His stereo was back and the patient was really happy. And this is to prove it. And I followed him 6 months post-op and several years post-op. And to my utter surprise, he was so happy. He asked if he could take a picture with me because he was so thrilled with the results. So here's that picture of him. So if I could go back in time, thinking about this case, I would have done a much larger medial rectus recession. Although I didn't think he could tolerate more than 20, I should have probably aimed for more. And instead of going back to the medials, I would have operated on the lateral rectus earlier. But of course, hindsight's 20/20. So my learning points, some of which are obvious to the experts on this panel, but this is what I reflected on, was the underlying esophoria is always larger than what you measure. Don't chicken out. Despite minimal deviation at near, fusing patients are usually able to fuse even if overcorrected. So they have these large convergence amplitudes, so don't be worried about that. And re-recessing medial recti doesn't always help, even if there's tight force ductions, which is really sort of 101. You want to release that restriction. And part of that reason is if you're doing these really small recessions and you haven't placed your sutures really close to the insertion, you may be doing a little bit of a resection. So then your resection and recession are sort of canceling each other out. And despite knowing that, it must have been part of my poor result. And of course, you want to rule out other possible causes. But of course, divergence insufficiency ET in older patients is very common and usually benign. And finally, just to emphasize good communication, developing trust with your patients. This patient loved me, even though I was so devastated with my results, managed expectations, and luckily everything turned out good in the end. Don't give up. So thank you. I hope I was on time.
Ying, thank you for that. That was fabulous. There's so much here that we could talk about, probably for the next 75 minutes. From the idea that the esophoria is actually larger, or that the mechanics are different, and that this is a different problem, and what the workup is. Daisy, Ying opened with using an in-office prism adaptation. What do you think about an orthoptist can add, or how we think about divergence insufficiency, and what we should do in the office to try and identify what's going on with the patient?
Well, first of all, it's not my experience that the ESO deviation is much larger than I measure. What I measure normally is correct, and I always check it with a Maddox rod to see the subjective deviation. Well, first of all, I would give prisms, because if you give the prisms, they're getting used to it. And then if the deviation is going to be larger, you will see it in the next visit. Then, so we do normally a prism adaptation test, always with intermittent exos, but not really with the esotropic or esophoric patients. And I know that my colleagues neither. So to measure a larger deviation, what I would suggest is first prisms, and then if the prism deviation or if the deviation after the prism is too large, then we do surgery. But what I've learned for all these old patients, and what also Jules Diemer said last year during the ISA meeting in Istanbul, is that you have to count twice, or you have to do the double of your surgical amount of recession. So if you would say 3, then at least to 6. And here the really a large series, and they were all undercorrected.
Yes, Daisy, that's right. It's double the amount in prism diopters, not in millimeters.
It's interesting. Thank you, Daisy. They, he was in this prism for so long. Like I put him on a Fresnel prism, and we also do that, sending them home with prisms, and he didn't build up with the Fresnel. But this is an unusual case for me, because usually I do like you said, and they do quite well. So I was not happy about it.
So we published that when we do bimedial recessions in this setting, if we don't fix the patient, they come up short, and if we did bimedial resections or plications, they came up overcorrected. But I would be remiss if I didn't take 30 seconds or 20 seconds and ask Yair Murad to comment, because he changed my approach completely with the surgery that he has published, and I've been using it exclusively since then. Yair, very briefly.
Thank you.
What do you do?
I was trying to raise my hand and say, no, these are patients with normal binocular vision who have sagging of the lateral rectus. And until you correct this sag, no matter what you do on the medial rectus, they're going to recur, because you're not addressing the problem. The problem here is sagging of the lateral rectus. So you need to plicate the lateral rectus, pull it up. This is the procedure that David told you about. It's called superior plication, and we published that in Strabismus. And when you do that, you solve the problem. So there's no need for Fresnel and prism adaptation and so on, because these are normal patients with normal binocular vision. The only problem they had is due to age or due to high myopia sometimes, the lateral rectus is sagging down. You just need to placate it upwards. Yes, Daisy.
That's a great point. His MRI did not show any sagging at all,
yeah,
or
I
intraoperatively.
I
Yeah,
agree.
so it was a weird case, but
sometimes you don't see it, but on surgery, you actually see the sagging of the lateral rectus.
Yes, Daisy?
Yes, but
I like to.
This patient had a limitation of abduction and tight medial rectus muscle, so I don't think it's a sagging problem you had in this patient. Is it correct?
Correct.
Yeah.
Yes. And so one last comment, Cheng.
Yes, I'd like to mention one of my patients. I did 3 times for the ET, but first time 15 degree, and a few months later another 15 degree. But when she came in, we still see a small degree of ET, and then we covered one eye, this time for 2 hours. This is not the routine time we cover. It's because we nearly the noon we're supposed to examine it, but said maybe you go to have a lunch, come back, we'll examine it because we're running over the time. But
Yes,
come back.
Cheng, we're short on time, so I want to make sure that you get to make your point.
Yeah, another 30 prism diopter was discovered after 2 hours cover. That's one thing I want to mention. Another thing
So
is
a diagnostic conclusion for a divergence insufficiency esotropia.
Yeah,
that's fabulous.
Another one is that another thing I want. Maybe you can use a local anesthesia to do the adjustable suture. Do you do
Yeah,
that?
and we didn't even get into adjustables. Ramesh, I know we have to keep moving forward. I didn't know if while you introduced the next person, if you wanted to comment on whether or not a patient with divergence insufficiency should have a workup before we operate on them.
Yeah, thank you, David. We will have to move on. I think when Savlin is sharing it completely, Jitendra, you can make a 10-second comment. I was seeing you're raising your hand. Just 10 seconds, please. And then we'll have a Savlin's talk on reoperating in strabismus.
Just a quick comment that, when we were doing the second surgery, we can do adjustable surgery, as Dr. Garnett said that we did not go into adjustable. So that was my point, that, if you have such difficult cases, we can use adjustable medial rectus recessions.
Thank you. Go ahead, Savlin. Thank you.
Thank you so much. A very good evening to all of you. With the second chance strategy, I'm going to present a simple case of a reoperation in strabismus, and hopefully we'll have some simple tools coming out of it. So I don't have any financial interest. I'm presenting a case of a 26-year female who had a deviation of either eye since birth. She did give history of strabismus surgery at 4 years of age elsewhere, and she did not have any records of the same. When I saw the patient last year, she was 20/40 and 20/20. She had a normal anterior and posterior segment, and as you can see, she had a left exotropia, which was large. She was fixating with that eye, but it was not showing any improvement with spectacles. This left exotropia seemed to have no pattern. As you can see, it measured around 60 to 65 prism diopter. Along with that, she also had a limitation of the rotation of the left eye medially, much more as compared to the right eye. So both eye, there was some limitation seen, but it seemed to be more in the left eye. This seemed to persist when the patient, we demonstrated it on duction. We reviewed the old photographs, and as you can see, she had an esotropia to begin with, got operated at 4 years of age, had a slight exo after that, and landed up something like this 20 years later. We did an anterior segment OCT for this patient, and the right eye medial rectus was found at 11 mm. So here you can see the medial rectus, and it's found at 11 mm. The right eye lateral rectus was unoperated. The left eye medial rectus was also recessed, but had a lot of scar in in front of the muscle insertion on the ASOCT, and the left eye lateral rectus was also resected. This was a diagnosis of consecutive exotropia, status post bilateral medial rectus recession, as we saw on the anterior segment OCT, as well as a left eye LR resection. So here we have a patient, just summarizing, a 60 to 65 prism diopter of left exotropia. We know there's a limitation of adduction of the left eye as well as the right eye. Also corroborating with our anterior segment OCT findings that both eye medial rectus were recessed. The left somehow had more adduction limitation, had more scarring, and we could see more thinning on the anterior segment OCT. So we decided that we do have to look at least the left MR, what is wrong with that, and probably advance it. Because the left eye had already undergone surgery, we decided to first explore the left eye, and the patient was counseled that she might be needing the other eye surgery as well, because the deviation was very large. Intraoperatively, we have given a little larger scar than we normally do. It was a paralimbal incision, I'm sorry. In the second photograph, you can see the scar, which was enlarged. We did see some amount of bleeding, some amount of scarring. And now we have pre-placed sutures in the lateral rectus, but did not complete the recession in the first go. We first explored the medial rectus of the same eye. So this is the left eye. I'm talking about the surgeon's view. You can see that there was a scar in the conjunctiva. So we went a little behind the scar that was already there, gave a larger paralimbal incision to expose the muscle, and then hooked the medial rectus. And yes, we did encounter some scarring, which was there over the muscle, around the muscle, and cleared it to isolate to see what was done before, as we saw on the anterior segment OCT. So this is where the normal medial rectus should be, if you can see on the first photograph. And the medial rectus was found to be recessed. We went ahead and did something like a plication, not really an advancement, but advanced to the original insertion, because we could not actually see where the scar was ending and where the muscle was beginning. So we plicated the whole muscle scar complex and advanced it to the original insertion. So overall, the medial rectus was now advanced to the original insertion, about 6 mm, by this plication advancement. Now we went ahead and completed the recession of the lateral rectus on an adjustable before closing the case. So post-operatively, this is how the patient looked like. She had orthotropia. Along with that, we did seem to give her some improvement in her limitation of adduction, although it was still not complete. So the learning pearl for a case of strabismus reoperation, I just went back to very, very basic things, and I thought we'll give us a mnemonic to remember. That's what I think would recapitulate my case. So the vowels of the English alphabet, I'll go by them: A, E, I, O, U. So if we all remember that, we ask the patient, we examine the patient, we image if possible, look at the operative findings, and then decide whether we have to undo or redo. So these are the 5 pearls that I would like to again highlight. Ask for a detailed history. We often get records, and even if not available, a complete family photographs will tell us what had happened before and would complete the story for us. Always examine and look at the rotations of the eye, because they will give you a clue as to what muscle was weakened before. There might be subtle palpable fissure changes induced by the first surgery. And do not forget to look at the scars on a slit lamp or under the microscope, as well as on the imaging if possible. So imaging, as we have published a lot, the anterior segment OCT and the UBM is not a better technology than that to look at the muscle insertion distances. MRI in select few cases where you think there, especially in cases of trauma, or you have lost or say slipped muscles. Look at the operative findings. Do a force suction test, locate all muscles. As in our case, we first looked at the lateral rectus, a normal recession going first, but did not complete it because there might be some anatomical variation seen in every case of resurgery. So always have a look at all the muscles first before you decide what you have to operate. And of course, on-table decisions are the gold standard. The last pearl is undo and new. Sometimes the Cooper's dictum might not be true. The advancement surgeries are known to give the same effect as resections. There are 2 articles that I'm really fond of, and I'm quoting them here. saying that advancement might have to be done a little more than the usual Parkes tables, and of course combined with recessions if you have a larger deviation. So just recapitulating again, ask, examine, image if you have access to, look at the operative findings because they are still the gold standard, and then decide whether you have to undo what was done before, redo, or touch something completely new. Acknowledgements to my mentor, Dr. Jasprit. Thank you very much for inviting me here. I'll just stop sharing.
Thank you, Savleen. I think we encounter this on a regular basis being a strabismologist. I really like the mnemonic, what you enumerated, AIOU. It's a very, very simple one. So, Jitendra, do you have any comments about the case?
Sir. Yeah, I think the best strategy is to do a R&R and put the lateral rectus on adjustable. I would do the lateral rectus on adjustable because we are not sure how much that particular plication of medial rectus would give. So I think lateral rectus should be put on adjustable, and that would be really helpful. FDT would definitely be helpful before the surgery. So.
Yeah. Thank you, Jitendra. I just wanted a quick raise of hand. How many of us do the imaging in strabismus resurgeries? Always? Show of hand, please. Always, Savleen. Occasionally, I do MRI, I do ASOCT. So I think people don't do that AIOU in all the cases. But I just wanted to ask Savleen, is there a scope to go back to the muscle a little bit more so that in the hindsight, is there a scope to advance that a little bit more so that the adduction would have improved? That's some question I had. And I would like to ask David Hunter, do you have any comments about this particular case?
Thank you so much for that question, Dr. Kekunnaya. We can do without imaging. We have been doing that without imaging, these surgeries for years together because I have access to, and I feel in cases of re-ops, it always gives me some additional information. That's why I'm able to counsel and modify my plan and counsel the patient better because I'm more sure. That's why I choose the anterior segment OCT in cases of re-ops mostly. And to answer your second question, yes, we could have advanced because the force reduction was coming tight, so I did not. But yeah, in the hindsight, I could have advanced a little more to get more adduction. I completely agree with you. Thank you.
Dr. Hunter's tips, please.
Yes, thank you. I was interested to see the choice of doing a plication on a stretched scar. I've not seen that before, and I thought, well, that's not going to, you're not preserving vascular supply, so there's no advantage to a plication there. But then again, I've seen even experienced surgeons go after, reoperate on a stretched scar and maybe not realize it's a stretched scar, and so then they put a suture in bad tissue and reattach that, and the patient looks good for a week or 2 weeks, and then they have a even worse adduction limitation. So in a way, it is a safety measure if you're not sure you have the muscle. But usually it's possible to be sure you have good muscle as long as you get good exposure. You have to do a big incision, get good retraction, and sometimes you're back there, way back there before you get the muscle on a suture. But I always want to be sure I've got the muscle on solid suture before I pull it forward and cut off the remaining attachments of the globe.
Thank you. I would like to invite Dr. David Hunter to share his slide. As he's sharing the slide, I wanted one practical tip from Dr. Claudia Apollo. Claudia?
Yes, one question for Savleen. Savleen, I would prefer put the eye in more overcorrection for the first days in this case, because it's very frequent that the subcorrection occur in this kind of patients with the stretch scars, especially. But it's a very interesting case.
Thank you.
I agree. Thank you.
Over to you, Dr. Hunter.
Okay, great. Thank you. So I will, so buckle your seatbelts. We're going to go quickly through this. So this is one case, 5 takeaways. This is a patient, a 59-year-old man. He had high myopia. He had a left superior oblique palsy and had a successful left inferior oblique recession 12 years ago. But then 4 months previously, he returned to his original surgeon with recurrent double vision. They brought him to the OR. The plan was for bilateral Harada Itos because he had bilateral extortion. But on the first eye, the sclera was very thin, so the surgeon abandoned the Harada Ito, decided intraoperatively that looking at the numbers again, maybe the patient had a heavy eye, and so changed to doing bilateral lateral to superior rectus myopexies. Unfortunately, when the patient woke up, he had a huge exotropia, and so under topical anesthesia, the surgeon was able to reach in and remove the myopexies. And so rather than going back to where he was before surgery, the patient felt that the double vision was now worse than ever, and he had to have this exact head chin up position to have single vision. Anywhere else, he was seeing double. So on examination, you see the high myopia. He's got bilateral upgaze limitation. And I want to point out a couple of other things here. It's a lot to take in a short time, but there is a small V pattern. You see the X of 0, XT8 in upgaze. That was a problem for him. There is a left hyper that's worse in downgaze in particular. And so that's why he needed that. There's that one sweet spot where the XT was small enough and the hyper was small enough for him to control. He does have bilateral extortion of both eyes anatomically and on double Maddox rod. And then I did decide to get an MRI scan because I wanted to see, does the patient have, didn't look like heavy eye to me. So I got the MRI and you see that the lateral to superior rectus bands look pretty much intact in this patient. So what to do? Well, I brought him to the OR and I found that on forced ductions, he had limited horizontal excursions, but the vertical movements were normal and the obliques had normal tension, even though he'd had a history of superior oblique palsy and inferior oblique surgery. But there you go. I wanted to focus on this vertical, primarily on the vertical alignment. So I recessed the right inferior rectus 5.5 millimeters. I suspended the lower lid retractors because I was concerned about a lower lid, cosmetic appearance of a larger inferior rectus recession, and recessed the left inferior rectus 2 millimeters. Why did I do both? Because I thought that could help with the V pattern. Because remember, he also was troubled by the XT and upgaze. On post-op day 6, he said he had single vision with his glasses, so we thought we were good. But he said, I don't see as well with my glasses. So I said, we're 6 days out. Go ahead and put your contacts in and see what you see. And he said, oh, no, now it's double with the contacts in. And it turns out that with his contacts in, he had now a right hyper. He'd gone from a left hyper to a right hyper, so I had slightly over-corrected. He still had the V pattern. He still had some extorsion of the fundus. So I used the short tag adjustable sutures, so I was still able to adjust him. And the reason that he was single with glasses but double with contacts, remember he's a high myope, and I did the math, and he tilting his glasses 10 diopter minus 10 correction, just 2 millimeters, gave him 2 prism diopters on each side. So that gave him the 4 prism diopters that he needed for his diplopia. So I did an office adjustment. I recessed the left inferior rectus. Now you could say, wait, he's overcorrected. Why not pull the right inferior rectus up? But I put the left inferior rectus back more because I wanted to further reduce the V pattern by further recessing the inferior rectus muscles. And after the adjustment in contact lenses, he had an exophoria of 1. So 2 months post-op, he's from far away. I only did a virtual visit, but his diplopia was almost resolved except in upgaze. We did self-performed cover testing on a virtual visit and he was a good observer, so he would tell me which one's higher, which one's lower. So left hypo and upgaze, otherwise no shift in the other gaze directions. He said his depth perception was improved and provided these images with the app that we have at Children's Hospital. So my 5 pearls from this case. Number 1, I think we should all abandon the classic Harada Ito procedure. It is non-anatomical. There's no reason to be pulling the superior oblique tendon all the way over next to the lateral rectus muscle. You can do it just as well by plicating or resecting the anterior fibers of the superior oblique muscle. Stacy Pinellas and Federico Velez did a video on this, and then Eric Bothan and Maud Anderson published this procedure where they actually make it post-operatively adjustable by doing this second pass. I don't do that. I just tie it down in the OR. And my sub pearl on this is that to check the torsion intraoperatively, it's simple enough. You put some sort of mark on the cornea. I get fancy and use the radial marker. And then and you put other marks above and below the eye. And then post Hirata Ito, you can look at the new angle, and you can actually put a little Mendez degree gauge up there and measure with some precision how much torsion you've obtained. That's pearl 1. Pearl 2, suspension of the lower eyelid retractors. We don't want to forget to do that. People can be happy with their alignment and unhappy with this lower lid retraction. And it's not that easy to fix if you don't do it. And it's because we're recessing the capsulopalpebral head. It's dropping back with the inferior rectus muscle, and so then the lid goes down with it. So Kushner and Guyton, Repka, Pacheco have both published strategies to correct this. It involves putting a suture through the capsulopalpebral head, and then Kushner sews it back to the muscle at the time of recession. Guyton, being the adjustable person that he is, sews it back to the sclera and then hangs the lid retractors back so that you can adjust that too. And indeed, in this patient, I did have to adjust both the muscle and the eyelid to get it exactly where I wanted it. Pearl 3, this is a lot of words, so you might want to just do a screen capture, but I found that if I'm getting an MRI of the orbits outside of my own institution, I have to be very specific about what I want. And in particular, they tend to want to use fat suppression, but we don't want fat suppression. And if you don't have Joe Deemer doing it, and you're having it done somewhere else. So putting down these criteria, 3 Tesla scanner, thin sections, and then why we're doing it, and that we don't need intravenous contrast. This is just if you're looking only at the orbits. Pearl 4, you can recess both inferior rectus muscles to treat a V pattern. So Kushner has published on this as well. Here's a case of Kushner's. The patient was ortho in this gaze. It was binocular single vision, but double everywhere in down gaze with 15 degrees of intorsion. He did 5 millimeter bilateral inferior rectus recessions in this case, and ended up with no extorsion at near in primary gaze and a significant expansion of the range of binocular single vision in that patient. And then the final pearl, the title of my talk, Prentice's Rule: be aware of induced prism from tilted glasses. It's the deviation in prism diopters is induced by the distance away from the optical center of the lens in centimeters times the power of lens in diopters. Delta equals H times D. You get prismatic effect when you get away from the center of the lens. So that is pretty much my case and my 5 pearls. Thank you.
David, thank you so much. That was fabulous. I did a double take when I saw the title of your talk. I originally thought it said President's Rule. And David's the president of APOS, so I mistook that at first. I would be remiss if I didn't ask you at least one optics question. The patient was also a high myope, right? That not just had the issue of being able to shift their glasses, but the measurements that you take in the office with a high myope in their glasses for side gaze, up and down gaze, if they have bifocals, they have significant astigmatism. How do you adapt for that for somebody who might be wearing contacts and going back and forth to glasses? And does it affect your surgery?
Well, yes, the adage is that minus measures more, and the deviation is so you measure a larger deviation. It's the number of diopters times oh gosh, no, it's a 20%, I think, times the number of diopters. So, or percent times 2% times the number of diopters. So this would be like 20%. So theoretically, at least, this patient had less deviation. However, he was then we measured. However, I do believe we measured in contact lenses. As far as cometance, as long as the refraction is symmetric, then the deviations in different gazes should not change. However, if you have anisometropia, say one eye was -10 and the other eye was plano, then you get into trouble when you get away from center. And that is a more realistic, practical problem where you can definitely have patients post-cataract surgery, for example, they end up by accident with large anisometropia. Now they have double in, say, down gaze. It's all because of the prismatic effect of the anisometropia and down gaze. And those patients, you do have to do things like slab off prism to correct them. But as far as my day-to-day life, I have not really taken the minus measures more or the opposite with plus measures less all that well into account, because maybe adjustable sutures or maybe just the slop of strabismus surgery is enough that we don't suffer too much by those differences.
Oh, terrific. There's a great article in Survey of Ophthalmology by Mel Rubin about his own cataract surgery, and he was a -9 myope, and he needed one eye done before the other and what to do. It's a great article. I give it to our residents. We have Yair Murad as our discussant for the case. Yair, it's all yours.
Yes, thank you. Well, I think the most important pearl from this presentation, for me at least, is how to treat a V pattern by recessing both inferior rectus muscles, because this is something that we don't normally do. And I would like to ask David, if you will offset the inferior rectus a little bit, also could you treat the exocyclar torsion better? What do you think?
You could potentially, let's see, if you offset temporally, you would extort the eye more. So offset nasally. But then you would, now you're going to potentially create some sort of pattern strabismus, right? So if you start to offset, you treat the torsion, but if you offset the lateral or medial rectus muscles, that treats A or V patterns. So if you offset the superior inferior rectus muscles, then that's gonna create patterns too. And I'm not sure I'm smart enough to figure out what pattern you'd create versus just recessing them.
But anyway,
So I have to jump in, and in in-post meeting, this actually came up, and David Guyton almost jumped out of his chair when the question came up about that the torsion and the pattern are in opposite directions when you offset.
Yeah. But what was the reason you decided to go for inferior rectus recession instead of treating the laterals and correct the V pattern by operating on the laterals? That's what I'm interested to hear.
Well, his main problem was he had a hypertropia in down gaze. That was really the limiting factor for him. And remember, he had just had a attempted LR-SR myopexy, which ended up creating a huge exotropia and big trouble elsewhere.
David, if you do an LR-SR myopexy, a one muscle myopexy, do you see this where you have these kinds of problems?
If you do it on a patient who doesn't need it, yeah. You'll create hypertropia.
I never do one eye myopexy. It's always bilateral. If you decide to do a myopexy, you have to do both eyes.
Oh, I've done it on one side.
Only if you don't want to operate on the other eye, maybe because of deep amblyopia or something like that. But usually it's a bilateral problem.
Maro Goldschmidt, you are a very thoughtful strabismologist. I'm wondering what you thought about the approach that David took, and if you've used the inferior recti recession for V patterns.
Hi, David. Thank you for the question. Yes, the bilateral inferior rectus recession was described by Carlos Sousa Diaz, and then later Kushner coded his proposal. And it helps correcting hypertropia, the V pattern, and the torsion with the same surgery. We have done this in superior oblique palsies, and it works.
We used to say, if you think you've discovered something new in ophthalmology, look at the German literature. But in my experience, if you think you've discovered something new, you have to look at the Brazilian literature, because invariably they've gotten there before we are. David, what do you think about what Maro's point was?
Yeah, no, I probably should have been more careful about who I cited in terms of this, but but it is a nice, when you have these orthophoric patients in primary gaze or in trouble, it's one of a number of tools that that I use to try to still make them better without making them worse.
Dr. Jachendra, David talked about separating the capsule palpebral head of the inferior retractors. I separate them if I'm doing modest recessions without actually tacking them back down. I find that the eyelid looks fabulous afterwards. Do you pay attention to the lower lid when you're recessing the inferior recti?
Yeah, I pretty much use the Dr. Kushner's technique, work with him. So I do what Dr. Hunter just suggested, that I go to the lower lid retractors and take a suture before recessing. So I take a suture and tie them so that there is no lid retraction.
If you look at those articles, it's 5 millimeters. Once you're over 5 millimeters, that's when you start getting in trouble.
And David, you threw out the Harada Ito. You threw the Harada Ito under the bus and said that we shouldn't be using it. And I am curious how the rest of our panel feels about throwing away a long-standing procedure. I've spoken to Eric Bothman about his procedure. It's an interesting technique. I haven't used it either, but I have plicated, as discussed. Has anyone else tossed Harada Ito into the trash heap of strabismus history?
Well, I tried. Oh, sorry. Yeah.
Well, no, I know
go
it's
ahead.
for anyone else, but
Go ahead.
Yeah, go ahead. Yair.
Yeah, well, I tried plicating the superior oblique and also recessing the superior oblique for cases of Brown, and it also works very well. So I feel, I'm not very keen on doing Harada Ito.
Yeah, I learned in Brazil to recess the superior oblique in Brown syndrome to the other side of the superior rectus and use forced ductions. And another lesson I learned from my visits to my colleagues in Brazil. Ramesh, I know you wanted to comment, and then I'll let you lead into our next speaker.
Yeah, I just want Mauro to share his slide. I just feel the same what Dr. Hunter does, because I think we don't have to really do the typical Harada syndrome and we can get away with it. So because of the want of the time, Dr. Mauro Goldschmidt, go ahead.
Can you see my slides?
Yes, go ahead, please.
Okay. Thank you, David and Ramesh, for the kind invitation. And I'll be talking about the case where the superior oblique was gone. So no conflict of interest. So this is a case of a 60-year-old man who had a trauma on his left eye with an iron that sustains Gall's milking hose one day before. So in this picture, you can see the iron, and here is the mechanism where it stays. He came from a city 3 hours from São Paulo, referred by an ophthalmologist with a left hypotropia 25. He was able to fuse this redness of the eye and a -4 limitation of elevation and a vertical diplopia. His visual acuity was good in both eyes, and he brought me an ultrasound that was normal on his left eye. He also did an MRI that showed on the left orbit an increased volume of the periorbital soft tissues on the left, appearing as interstitial edema and hematoma. It presents intraorbital projection along the superior contour of the eyeball, where air bubbles are associated. The changes involved the superior and superior rectus and superior oblique muscles, which were also edematous and with interstitial hemorrhage, and may be lacerated. The eyeball was intact and rotated inferiorly. So my diagnosis was of a possible traumatic lesion to the superior rectus and superior oblique. Important, there was no injury to the lid. So the lid was intact and the eyeball was intact. At surgery, of course, we explain all the expectations of this surgery to the patient and the family. The position of the eye under general anesthesia was a left hypotropia. And when we explore the superior rectus, we can see here the insertion was there and fiber muscles and vessels were present. Although the superior rectus was loosened with a small section here 8 millimeters posteriorly that we suture. So when we came to the medial side of the superior rectus, we found this structure that we start bringing with the forceps, and suddenly it came this structure here with tendon and muscle. So we had the superior oblique, this inserted on his muscle portion in the back of the orbit, 35 millimeters here. Here is the insertion of the superior oblique, tendon, and muscle fibers. So here we see the piece, the superior oblique. And so what we did in this surgery, we excised the superior oblique, we resected 4 millimeters and advanced 3 millimeters of the left superior rectus, and we injected 5 units of Botox on the inferior rectus. Here is the position of the eye at the end of surgery with a small XT and a small left hypo. And on the first day, he was able to elevate the eye. In primary, he was ortho, and he was okay in down gaze. When Botox started working, we see that there is a limitation of depression of the left eye, but he was ortho and in elevation and in primary position. And 3 months later, he was still ortho in up gaze, in primary position, but a left hypertropia on far down gaze position. This patient never complained of torsional diplopia, and on fundus, there was no torsion. So this was a capricious injury. Imagine this size of iron entering between the eyeball and the globe and the lid. So there was no injury to those structures. Lucky guy. And my questions to the panel: would you have done something different, considering that the superior oblique is missing? Would you have thought performing a myectomy of the inferior oblique? And how do you explain that the patient did not complain of torsional diplopia? So to take home message, of course, this is not the patient, the picture, but repair a post-traumatic eye orbit injury may represent a challenging procedure. Structures affected may include the globe, muscles, nerves, and bones. And this type of injury can potentially interfere with vision, damage extraocular muscles, and the patient complains of diplopia with limitation of movements. And of course, images are extremely useful. Important to have experienced colleagues helping on surgery, and I thank my 2 colleagues that were with me from 11 a.m. to 5 p.m. Surgery started at 3 p.m. Before that, we examined the patient. We had some administrative things to do, and then we ended at 4:30. And this happened on December 24th. So they were able to go back home and celebrate Christmas. Thank you.
Thank you so much, Mauro. I think this is a fascinating case. You know, trauma always leads to surprise, but very, very mysterious case that there is no torsion. Even after the surgery, when you resected and advanced the superior rectus, there is no torsion. After the 3rd month, when the botulinum toxin effect gone, no torsion. This is something difficult. Like sometimes when you do a topical anesthesia surgery, I do see when I disinsert the muscle and ask the patient to abduct, you know, they have almost 70% of the abduction very much intact. You know, this is in a live patient what you can see. But I still don't know why this patient does not have a torsion, but beautiful result and beautiful case. So I would like any of the panelists to comment on this particular case. I would start with Dr. Dongsheng to begin with, and then I'll go around other panelists.
Thank you. It's really a beautiful case. Beautifully present and good results. It's a very difficult case, and I think I will ask the same questions, but I truly don't have the answer to why the patient don't feel the diplopia. Anyway, I don't work on this type of the patient a lot. I would like to have the opportunity to other panelists. Thank
Sure.
you.
Daisy, do you have anything in your, I know you don't do surgeries, but can you explain about the torsion in specific in this patient?
Well, first of all, I wanted to ask Mauro, did you really ask it and measured it with really when you look down in the synoptophore, for example, and with a double Maddox rod? Because I think it's also important that patients sometimes, well, I don't hear a lot of torsional complaints, but if you measure it, you find torsion, but they don't often always complain about it. So did you really measure it in all the positions in up, primary and down gaze?
No, I didn't measure. I didn't have the chance for doing that, but I just asked the patient. And I always tell my residents, my fellows, don't ask if they are seeing double, if they are having torsion. Let them
If they don't
ask you.
complain, don't ask it.
Yeah, that's right. That's it.
Yeah.
I wanted, yeah, go ahead, Daisy.
No, but perhaps if you really measure it, that you find some torsion.
But the point, Daisy, if you have a superior oblique palsy, a small palsy, and the patient comes and complains of torsion, if he missed the superior oblique muscle, it's totally
you should have
absent.
a lot of torsion. Of course,
Sure.
Yeah, thank you. I just wanted David H and David G to comment very briefly. David, in India, when you add G in front of your name, that means with respect. So David G and David H.
David, I'll jump in first if it's okay. Just briefly, this is fascinating to me, and we've all seen these. It's sort of if you've seen one trauma, you've seen one trauma, because you don't know exactly what you're going to find tomorrow. It's astonishing that nothing else happened to that eye. We had a fellow years ago who's now just an absolute spectacular pediatric ophthalmologist, Faye Cruz, who used to say our plan was to explore and figure it out on the table. And I think that's what you have to do some of these times, that you're stuck with that. And I want to join with you in, we never talk a happy patient out of a good result. So if they're happy, I don't care what the numbers on the page say, I'm happy.
David, Dr. Hunter?
I added my middle initial G to my...
Okay, one more David G. Yeah.
I'm with Daisy on this. Like, yes, patient's happy, but it would be interesting to know what's the anatomic torsion. What is there an A or a V pattern? What happened now? So the superior oblique is an intortor. We presumably lost the whole thing. Though I would have been curious about intraoperative exaggerated traction testing to see, is the superior oblique completely not palpable, or are there still some fibers of superior oblique attached? And then the other thing is the superior rectus is an intortor, and we strengthen the superior rectus, so that will counteract. That's like 7 millimeters, I think, on the superior rectus, a piece taken out. So that's gonna intort the eye some to balance some of the loss of torsion from losing all or part of the superior oblique.
Thank you. I think we have run out of time. Both Mauro and Yair can comment still. Aditi, I would like for you to share the screen. Yeah. Mauro and then Yair.
No, I was just going to say that I thought about the resection of the superior rectus that could help on the torsion also.
Okay.
I wanted to talk about the inferior oblique. You said what to do with the inferior oblique, maybe to do a myectomy. Don't do a myectomy, because the inferior oblique can save you in cases where the superior oblique is gone, because this is actually, I presented that in Sao Paulo, if you remember. You can take the inferior oblique and do a nasal transposition, and here it will intort the eye and also help in moving the eye downwards if the superior oblique is gone. So inferior oblique is very important. Don't touch it if you don't need to.
Thank you. Aditi, go ahead.
I hope you can see my slides.
Yes.
Thank you. Good morning, good evening, one and all. Thank you, WSPOS for the opportunity, and I also thank Dr. Ramesh Kekunnaya for the case, which is beautifully managed. So this case actually demonstrates how powerful and sometimes unforgiving our extraocular muscle vector forces can be. So let's begin. Yes, here is a 19-year-old male who came with complaint of outward deviation of left eye, which is actually increased since 4 years. His vision, however, good in both eyes, but vectogram showed left eye suppression. On digging down deep into history, we got these photographs, which is around 3 to 5 years of age, and this all photograph shows that there is a small amount of esotropia with left head turn, for which actually he underwent this surgery, left eye Jensen's procedure and MR recession elsewhere. After that, actually, he has noticed that his eye, instead of going inside, was going outside. So basically, he had developed consecutive exotropia post this surgery, and his records again showed that for this, he underwent again a second surgery, which was left eye medial rectus advancement. So with this, we thought of left eye diagnosis as left eye Duan retraction syndrome type 1, which is now converted to type 3, probably because of MR recession. And now he was sitting in front of us with large consecutive exotropia and with this -6 adduction limitation in left eye. So the important question now was how to tackle this vector forces of extraocular muscles, which because of previous surgeries. So we took him to the operation table. First step first, we did FDT, which was very, very tight for lateral rectus. Superior rectus and lateral rectus transposition suture was intact, but inferiorly it is formed a dense scarring. And medial rectus was sitting around 9 millimeter from the limbus even after advancement surgery. So the surgery we performed were, first of all, we released this superior transposition suture. We advanced the medial rectus around 3.5 millimeters. So we kept it around 5.5 millimeter from the limbus, and we recessed this tight LR. Post-operative day 1, he was doing well, but 8 months later, he again came back with a large exotropia. His adduction limitation was improved, but he also had abduction limitation this time. So what was the option now? Since we have already released the superior suture, we thought of going ahead and explore the inferior part now. And we saw that the lateral rectus and inferior rectus has formed a broad insertion here, and there was an inclusion cyst sitting over it. So we removed this cyst first. We did inferior fiber tenotomy, and LR we recessed further to 7 millimeter. Again, on post-operative day 1, he was doing well, but then soon he came back with large amount of exotropia. So this was now very frustrating. We really wanted something definitive, and we again took him to the operation table. We did FTD. FDT was still very tight for lateral rectus. LR was sitting almost 13 millimeter from the limbus, and MR was at 5.5 millimeter where we had kept it earlier. So this time we performed lateral rectus periosteal fixation in left eye. He was doing well again on post-operative day 1, and this effect was stable even 8 months later. That was last visit, and he was doing well with a small amount of adduction and abduction limitation. So this is the slide just to summarize the timeline of our case and a story of recurrent large exotropia post consecutive every corrective effort until it became stable to almost 20 prism diopter of exotropia post periosteal fixation. So he was happy now at the end, but still was left with small amount of horizontal cross diplopia. Hence, we took here help of our orthoptics colleagues, And he was relieved with diplopia with 5 prism diopter of basin prisms in front of both eyes. So we prescribed these prisms. So this was actually his and our journey combined to conquer the vector forces, which had many ups and downs. And to his perspective, he was still left with small amount of restriction of fields, but he was very happy. He was able to play games, he was able to drive, and he was happy. So, but actually this case taught me a few lessons which I actually wanted to share with you all. Previously, a small angle of esotropia had converted to large angle of exotropia, probably because of this Jensen's procedure. So my first learning from this case was to avoid transposition surgeries for small deviations in DRS. Even after 2 advancement surgeries, for one elsewhere and one with us, he continued to have large exotropia. So probably advancement surgery alone may not be effective to reverse the effect of transposition surgeries. He underwent multiple procedures, but periosteal fixation finally gave a stable result. So this teaches us that despite previous transposition surgery and multiple recession surgeries, periosteal fixation still gives good results. In small and cosmetically acceptable deviation after multiple surgeries, if you still have small amount of diplopia, take a help of your orthopedic colleague and can try prism classes. He is actually fighter, underwent multiple intervention to come out of acceptable results, but for which he had to undergo nearly 4 surgeries to correct just 1 transposition surgery. Hence, my final pearl is do not play with vector forces unnecessarily. Reversal of transposition is really a difficult task. Thank you.
Wow. Thank you for that incredible case and great outcome. I love the warning, do not play with vector forces. You may get burned. So thank you for that. Claudia, I have a lot of thoughts about this, but the transposition for small Duane's and a Jensen procedure in Argentina, Claudia, is that what you would do, or would you approach it differently to start?
The case is absolutely fantastic. Congratulations for the result. Of course, I think, as you, that the first surgeon was very exaggerated with the surgery, because the isotropia was very little to the procedure. I would prefer only touch, only do a little bit of recess of medial rectus in this little isotropia at the beginning. But then you have to solve all of these different vectors than was manipulated in exaggerated decision, I think. But we have to be very cautious with doing syndrome. We know that the misinnervation, the anomalous innervation between lateral rectus and medial rectus could produce this kind of disasters if we don't take these points of view at the beginning. So I think you solved all of the problems of the patient, and he is happy, and we are happy with the result of your procedures. But we have to take in mind that the Duane syndrome is very, very challenging patient. So we have to be cautious with the indication of surgery, especially when we decided to do the transposition. We have to select carefully the patient with the complete examination when the awake patient and with the patient is under anesthesia, especially with force induction test under anesthesia. This is the way we can measure the anomalous innervation between lateral rectus and medial rectus.
Yining, in Canada, do you do the Jensen procedure? I generally don't like it, in large part because I don't want to ever have to go back on it. And I was worried about an Ishida, for example, because it's like half a Jensen. And I just wondering what your thoughts are and if you have any pearls for us because they're out there. What do we do when we find a patient like this?
Yeah, similar to Claudia, I would have done a medial rectus recession. I don't do the Jensen if I'm doing a transposition for a sixth nerve palsy. I would do like a Hummelsheim, but I don't typically do transpositions for Duane syndrome. I can't speak for all of Canada.
David Hunter, the other David G. You've talked about maybe only moving one muscle sometimes. I saw you shake your head. Do you use the Jensen procedure?
God, no.
I assume for this very
when you go
reason.
back, because I've gone back on Jensen's and all I find is just scar all the way along. I mean, I'm not sure what your experience was with this patient, but you've got superior, you've got lateral, it's all split. And then it's just thin muscle that's nothing, and you can barely even find the muscle. So I wonder if that was part of the problem. As someone who plays with vector forces a lot, sometimes I will, in a case where it is a small deviation, sometimes I have patients who really want to get like a little bit of abduction. So I will do a just superior rectus transposition. Yeah, to your question, I've had a lot of success with that. And I won't touch the medial in those cases if it's small. I only do the transposition. And that by itself usually doesn't, has not been problematic. But I wouldn't do both in a case like this where it's just a small angle necessarily. I don't know, I have more to say, but.
Dongshen in China, do you approach this any differently? You're muted.
You're muted.
Yeah, I hear. So I just have a question. Why, you have the 20 prism diopter left, not operated on, just use glasses? Do you hear my question?
Yes, Dr. Aditi or Ramesh, Dr. Ramesh.
I think, this is the case, typically this is almost done elsewhere, almost 24 years ago. Somewhere in a medical college, one of the professors wanted to improve the abduction. Typically in Duane's, many people say, I can improve the abduction. They don't even think about the primary position. Because in Duane syndrome, generally, the esotropia is out of proportion to the abduction limitation. They will have -4, or it won't even go beyond the midline, but their deviation can be as small as 8 prism diopters, or they can be ortho. So this professor wanted to improve the abduction. That's what they told the family. So Dongsheng, after doing, as Dr. Hunter said, it's a mess when you go there. We don't know what is happening. We can see 2-3 non-absorbable sutures, conjunctiva is stuck everywhere. It almost takes 1.5 hours to get into all of those muscles and clean up and tidy up and come back. It takes so much time. So your question is 20 prism diopters residual. Can you do something? Yes, definitely we can do something. But that child is so happy now. I can do a right lateral rectus recession. It's kind of yoke. It'll really help that person. But he is really happy and he's out of the world at this point of time. He's really enjoying. So I had a conversation with him, but he is happy. Daisy can tell us that these small prisms can really help these patients and avoid surgeries if possible. It's always a patient's choice.
Thank you.
I think that goes back to don't talk a happy patient out of a good result. And we are at time, right, Ramesh? This is the time we have to
It's on time.
Yes, right on time, exactly. So thank you all from all over the world, from almost every continent represented. Your expertise is greatly appreciated. This was a textbook, and all of us know that every case we could have spoken for 75 minutes each. So thank you for your understanding about our time limitations. To our audience, thank you so much. Wherever you are around the world, enjoy the rest of your day or get a good night's sleep. Thank you all again for listening, and to our experts, we very, very dearly appreciate you spending your time with us. Thank you.
Thank you.
Thank you all.
Bye-bye.
A big namaste from India.
Bye-bye.
Bye. Thank you.
Bye-bye.
Thank you. Thank you.
Bye.
Thank you.